right to the left side, and so lead 3 will have a deep S
Doesn't like
wave. So on baseline in the ECG, if you see an RS complex in lead 3, then you are thinking that patient may have a atrial fascicular pathway with antiochromic ESP as a possibility.
Dr.
Some
DK
common
Singh.
misconceptions. We think
Yes, sir.
that people who have VT
Tinker?
will be hemodynamically unstable, but that is not true. You can have patients walking into your clinic with palpitations. I have had patients coming on a motorcycle, getting off, coming to the clinic with a broad complex tachycardia, and it's actually VT. So some VTs can be hemodynamically stable. The other misconception is that
आप
you
लोग कहाँ से
don't
हो?
see VA
हर
conduction.
समय छोटे ना
Actually, VA conduction can be seen in 30 to 50% of patients with VT. So you can have one-to-one VA conduction even in VT. So how to understand, how to look at an ECG which is broad complex and say, is it SVT with aberrancy? It's important to look at some principles rather than trying to by heart the things. So if you look at the principles, the first and most important principle is to look at the shape of the ECG. So if the shape is like a typical bundle branch block, which is like a typical RBBB or typical LBBB, then it has to be SVT with aberrancy. Because only in typical bundle branch block will come only if you have a SVT. If it is a VT, it won't have that typical appearance of RBBB or typical appearance of LBBB. The only exception is a VT coming from the conduction system, like a fascicular VT or a bundle branch reentrant VT. These VTs will come from the conduction system, so they will have appearance as if one bundle is conducting and the other bundle is not conducting. But otherwise, any VT will be coming from the ventricular muscle, and that will not have the exact appearance of a RBBB or a LBBB. So for example, if you look at this ECG, you can see clearly that it has a RSR pattern in V6, a small r deepest pattern in V1. Now this is very classic of left bundle branch block. Only in left bundle branch block ECG you will see this appearance. So straight away when you see an ECG like this, you know it is most likely SVT with aberrancy. It is not going to be VT. So like I said, in SVT with aberrancy, if you're looking at V6, you will have a RSR pattern. Whereas if instead of RSR pattern, you're having a Q wave, then it is likely to be a VT. It will not be SVT, because SVT with aberrancy will look just like typical bundle branch block where you have RSR in V6. But if you have a Q wave in V6, then it is not going to be SVT, it has to be VT. Same way, if you look at lead V1, you will have a RS complex in SVT. So just look at this ECG here, small r, deep S. This is how it will look in V1 if it's a SVT with aberrancy. But if it's a VT, then instead of this downslope being smooth, this downslope will become jagged. So there'll be slurring in this downslope. And when you see slurring in this downslope, it means it is likely to be a VT because the muscles are conducting slowly across. It's not conducting uniformly. So there's some slow activation which gives that appearance. Now we move to the second principle to differentiate between SVT and VT, and it is to do with the activation of the myocardium. So in SVT with aberrancy, the impulse is coming from the SA node to the AV node, and then it's coming down the bundle branches. So let us say the two bundle branches, one is conducting normally, one is conducting slowly. The one which is conducting normally will take the impulse to that part of the ventricle very fast. So the initial activation of the ventricular muscle will be rapid because it is happening through the conduction system. So when it is rapid, you look at the slope of the depolarization of the QRS, you will find the slope is very rapid up and rapid down. So you look at the initial activation of QRS, it will be rapid if it is activating through the conduction system. On the contrary, if you're looking at VT, you will have activation starting from one part of the ventricular muscle and then traveling cell by cell across the ventricular musculature. So the initial activation will not be rapid. The latter activation may be rapid because eventually it will reach some conduction fiber, and through that fiber it will activate all the other fibers and all the other cells. But till it reaches that conduction fiber, it is traveling cell by cell by cell slowly. So the rate of depolarization will be slow. So if you look at the QRS, instead of going rapidly up, it will go slowly up. So when it goes slowly up, the initial part of QRS, then you are thinking it must be VT. It is unlikely to be SVT. So again here, when you have SVT with aberrancy, you have a block in one bundle, other bundle is conducting. So this part of the ventricle will get activated very, very rapidly. Whereas if you are having a VT or an antidromic AVRT, it has to travel cell by cell through the muscle till it activates the entire ventricle. Thereby, the slope of the initial QRS will be slow. So the same principle, people have interpreted in a different way or expressed it differently. They have said you look at the slope of the initial 40 milliseconds and the latter 40 milliseconds. Compare the initial depolarization of QRS and the latter depolarization of QRS. If the initial depolarization is rapid compared to the latter part, it is SVT with aberrancy. If initial is slow, then it is VT. So look at this ECG. In this ECG, if you're looking at the leads, you can see that in most of the leads, the initial activation is slow. It is going slowly up. Later, it is coming fast down. Same way, look at lead 1, slowly up, fast down. Lead 3, slowly down, fast up. So the initial part, the slope is slow. The latter part, the slope is rapid. You may look at some of the leads and say it is looking like, say, in lead V3 that the initial is rapid. But then you must look at the onset of the QRS, and you see the onset of QRS by comparing with the other leads. You know the onset of the QRS is much earlier. So the onset of the QRS is actually over here with the small part, not this big rapid part. And the initial onset is gradual. So if you compare across leads to see where the actual onset of the QRS is, and then look at the initial part and compare to the final part, you'll find that the initial part is slow, the latter part is rapid. When initial part is slow, it means it has to be VT. Principle number 3. Now, when we look at leads, we generally look at them as friends. So you have lead 2, 3 AVF, which are friends. They are near each other. All of them are looking at the inferior surface of the heart. You look at V1, V2, V3, V4, they are all friends. They all look at the anterior surface of the heart. You look at V5, V6, 1 AVL, they are friends. They look at the lateral surface of the heart. But there is one lead who has no friends, and that lead is AVR. AVR is an orphan lead. That lead is sitting over here and he has no friends. He is looking at the cavity of the ventricle. From there, he is looking at the cavity of the ventricle. And depolarization is always the enemy of AVR. It travels away from AVR. Whether it is atrial depolarization or ventricular depolarization, it does not go towards AVR. It goes away. So atrial depolarization this direction. So your P wave will be negative in AVR. Ventricular depolarization also goes in this direction. So your QRS will also be negative in AVR. So current is always traveling in the heart away from lead AVR. So AVR will always record negative P waves, negative QRS. Supposing AVR is recording positive QRS, it means current is traveling towards AVR. There is no reason for current to travel towards AVR because your AV node is taking the current down the His bundle, it's taking it down the bundle branches, current is traveling away from AVR. If current is traveling towards AVR, the heart should have done an absolute somersault. You know, instead of being like this, it should have come like this. Only then current can travel towards AVR. Now, the heart is not going to do a somersault in the chest. So if current is traveling towards AVR, it means the current is being produced from near the apex of the heart, and from there it is traveling towards AVR. And if current is being produced from the apex of the heart, it has to be a VT. So if an ECG is showing prominent R waves in AVR, AVR is recording positive complexes, then it has to be VT. In other words, if it is north-west axis, which is saying the same thing in a different language. Instead of saying positive R wave in AVR, I'm saying northwest axis. If you have northwest axis on ECG, it means it has to be VT. So you see a broad complex tachycardia with a northwest axis, it has to be VT.
Dr. Jacob, try to finish it also.
Sure, sir.
Yeah, already late.
So then going on to principle number 4, when you look at the initial rapid activation and the lateral activation, they will not be identical. So if you're having a SVT with aberrancy, like a left bundle branch block or a right bundle branch block, the activation of the septum, activation of free wall is happening in different directions. So because of that, if you look at leads V1 to V6, they will never be either all positive or all negative. Some will be positive, some will be negative, because current is traveling in different directions when you have SVT with aberrancy. But when you have VT and the focus is right in the front of the heart muscle, then all the current will travel away from V1 to V6. So you'll have negative in V1 to V6. Whereas if the focus is right at the back of the heart, all the current will travel towards V1 to V6. So you can have either positive concordance or negative concordance. If any of that happens, it has to be VT. And the last principle is AV dissociation or VA block, which involves capture beats and fusion beats. And this is something we know from our MBBS days. So if you have AV dissociation, then you know you're dealing with VT. So here again is an ECG of a patient where you have one-to-one VA conduction of a broad complex tachycardia, but you will agree with me that the initial depolarization is slow, lateral depolarization is rapid. So that is suggestive of VT. Same patient, we continue to watch the patient in the emergency, and you see now AV dissociation has appeared. So you're having P waves coming in the middle at regular intervals. So there is AV dissociation. So this is VT. So these criteria have been given to us by Hein Wellens and Philip Kummel, who are the famous people who gave up this criteria. These are some of the classic criteria, which is the same thing expressed in a different way. So with that, I will end my talk. So essentially, when you're differentiating a broad complex tachycardia, we are differentiating between VT and SVT with aberrancy. It's good to look at the principles. Among the principles that we discussed, we said you look at the initial activation and the lateral activation. The initial activation will be slow, lateral will be rapid if it's a VT. We spoke about how if you have positive concordance, it is VT. If you have negative concordance, it's VT, whereas SVT with aberrancy will not have either of them. Then we also spoke about capture beats and fusion beats and AV dissociation. So these are some of the principles that we need to follow when you differentiate SVT with aberrancy from VT. Thank you very much.
Thank you, Dr. Jacob, for nice presentation. We have understood quite a lot about VT. And now I invite Dr. Amarnath Upadhyay from Dehradun. Pardon? Oh, Dr. Narasimhan, he is presenting online about conduction system pacing, and we will.
Thank you very much, Chairperson. Ladies and gentlemen, at the outset, I would like to thank you all for the kind invitation. I was talking about the conduction system pacing. This is the RAO view. The right atrium is exposed and the septal leaflet of the tricuspid valve. This is an important anatomical concept for you to realize, because in contrast to regular pacemaker where the lead goes all the way here, I don't want it to get it entangled in the septal leaflet, or the septal leaflet should not be jailed to produce more TR. We'll tell you how to go about this. So this is what you see, the real life RAO view. What you see in the red is the right bundle, and what you see in purple is the left bundle. But they are the right bundle is anterior close to the sternum and the left bundle is posterior. And you have to predict where, if you penetrate the septum, how are you going to capture this purple area? That is what is the most important thing in determining where to screw the lead. So you come from the subclavian vein, cross the tricuspid valve, make sure up to this, I'm going to predominantly talk about one leadless, that is your lumenless lead 3830 of the Medtronic. That is the predominant lead world over that is used for conduction system pacing. If you are a beginner, I would strongly recommend to stick to that lead. The complications are the least. When you begin, don't try with a stylet. All of us can do it with stylet driven, but the complications are slightly higher. So you cross the tricuspid valve and then just expose the tip of the screw. If it is exposed and if it comes into contact with the muscle, you will see a current of injury. The unipolar current of injury will be seen. But if it's touching the tricuspid septal leaflet, you won't see the current of injury and you can't pace through this area at a low output. So that indicates that you're not against the septal leaflet if you see a current of injury and you see pace at a low output. If you start fixating the lead on the septum and start screwing in posteriorly, you should be able to capture the left bundle. Now, this is the fluoroscopic landmark. So we are in EP practice, we mark the His bundle. But if you're not used to recording the His bundle, it doesn't matter. You just put a RV pacing lead where it turns smooth. The apex of this curve roughly marks where the His bundle is. And your target for screwing in is about 1 to 2 centimeter below on an imaginary line that is drawn between this area and the RV apex in RAO view. So you draw a line from the apex of this RV pacing lead to the RV apex, and somewhere 1 to 2 centimeter below, you'll be able to capture the left bundle. Now, how do you know which is the right place to screw in? The simplest thing is the ECG. Learn to recognize the ECG pattern. If you're in the mid-septum, you will see when you pace from the right ventricular aspect of the septum, you are not started to screw in. You want to know where to screw in. So you just expose the tip of the electrode, don't come out fully, just the screw alone comes out. Pace in unipolar mode. When you pace in unipolar mode, you will see an R in lead 2 and a negative complex RS or a Q in lead 3. Secondly, it will be upright in AVL and inverted in AVR. Thirdly, you will see a W pattern in V1, that is the notch in the V1 electrode. So this is the lead that I was talking about, and this is the sheath. This sheath is a little flimsy for you to operate. It is not very well braided. So don't torque this lead without something sitting inside the lead. When you try to torque the lead and cross the tricuspid valve without either a stylet, without a lead inside, it tends to kink itself. So when you cross the tricuspid valve, what I would suggest is keep the lead inside the sheath. Don't come out. You just keep it somewhere here, and then that will give you a sufficient body to cross the tricuspid valve. As you come from above, from the subclavian, tricuspid is anterior structure. So you rotate it clockwise gently, you will cross the tricuspid valve. Once you cross the tricuspid valve, you counterclockwise the sheath. Now, it is important to know these measurements because roughly the septum is about 10 millimeter in thickness. The helix is about 1.8 millimeter. And if you see a marker of this anode, this is radiographically visible. The distance between this screw and the tip of the anode is about 9 millimeter. So when this portion reaches the RV aspect of the septum, that means you have crossed 10 millimeter into the interventricular septum. Most important for you people to decide is the target. Again, I would like to emphasize, it may look too redundant, but don't kink the lead as you cross in. Second thing is, identify the thickness of the septum. Some of the patients, if you're starting to do this, avoid patients with septal scar. Old anteroseptal infarction, HCM patients are not good candidates for conduction system pacing. So visualize the septum on echo before taking up. If you think it is scarred, don't start. It can be done, but I would suggest not to start with those cases. So this is what we do. And you start operating in RAO. Locate the distal His bundle from a catheter in the groin, or you can use a RV pacing lead where it kind of makes a bend. The apex of the U will be roughly the position, and you start targeting about 1 to 2 centimeter inferior on a line, imaginary line between this and the RV apex. And then once you start pace map this area, suppose, let me give you this example. This is the ideal location. Instead of this, if you place the lead here, 2-3 AVF, everything will be upright. If you place it here, 2-3 AVF, everything will be inverted. Whereas at this sweet spot, 2 will be slightly upward and 3 will be slightly equiphasic or downward. That tells you anatomically you are at the right side. And once you start, the sheath will be covering till here. Only the tip of the screw is exposed. In this current in unipolar mode, you look for current of injury. That tells you you are abutting on the septum. And then come into LAO, you will find that this is facing perpendicular to the septum. Roughly, we operate in about 30-degree LAO. And your assistant should be better to have initially an additional assistant who will be able to make this sheath coaxial or perpendicular to the septum. It should not be facing down like this or too much upward like this. Make it perpendicular to the septum. And then if you are, this has a side port, you can inject a little contrast and see whether you are layering the septum if you want, and then start screwing in. I would like to emphasize, it may look too basic and redundant. Please do not have a blood-stained glove. For you to transmit the torque on this lead, the glove has to be dry. So if you are operating on if your glove is already messed up with a lot of blood, remove and change the glove, or have 2 gloves and take out the first glove and operate in a dry glove. That makes a huge difference in terms of transmitting the torque. So you start pacing, and V1, it will look like this. V1 will have a notch at the downstroke or slightly on the upstroke of this. That tells you you are at the right side to start screwing it in, and then move over to LAO view. In the LAO view, what you do is, unlike his bundle where we do slow turning, rapidly deliver 3 or 4 turns. This is important because the most important site of resistance is the RV endocardium. So to penetrate, you need to have, just like you move the RCA guide, you use both the hands and transmit the torque rapidly for about 4 to 5 turns. You will be able to overcome the resistance of the RV endocardial aspect and penetrate the septum. Once you are in the muscle, it goes in fairly easily. Now, and this is important as you do this, get a good septal position with the sheath. And how do you assess the location? Again, pace map and get the discordance between AVR and AVL, 2 being upright, 3 being inverted, and V1 showing a notch at the nadir of the V1 electrode. And get a baseline impedance, unipolar impedance, before you start screwing in the lead. Please remember, you are exposed to the blood in the RV endocardium. So the impedance, suppose it's about 540 milliseconds. As the tip loses the contact of the blood and goes inside the muscle, you'll find a change in impedance that tells you you're screwing in very well. So this is the lead coming out of C315 sheath, and you connect it to a unipolar mode. The cathode is connected to the tip. Anode is connected to either a metal object or the skin, and ask the Medtronic or whichever the rep is to connect it to the atrial channel, because you'll be able to have different filter settings and you'll see the electrograms much better. And this will be the rough. You can see you're manipulating the sheath there, and clockwise, counterclockwise rotation, and you try to go past the tricuspid valve. And once you know you are in the right position, you come back to LAO view and slowly start screwing in. So how do you know you're moving inside the lead? Number one is fluoroscopic, but more importantly, as I told you here, for example, lead 2 is upright, less of upright position in lead 3, and there is a notch in V1. This notch, as you go deeper and deeper in the septum, will start migrating here, here, here. And finally, the notch will come towards the end of V1, and it will become an QR or RSR dash pattern, which tells you are very close to the left bundle. If you are very particular, you can record from there a left bundle branch potential, a sharp potential here, followed by a ventricular electrogram. that tells you you're sitting and recording the left bundle potential. This is once you reach this side, you should not be aggressive about screwing in the lead because the risk of perforation is high. And I want you to avoid that. How to do it? We'll go over this. Number one is to watch the impedance and current of injury. Current of injury is the ST elevation that you see on the unipolar lead. That should not suddenly become isoelectric, or you shouldn't lose it. So how do you know you are capturing the left bundle? Is if you are capturing the left bundle, V5, V6 activation will occur very early. So from the pacing spike to the peak of the R wave will occur within about 70 to 80 milliseconds. That tells you you have captured the left bundle. As you are proceeding close to this area, left bundle is a very, very irritable structure. As you close to that area, you will start having what are known as fixation beats. That these are ectopic beats due to irritation of the left bundle. These fixation beats, once it occurs, please do not aggressively start screwing in because you can quickly land in the cavity of the LV, causing septal perforation. Now, when we are close to the left bundle, at a very high output and a very low output, say at 8 millivolts, 8 milliamperes as well as at 2 milliamperes, the pacing spike to the peak of the R wave in V5, V6 will remain identical. If there is a difference, suppose you are capturing at a very high output, the left ventricular activation time is 60 milliseconds or 70 milliseconds, but at a low output, it becomes prolonged. That means you are close to left bundle, but not close enough. At that stage, you need to clockwise rotate very gently, half to one turn, and recheck what is going on. And that is what is, if you're very aggressive, and in especially elderly women, see, for example, here, as they screw in, it just goes like butter, and you're in the cavity of the LV. As you screw in, very easily it just goes in, and you have entered the LV cavity. How do you recognize this? You memorize this pattern into your mind. This is the current of injury on a unipolar mode. This should always be there. This tells you are not entered the cavity. If this ST elevation is lost and it becomes flat, or it becomes downward, the Q wave, instead of an R wave, it becomes a QS pattern, it tells you are inside the cavity. You should immediately abandon this, come back. Do not try to pull it back and leave in a better position because it will invariably dislocate. So you need to take out the lead. Invariably at the tip, you will see a little bit of muscle tissue. You just clean it up with a small 26 gauge insulin needle and flush it well so that there is no muscle tissue. And then you get a slightly different site and start screwing it in. Do not make the mistake of just pulling it back and leaving it at a better site. So there are 3 signs that you have entered the cavity. Number one is if you lose the ST elevation, that is sudden drop in amplitude of current of injury. And if I told you, you start with an impedance of 540 or 600 millisecond, suddenly it drops below 400 ohms. It tells you are in the blood pool and you have reached the cavity. And if you see this type of a pattern of a QS or an RS pattern, that tells you again you have reached septal perforation has occurred. You should pull out the lead, nothing wrong, clean up the tip and choose a different site. I'll show you an example. The last patient, what you saw on fluoroscopy, this is the ST elevation that you see as you are screwing it in. A little aggressive screwing in, you find that the ST elevation is lost and it has become a QS complex. And that is where you know that you have entered. And suddenly the impedance from 560 ohms has dropped to 380 ohms, loss of current of injury. And there is an RS pattern suddenly telling you that you have reached the cavity. You should not persist. So in the brief time that is allocated, I would like to tell that it's a useful technique. It's not very difficult, provided you take some simple precautions. Number one, do not kink the sheath. Number two, choose your patients well. To begin with, don't choose patients with septal scar. And ensure a good sheath position. That is, you enter the tricuspid valve. The moment you enter the tricuspid valve, counterclockwise the sheath, so that instead of facing towards the apex, it will face towards the septum. Counterclockwise rotate. There is a white hub that you see. Just use the hub to counterclockwise turn the sheath and then advance the lead. And monitor the baseline impedance, current of injury, and pace map the septum to get a good morphology of the V1 showing a notch, upright R wave in lead 2 and negative R wave, QS complex or small r, big S in lead 3, and look for ideal position. Minimize complications by carefully looking for fixation beats and gently screwing in as you reach the septum, left side septum. To penetrate the right side of septum, you need rapid screwing. But as you reach the left side interventricular septum, you need to be very gentle. One by one, you screw in. These are the tips and tricks. If there are any questions, we'll be happy to take in. Thank you so much for the patient listening.
Thank you, sir, for the enlightening talk. Due to lack of time, we will go ahead to the next speaker. And if there are any questions.
Sure. John is there. Of course, he can address. Thank you. Thank you so much.
So the next speaker is Dr. Amarnath Upadhyay. He is Associate Professor of Cardiology in Government Doon Medical College, Dehradun. And I would like to invite him to take the stage to shed light on his topic, conduction system pacing in a 7-year-old child.
So, respected chairperson and all the invited guests, a very good morning to you all. I must congratulate the organizer for organizing such a wonderful conference, and I wish this conference a great success. So after such an elaborate talk by Narasimhan sir, it became quite easier for me to present my case, and I will not take even 6 minutes for this presentation. So I'm going to present a case of a 7-year-old female child who underwent surgery for ventricular septal defect closure a month back. And at the presentation, parents narrated that of late they have noticed that the child is becoming irritable, lethargic, and listless. On anthropometric measurements, her weight to height was less than 2 standard deviation, which was suggestive of the fact that the VSD for which she got operated was hemodynamically significant. So this was the ECG at presentation, which is showing AV dissociation due to complete heart block, a rate of 40-45 and corrected QT of roughly 400 milliseconds. So it all started with a few clinical questions. Like the first question was site of pacing, where to pace. Because we don't have long-term data on pediatric conduction system pacing. A few case series, maximum follow-up 2.5 years. But we do have data on long-term RV apical pacing. And we know that even the sequential RV apical pacing, there is some deterioration of LV function in long run, and the patients was needing pacemaker for the lifetime. So we decided to go for conduction system pacing. Right, so this is the applied anatomy of conduction system pertinent to conduction system pacing. The penetrating portion of his bundle penetrates the membranous portion of atrioventricular septum, and at the crest of muscular septum, it divides into right and left branches. So the patient had a perimembranous VSD, and there was a patch at the basal septum. This was the echo recorded, you can see mildly dilated LLV and a patch at the basal septum. So the second problem was thin septum. As Narasimhan sir told, the select secure lead which we use for left bundle area pacing, the distance between tip to ring electrode is 1.8 plus 9, 10.8 millimeter. In our case, the thickness of the septum was 8 to 9 millimeter. So it was clear that the two things were clear. We had two problems actually, a patch at the basal septum and thin septum. Fortunately, both the problems had similar solution. So we decided that if we are not able to catch the main left bundle, we will go slightly inferiorly to catch the posterior fascicle. In that case, we have to go oblique in the septum. And if we are going oblique in the septum, even in the thin septum, we can have better lead stability and we will be able to do bipolar pacing. I mean, we can abut the septum by the ring electrode. So we started with doing with the venogram. We don't routinely do venogram with before pacemaker, but this was just to assess the size of the vein, whether it can accommodate those seats or not. And then we did extrathoracic subclavian vein puncture. So at the we used echo to guide our sheath position. We position the sheath because the patch is not visible fluoroscopically. So we position the sheath slightly apical from the patch and we try to go slightly 4 o'clock. I know that the precise control is not easy, but our idea is to go slightly inferiorly or 4 o'clock in LAO. I'm really sorry for the quality of the truss, but we don't have EP system, dedicated EP system in our lab. We use our TMT monitor for conduction system pacing. So the parameters which are described at the site are AVR-AVL discordance, lead 2 more positive than lead 3, and a notch in W. We had a notch in W, but the crest, the notch was not in the middle of the crest of the W. Anyway, we decided to go there. So we were very slow while screwing in the septum. And after every 2-3 turn, I was measuring unipolar impedance and I was looking for the width of QRS. And it is needless to say that with every turn of a screw, my heart was coming to my mouth because I'm really scared about the perforation of the septum. So at the place where impedance dropped by 100 to 150 ohms, QRS became narrow. We measured LVAT, which was coming 80 millisecond even at the low threshold. So we decided to stop here. And then we put atrial lead and these large loops, we were not unmindful of these large loops. They were kept deliberately just to ensure that even after the pubertal growth spot, this lead should not become straightened. And this is the ECG, which is recorded after pacemaker implantation. A narrow complex QRS, 100 millisecond, good height of R wave, and inferior and superior axis. So in all likelihood, we caught the posterior fascicle. Thank you.
Yes, thank you for that very short and good demonstration. And it was a very good result in the end. And glad to see the alpha loops, whether intentional or unintentional, it's always a good idea to keep it in a growing child to keep, for the pubertal growth. So all in all, a good result.
Thanks.
V6 showing QS. Is it LB pacing then?
Sir, sorry, sir.
The lead V6 after the pacing done was showing QS.
That you may get, sir, it is not typical RBBB. We got this left anterior hemiblock kind of thing because we got the posterior fascicle. So we are activating the posterior fascicle earlier than the anterior fascicle. So it's a kind of left anterior hemiblock.
Maybe.
Any comment? Very good result. I want John sir to comment on this. Any?
Yeah, so I think it is a good result, like Dr. Vipin was saying. And like he explained, it was not left bundle pacing. It was gone into the left posterior fascicle. So that's why the QRS is not as ideal as we will expect to get. So we still don't have enough evidence to consistently do it in all children. But this is early work that's being done in this field. And we hope that in future, we will know exactly how many turns to give so that we don't cause septal perforation and try to be more specific towards getting left bundle pacing versus left posterior fascicle pacing. And at this juncture, we are not even sure whether left bundle pacing is superior to left posterior fascicle pacing. Because as long as we get it into the conduction system, we should be able to activate the entire ventricle fast enough. So right now we are aiming for distinction, but actually even scoring 95% should be okay. That's what we feel, but we don't know. Time will tell us. Studies are ongoing.
I have got a comment.
Got one question from Dr. Narsingham. I don't know whether he's there.
Yes, please.
Then Dr. Jacob can answer.
Yeah,
What is the ideal width of the interventricular septum for which this should be done? I mean, beyond which we should not try.
So the normal interventricular septum thickness should be anywhere between 10 to 12 millimeters. And we should not do this in patients who have had sarcoidosis, as well as when you had anteroseptal MI, when the basal septum is scarred and fibrosed, then getting the conduction system becomes difficult.
Sir, I have got a question, sir, here. To all the panelists, to all the speakers, in fact. So my question is, should we do one MRI before the septal pacing or left bundle branch pacing, or the echocardiography is enough? This is part one of the question. And second is, the case that was presented just now, whether we should call it the left bundle branch pacing, or should we call it fascicular pacing? Because the result we are having is that of the fascicular pacing. And third is my comment that left bundle branch pacing is really used when we started in our life with the pacing techniques. We never had the idea, but now we have started it. But the recommendation wise, it should be known to everyone. Recommendation wise, the bundle branch pacing is not yet put in the class 1 recommendation. But there are so many causes why it is so, but it is class 2 recommendation. So with these comments, I want to have your opinion.
Shall I answer, sir? So MRI is currently not recommended before conduction system pacing. You are particularly concerned about a scar when you are doing conduction system pacing for cardiac resynchronization. In those patients, when you are doing optimize CRT, when you need a RV lead which is at the septum, in those cases you may go for MRI, but it is not recommended routinely before conduction system pacing. What we do, we measure the septal thickness, and because the lead tip and ring electrode is 10.8 millimeter, your septal thickness should be more than that.
One more question. What is the incidence of fibrosis distal to the pacing site? Does fibrosis always involve proximal to the pacing? His bundle is fibrosed, but distal branches, LVB, left bundle, distal portion is also involved.
Sir,
what is your opinion? What is
very
incidence?
Very interesting question, sir. The tissue around his bundle and left bundle is quite different. Collagen and proteoglycan around his bundle, and that was one of the reasons the delayed rise of threshold, because those tissues are not good conductor of electricity. Tissue around left bundle are myocyte, so they are very good conductor of electricity, and that is why the pacing or left bundle area pacing, the delayed rise of threshold has not been reported that much as it was recorded with the his bundle pacing.
Thank you, Dr. Upadhyay. It has been a nice presentation.
Thank you.
Thank you very much.
Thank you.
And we are short of time, so we are closing this session. And I now ask him to go. What I was asking is, we don't take this.
So next session is a structural session, and we have Dr. B.C. Srinivas for that session. May I like to invite the chairperson for that session, Dr. B.C. Srinivas, sir. Dr. Nigam Prakash Narayan, sir. Dr. R.D. Yadav, sir. Dr. Shraddha Ranjan. Dr. Praveen Jha. And Dr. Mukesh Tiwari. I would like chairpersons to start the session with Dr. B.C. Srinivas, sir.
Thank you very much for inviting us for this chairing this session. I invite the first speaker, Dr. B.C. Srinivas from Bangalore, who will be talking about BMV, the tips and tricks with reference to difficult septal puncture. Yeah, Dr. B.C. Srinivas is a distinguished senior consultant cardiologist in India. He has boasted 30 plus years of invaluable experience in the field of cardiology. He played a vital role in founding the Department of Cardiac Sciences at Sri Jayadev Institute of Cardiology, Bangalore. As an accomplished investigator, he made significant contributions to the FAMI trial in '96. Dr. Srinivas's expertise and dedication have earned him immense respect in the medical community. He is lifetime member of Fellow of Society of Cardiovascular Angiography and Interventions and Fellow of American College of Cardiology. He has lots of honors and awards, published author in reputable medical journals in national and international significance. He contributed expertise to the field of cardiology through a chapter of venous interventions in the book Cardiac Catheterization and Imaging, and his area of expertise is TAVI and TAVI. Thank you very much, sir. Dr. Srinivas, the floor is yours.
This is the respected chairpersons and dear delegates. At the outset, I would like to thank the organizers for inviting, and thank you for the invite. So, thank you. So the most important step in BMV is executing IAS puncture safely. A well-executed IAS puncture is the actually backbone of a successful BMV. IAS puncture is done in multiple views by different operators. Some of them do in AP view, some of them do in RAVO, and few will do in LAVO, and some of them do in lateral. What I would suggest is, whatever view you are comfortable with, understanding of the IAS anatomy, you continue to do in the same, because once you achieve certain level of expertise, you just continue in that because it will be safer. Because so the most important, you actually saw this, Dr. Narasimhan showed it, the perspective of the P. So the thing is, the IAS superiorly is bounded by the superior vena cava, inferiorly by the inferior vena cava, and posteriorly by the pericardium behind the RA and LA, and anteriorly there is the septal leaflet of the tricuspid valve. In fact, if you look at the evolution of the IAS puncture, it started in 1952, initially in 1959, Dr. Ross and Brownwald, and subsequently Sinclair actually standardized these procedures for catheterization of the left atrium and the left heart. So they used actually these actually the anatomical markings, and subsequently Dr. Inouye used the angiography method to develop landmarks. The initial landmark was top of the tricuspid valve. That corresponds to the non-coronary cusp of the aortic root, which also lands there. And it's also the region of is bundle. So you have EP people putting the is bundle and then doing the IAS puncture without keeping a pigtail, whereas we keep a pigtail in the non-coronary sinus and then take it as a marker. And angiographically, you can use the same anterior leaflet of the upper border of the tricuspid valve, that is the septal leaflet of tricuspid valve, as a marker. The same marker, different people use in different ways. So the idea is to puncture in the fossa valis. In fact, more than 1/3 of the people, even in adults, the fossa is patent. So the imaginary midline, which actually divides interatrial septum into two halves, the anterior and the posterior, that is the line on which we intend to do the septal puncture. And that is typically done at the level of the middle of the mitral annulus, that plane which intersects with a middle line, which divides IAS into two halves. That is what is the recommended point. So the same point in frontal view, in lateral view, and RAV view I have shown, but I'll just take you through the case examples. Actually, no, I don't normally use pigtail for doing IS puncture and doing BMV. I just take it, and based on the fluoroscopic and the vertebral landmarks itself and feel of the IAS, I just go through and then do my BMVs. So there are difficult scenarios where you need to be careful. These are some of the scenarios. I'll take you through the case examples. So you look at this. This is a markedly dilated left atrium. The entire, you can see that it's a huge cardiomegaly. In fact, you look at the left atrium is virtually compressing the right atrium, and then you can see the whole assembly is being pushed to the right. In such scenario, the traditional landmarks will not hold good. You'll have to stain the septum. So that's what I'm doing here. I have stained the septum and then puncture. And this is also the case where, once you enter giant LA, you have the traditional method of crossing the mitral valve tough. So you do over the wire. So you get into the left ventricle, then dilate the interatrial septum well, and then you do over the wire technique. So you need to increase the curvature of the puncture of the needle, and maybe you have to go a bit low. When you're low, it's better to go mid or posterior rather than anterior, because anterior crossing the mitral valve will be very difficult, and try to do over the wire technique. So what about left atrial appendage LA clots? So LA clots, you don't want to come in contact with the clot by the PTMC hardware. That is the main criteria. So what are the situations where you can do? So the clots which are restricted to left atrial appendage are only the roof. These are two subsets wherein you can still do BMV, so that, taking care to see that the PTMC hardwares do not come in contact with the clot, so that you don't embolize. The clots which are, which should not be done are the ones where, of course, the IAS clot or the roof clot extending beyond half of the left atrium. So this is a typical example. This is a IAS clot where you should not do BMV. So where you can do is the one which is restricted to left atrial appendage. So how you do that? You puncture a bit low, maybe a mid or posterior, and then get into the left ventricle and do all the exchanges over the wire, like dilator, balloon, and then even withdrawal. You will be careful, and over the wire only withdraw. So this is an example. You see here, I'm injecting, there is a LA appendage clot there. You puncture a bit low and then cross, and then get the spring coil guide wire in the LV and do your BMV and come out quickly over the wire. So this is an example of a roof clot wherein we have done a BMV successfully. So case selection is the, but all LA clots, we typically anticoagulate them for 8 to 12 weeks. Make sure that, LA clot disappears, and then only do. In some cases where it is still restricted LA appendage despite anticoagulation, then we go ahead and do at the end of that 8 to 12 weeks. There are, see, this was a case of Lutem Bashers with severe MS. You can see here, there was severe submitral stenosis. So contrary to the popular belief that it's easier to cross into the mitral valve, it is very difficult in the setting of Lutem Bashers, because you go to the defense, try to cross, it is difficult. So in this case, it was more difficult because there was submitral fusion. So I had to puncture the IAS below the ASD to anchor the balloon and then try to cross. But even then I was not able to cross. So in this case, I had to actually, take the wire down into the descending thoracic aorta and then snare it. And after snaring, retrogradely, I had to do a balloon dilatation using a peripheral balloon of the submitral. And then I was able to go with the Accura balloon and then do the procedure. So dextrocardia is another scenario where the septal puncture will be tough. So here, to ease the procedure, you go from the left femoral vein approach instead of the right femoral, number one. Number two, invert the image chain on the, the fluoroscopy itself. And then instead of using the PA RAO, you go for PA LAO, that is the pseudo RAO. So, or you take the help of, you do a pulmonary artery angiogram in the liver phase when you have the LA pictures. Use that for your, for example, this was a situs inversus. In fact, this boy also had May Turner. And then you can see that the contrast is not flowing because they had punctured the right femoral limb when I entered the cath lab. So then I had to take over and then do the procedure from the left femoral vein. Here I have done you see this pulmonary artery angiogram, you can see in the liver phase, the LA is very well opacified. Here, the 1.5 centimeter below the pigtail in the non-coronary sinus, and then looking into the liver. So in this is the going through the LAO. This is the NFOS view, actually. You are seeing the IAS like this, NFOS. So that is in the routine cases, RAO view. Where you can see the IAS NFOS. So we did the procedure. The patient also had severe bicuspid aortic with a gradient of 100 millimeters of mercury. So what we did, we passed a wire and crossed the aortic valve and then snared it out and came with a Ty-Shak balloon and dilated, got a good relief for both the mitral as well as the aortic valve here. Then another scenario, you have absent IVC or IVC interrupted, that then your IAS puncture from the jugular calls for attention. So here what we do, here also we keep the pigtail, but do our, from the jugular approach, but we take a Broken-Brough needle or a Henry's needle, which are shorter. The adult Broken-Brough needle is 71 centimeters, whereas the pediatric is 56. Henry is 36 centimeters. So you take a shorter needle and you can see that we start our the site of puncture just at the level of pigtail and then try to go in. So or a centimeter above, so that this is so then you can easily cross across the mitral vein and do your BMV. So typically we use either pediatric or Henry's needle, and then we sometimes use the PA angio LA opacification, the liver phase, to direct our, of course, we keep the pigtail in NCC and reduce the curvature of the, the puncture needle, the Broken-Brough puncture needle. So director indicator should be towards 7 to 8 o'clock instead of, 4 to 5 o'clock. So another interesting case, this is, you can see this is again with CMV done and then re-stenosed. This patient also had IVC interruption. Here we have used the PA injection, and then we have done in the LAO view, you can see here, keeping the catheter in the pigtail a centimeter above, and then doing the BMV successfully. You can see that we got a bicommissural split in this case. This was an extremely rare case. Only one case I have seen like this. The entire upper body venous drainage was into the coronary sinus. You can see that the coronary sinus is aneurysmal because of that, and the patient had severe MS. So we had to, in this case, we had to, there was no SVC to go into. So we had to keep the Broken-Brough needle system in the RA and then puncture. So what we did here, so this is again, I used a pigtail to mark and then stained the IAS and then did the eye puncture. Once I did the eye puncture, it is tough to cross the mitral valve. So this is a typical case wherein you have to go again with a, over the wire technique to cross. So if you change your puncture site, then the routine method of crossing doesn't help. You'll have to go for a the wire technique to cross the mitral valve. So we could successfully do. When you perform complex BMVs, watch for complications. The most complication is cardiac, inverted RA or the RA stitch, RA LA. So this was one of my associates had taken, unfortunately, a kyphoscoliosis case with severe MS, and he was shouting for help. Then I entered the lab. This was the scene. The patient has arrested. The patient has kyphoscoliosis. This was the picture. So what we do in this scenario is first relieve the cardiac tamponade, get into pericardium, put a pigtail, start draining, and do autoperfusion. venous sheath in the left femoral vein. So once you stabilize the hemodynamics, scenario you can see here. See what happens in mitral stenosis is when the LA enlarges, the AS is pushed down and you can see this horizontal it is. So this is what happens in mitral stenosis. So you should be aware of this. So here virtually you are, in this case, we punctured a bit low and it was anterior. When it is low and anterior, it's extremely tough in this anatomy to cross the valve. Try to go over the wire technique. Even over the wire technique, what happened was the balloon was getting pushed back. So what we did, there was a reverse loop technique. You go across the floor of mitral valve, the left atrium, and then enter. So when you go along the right lateral border of LA and then floor, the balloon gets anchored and you can do your balloon meditation well across. So this is what we did ultimately in that case. So again, so there's another case wherein you can see here the operator was going through. If you are out of the right side of the vertebral border, very likely you will cause a stitch because you are going through the RA, entering the pericardium, re-entering the LA. So if it is only needle, many times, if you take it out, it seals off. But if you take the septum, in this case, they had already taken the balloon in, patient in massive, cardiac tamponade. So what we did, I left that to stent that defect there itself. I took a different puncture in the femoral vein below the existing femoral vein. A more, anteromedial puncture and then got into the LA, finished this. And now what to do for the stitch was the question. So I looked at the votis, all 4 votis were occupied. So what we did, we decided, we will use devices to stitch this. So what we did, there was a stitch between the 2 atrium through the pericardium, which was which responsible for tamponade. So we took a Cook sheath, initially tried a 6 mm Amplatz septal occluder. The right side of the disc actually opened in the pericardium. So it had stented only the left atrial perforation. So the pericardial effusion continued despite the closure of the left atrial. So what we did, we took another device. So another device between the pericardium and the RA. So we had 2 AST devices. So closing both from LA to pericardium and one from pericardium to right atrium. So could seal both the perforations. So this is what, and the tamponade resolved. And then we did the follow-up almost 13 years now. She is doing well even now. So when in rheumatic what happens is there is dilatation of the left atrium and sometimes right atrium also. So if you go for a high puncture, there is a high likely chance that you can go through the free wall of RA. Or if you go towards the right, as I showed you, outside the vertebral border, if you're puncturing, then you will cause a stitch. And if you are sometimes inadvertently, you can go through the free wall of, especially in high punctures. So roof of LA. So you be aware of all these points. So to conclude, it is safe and effective across wide spectrum BMV. Echo assistance actually facilitates BMV very well. So you need to have the echo machine in the cath lab when you do BMV. Transeptal puncture does have a learning curve, but it can be safely and easily executed once you are aware of the landmarks well. But well-executed transeptal puncture is in an appropriate site is of paramount importance, not only for safety, but also efficacy of whatever procedure you are doing. And TSP is very essential for many other procedures today because mitral clip, mitral valve replacement, and the left atrial appendage closure. Then you have so many EP studies and the ablations you can do. And then if there are prosthetic aortic valve in that scenario, if you want to enter into LV, this is the best way. You puncture the intra-atrial septum and then enter LV from the LA. So These are clearly many indications. Extreme peripheral vascular disease where there are no act, then IAS is the act. You can still, access the aorta through intra-atrial septum. So knowing, and then IAS puncture is challenging in technically difficult cases. In such scenarios, you may have to do a PA angio, use the liver phase opacification of the left atrium, and then do IAS puncture. So knowing these different methods of puncturing and crossing the mitral valve is essential in technically challenging cases. What I have seen is over-the-wire technique is very useful technique in technically challenging cases. Of course, in each, based on individual case, you adapt the different technology. So BMV in complex anatomy should be ideally done by experienced operators. Thank you.
Excellent talk, really. All variants of abnormalities you can do the BMV. It's a very rewarding procedure. Still, I love it. And it's poor man's disease. So that is the problem.
Yeah.
Everyone cannot.
It is actually coming down, Dr. Yadav. Now it is actually the BMV's number even in public hospitals is coming down. That's a good sign. The
standard of living has improved.
Has improved. Absolutely. We used to do 15, 20 per day. Now it has come down to 2 to 4 per day. So that is a good indicator of the rheumatic fever and rheumatic heart disease coming down in India.
So all the questions will be later on.
Yeah.
We'll
Thank you.
call next speaker. Dr. Sushant Kumar Pathak, CD presentation, TAVR.
Yeah. Sorry to request you, who's sitting behind, please do not talk, cross talk, do not make sound. Otherwise, the speakers will are getting disturbed. I request with folded hand, please maintain silence. Thank you.
Yeah. Good morning, all the seniors and colleagues. Starting with the topic that TAVR in bicuspid aortic valve and with a low coronary height. A 70-year-old male patient admitted with the symptoms of heart failure. ECG was done, which shows LVH. Echo was done, which shows severe aortic stenosis with severe LV systolic dysfunction. Initially, the creatinine was 2.1 as the patient was admitted with the symptoms of heart failure in shock stage. After stabilization, as the renal function improved, we took the patient for coronary angiogram. We saw double vessel disease with significant stenosis in the mid part of the left anti-descending artery. So the plan was either for CABG with SAVR or TAVR with low contrast PCI in heart team mid. Patient party opted for the TAVR plus PCI to LAD when we proceed accordingly with cardiac CT was done. This is the cardiac CT showing the various measurements like aortic annulus perimeter is 24.7 millimeter, area is around 24.4 millimeter. LVOT is more or less similar, not very dilated, that is one advantage. Second is the RC height, it was inadequate, 30.2 millimeter from the cusp, the annulus size, annulus length. And the problem was that the LCA, which was around 9.6, it was slightly closer to the high risk as the patient has a risk of abrupt left main occlusion during implantation. So we were aware of these things. Next thing was proceed with the femoral artery measurement. It shows it is around 9 millimeter in the right and it is more than 10. So we opted for the right approach because as we have a graft of 10 millimeter in our slab. These are the measurements showing how the perimeters were calculated from the cardiac CT. The valve was a bicuspid type 1 aortic valve. Along with the severe calcification, the fusion was between the left and right coronary cusp. LVOT was free of any kind of calcification. Annulus was less than 45 ascending aorta was less than 45 millimeter. The only challenging was the calcification, bicuspid valve, and the left coronary height, which was less than recommended safe landing zone for valve. So we were aware of that we may land up in the abrupt left main occlusion. Accordingly, these are the various measurement and different angles given by the CT for the procedures. This was the angiogram showing significant stenosis in the mid part of the LAD. We stent it with DES. And then after 1 day we start with the TAVR as the patient was under conscious sedation. Access was right femoral artery and left femoral artery and vein. We kept the left femoral artery because after plastic procedure, his right radial artery occlusion was there. So we were not able to trace it. So we do with the right femoral artery and left femoral artery and vein. Right femoral artery for all the procedures of the TAVR. So gradual femoral access were dilated with the 5 French micropunction, then sequentially with the 7 French and 9 French, and ultimately the 14 French Python sheath was deployed. Temporary pacemaker was done to the left femoral vein was deployed, and the left femoral artery was kept for the check angiogram and coronary access in case of any kind of coronary occlusion. This is the aortogram in the 2 cusp view and the 3 cusp view according to CT angles. In 3 cusp view, this is the curved wire is showing the another cusp. Aortic valve was crossed with AL1 with straight tip termo, and sequentially it was changed with double exchange length and safari wire. Extra support was parked subsequently, and then the valve was pre-dilated with mammoth balloon of 20 into 40 millimeters. This aortogram actually was done to check whether the dilated balloon was done to assess how our valve will behave after valve expansion. In view of left coronary height was 9.6 and as well as bicuspid aortic valve. So the expansion it was a bicuspid aortic valve and heavily calcified. The chance of proper expansion or some kind of residual paravalvular leak are high. So we checked this whether we need prior wiring of the left coronary artery with placing a guide liner before planting the aortic valve. But however, this shows that it's quite safe. We can deal it later on also. No need of unnecessary prior wiring of the valve, wiring of the LAD artery, and keeping a stent inside, because maximum of the studies have shown that in doing this stage, any kind of dissections can occur, and ultimately unnecessary stent deployment has done. So the my valve of size 24.5 mm was deployed. This is actually it was kept at 70% inside the aortic range and 30% by 30% below the aortic annulus. These things are actually by the light and white, dark and light bands which are present on the valve after crimping. And deployments completely, so during deployment also we give an injectogram and shows that the coronary occlusion, coronary artery was safe. This is the final stage, and we also trace the pressure testing from there was no significant gradient across the valve. Ultimately, the most important piece is the site access closer, because after doing all of this, if any kind of damage to the large femoral artery with the 14 French sheath, the whole procedure can be gone in vain. So the final closure was done with as it is Python sheath used from right femoral artery. So we use 1 angioseal and 1 ProGlide. It's good to closure of 14 French access, and 1 angioseal was used for the left femoral artery. And definitely prior to closing the right, we check and DSA so that no leakage was seen from the right femoral artery, and the things was okay. Echo after 2 weeks, LVF improved from 35% to 50%, and the gradient across the valve was around 5 millimeter mark. No any kind of perivalvular leak. Thank you.
Thank you, Dr. Sushant, for such a nice presentation. Next topic is RSOV closure. I would like to welcome Dr. Anup Singh for presentation.
Good morning, and thank you to BICC team. Case summary: 21-year-old male admitted with complaining of dyspnea with feature of congestive cardiac failure, like ascites and bilateral pedal edema. He had history of acute onset of dyspnea after lifting a heavy weight 4 months back before admission. The basic blood investigation was normal except a deranged LFT and ECG having incomplete RBB with RV stent pattern. Echo show LVF ejection fraction 40%, global hypokinesia with RSOV between right coronary cusp to RVOT, size approx 7.2 mm with moderate MR, TR and PH. RA, RV and MPA was dilated. This is the chest X-ray at the time of admission, which show right side pure effusion with cardiomegaly. This is echocardiography. The left one show there is a communication between right coronary cusp to RVOT, and the right one show the classical wind shock appearance with RARV dilated along with MP is also dilated. This is before the procedure. LV is approx 40 to 42%. First of all, I took a LV angiogram to rule out any BSD or any significant AR. And after that, aortic root angiography done in different view, left lateral, LAO view, along with RAO view. And this is RAO view, the defect was clearly visible, and further the size was measured approx 7.2 mm. And with the help of GR catheter, the thermo exchange length wire is placed into the RBOT. And by the venous access, we took a thermo wire, and with this help, I placed the MPA catheter into RBOT for the extrusion of the exchange length wire to form a AV loop. Then by hit and trial method, with the help of a snare within the MPA catheter, the exchange length wire from the arterial side is externalized to form a AV loop. Now the whole delivery system, along with catheter and dilator, whole delivery system was railed over the thermo with slides showing difficulty during passage through the defect. And other end was firmly held of the arterial side. Here, one point is to be remember that never remove this GR catheter during the passage of this delivery system across the defect, because bare thermo catheter, bare thermo wire can damage the aortic structure at the aortic arch and ascending aorta, and it also support the delivery system to cross over the defect. And the whole then dilator along with wire was removed, and the delivery sheath was here placed, and the device was taken as approx 10 to 12 PDA device occluder was taken, and it is first distal end, then proximal end was open, and after repeated pulling, and the That slide is not moving. Right one. Before that slide. Before. Yes, yes. And I took a pigtail short aortic rotogram with the pigtail catheter to rule out any compression of the RCA or any leakage from the device. And then device is released in RO view. This is the device in different view, LO, RO, as well as AP in left lateral. And just after releasing the device, the LV function gradually decreased approximately 20 to 25% because of increased afterload. And the color and the echo shows this is the device without any residual shunt. And after 1 week, patient was discharged with this chest X-ray and came with follow-up without any symptom. So take-home message is treat as early as possible to this type of shunt lesion. Always take LV and aortic root angiogram for the exclusion of any VSD or severe AR. Take more than one angiographic view for better procedural outcome. Never remove JR or MPA catheter from the ascending or arch of aorta during the snaring for AV loop formation and also during placement of delivery system from venous route over exchange length thermowire. Otherwise, it can damage the aortic structure by seizing effect. Because of increased afterload, patient had developed severe LV dysfunction after the device placement. So use diuretics post-op immediately. Thank you.
Thank you, Dr. Anup. Very nice case. I think we'll move on to the next case and we'll take questions afterward. So next case will be, there'll be some pediatric intervention cases delivered by Dr. Shiv Kamal.
Good morning, everyone on the dais, of the dais, and thankful to organizers who gave me opportunity to present this case. I am Dr. Shiv Kamal, third year resident of Department of Cardiology, IGMS Patna. During the OPD, 8-year-old female came with the complaints of fever, dyspnea, and failure of thrive. And during the cardiovascular examination, her apex beat was found at left fifth intercostal space at mid-clavicular line, and S1, S2 was present, and continuous murmur at the left external border were present. And respiratory examination was normal and treated as LRTI. After that, we have evaluated her on showing that she is having situs solitus levocardia, and left main coronary artery is of about 6 mm dilated, which gives moderately large coronary cameral fistula to RA, with RA opening of size 5 mm and coronary opening of 6 mm of size, left to right flow with pressure gradient of 10 mm of VG. And RCA was small and dilated. LA and LV was dilated. She is having intact LA interatrial septum and interventricular septum at good bioventricular contractility, and TR was mild, having ASP of 40 mm of VG, and she is having no ASD, VSD, PDA, coarctation of aorta, and LSVC. And after that, we have planned for device closure. For that, we have put 5-way femoral sheath placed in the right femoral artery and vein, and 5 French JR catheter with exchange length entered through the femoral artery. After that, catheter is taken into the aorta aortic root under fluoroscopy guidance, and left main coronary hooked with a Judkins right catheter, and then into the left coronary artery to fistula into the RA, and then into the right ventricle followed by pulmonary artery. Then catheter is taken in with another with another 5 French Judkins catheter with thermo wire entered through the femoral vein and taken integrally into up to the IVC, and then RA to RV, and finally into the pulmonary artery. Thermo wire is removed and a snare catheter with delivery system is taken into over the JR catheter placed in the pulmonary artery through the femoral vein sheath, and then exchange length thermo wire already placed in the pulmonary vein through the femoral artery, a snare, and exits through the femoral vein, sir. After that sheath is placed into the femoral vein and was removed, and 6 French Moulin sheath was taken over thermo wire through the femoral vein, and the sheath placed in the narrowest portion of the coronary fistula. After that, we have created AV loop. Now the JR catheter placed at the opposite end of the fistula and was removed. Then muscular VHD occluder of size 10 mm by 7 mm with the help of delivery system taken over the Moulin sheath, and it was placed at the narrowest portion of the coronary fistula. We can see the device over here. Then all hardware placed through the both routes were taken out, and residual flow across the device was not present. And no complication occurs at the procedure, and the patient was hemodynamically stable. And post-operative loading dose of aspirin of 10 milligram per kg per body weight was given, and maintenance dose of 5 milligram per kg once daily started for 6 months. And anticoagulation of warfarin 3 milligram was started, and planned for repeat angiogram 6 months after to check the residual flow, sir. The take-home message was for when we encounter a patient having coronary artery fistula, if he or she is having symptomatic of medium to large coronary artery fistula, and if she is having ischemia in the feeder artery territory, arrhythmia thought to be related to the coronary artery fistula, endarteritis, vessel rupture, cardiac chamber enlargement, and ventricular dysfunction, the patient should undergo device closure. Thank you, sir.
Actually, you have used the PDA device, because PDA device is cheaper as compared to PDA.
Yes.
Because you need to know the umbrella should be on that's what they are. PDA device.
Yes.
Nice case, actually. Well done. But do we need to anticoagulate? I think aspirin should be alone. Actually, there is no need to anticoagulate. And then, no, but here we want,
It's quite high.
no, here we want the tract to get clotted.
Yeah, combo.
Yeah, so I don't, only aspirin is enough.
Okay,
No, that is our practice. That's our practice. So no, I think probably because it is left main, they are, worried about the thrombus extending it to, but I think that is not the case because the coronary arteries is high flow. I think aspirin should alone should be fine. I think taking away warfarin is the, that's what we do for all these cases, actually.
Once again, I am thank you to our dynamic HOD, respected Ravi Vishnu sir, for giving me opportunity to present here. Thank you, sir.
Thank you. Very well done. All the cases were
RSO
actually.
case was done well, very good case. Because RVOT, rupture of right coronary cusp into RVOT, alignment of device is difficult. And instead of seat, we go seat inside the descending thoracic aorta. Because if any air while pushing the device, any air goes, it goes down rather than in the cranial or coronary. And then take out open the LA disc, distal umbrella, and then pull out and engage into the RVOT. Because orientation is different. And when you release, keep the seat more closer to the device. Because when you release the needle, cable needle, it can perforate the RV. That's why you try to keep the delivery sheet as close to needle, and then de-screw. That's all. Because you pull out immediately, but you see it short back entirely. Otherwise, no comment. All are done well.
I think we come to the end of this session. We'll go to the next session.
Now we'll start next session, session 3. For that, we invite Dr. B.C. Srinivas sir, Dr. Sanjeev sir, AIMS, Dr. Ashish Kumar Jha, Heart Hospital, Dr. J.P. Karn, Darbhanga, and Dr. Rajiv Krishna was, and Dr. Dilip Kumar Singh, IGSC Patna. We'll request to start the session as early as possible.
A very interesting session of peripheral interventions. Our first speaker is Dr. B.C. Srinivas sir from Bangalore, and he is going to speak on venous interventional procedure. So please, sir.
Dr. B.C. Srinivas has probably the most highest number of venous interventions in India, and he's expert in that and has a huge case series.
Thank you, Ashish. Thank you for the kind. I especially thank you for the invitation. Okay, actually, this by default we started doing this procedure because these patients in late 90s and early part of the 2000s, what we saw, no one was offering any therapy. So that is how the thought process came into us, how we should approach these cases. So what we have gained experience now in the setting of IVC, hepatic vein obstruction, SVC syndromes, central venous occlusions, DVT with or without pulmonary embolism, and pelvic venous outflow obstructions. So the vein is unfortunately has not received attention. So because no one else was doing, I started doing. Now, fortunately, the vascular and the interventional radiologists have started. We have trained them. Now they are actually doing these procedures regularly. I'll just take you through examples. So typically what I see when we have the IVC syndromes, we have one picture of ascites, which is very common with hepatic venous obstructions. Or you have prominent veins like this over the abdomen and then leg swelling. This is more common with IVC obstruction. When you have a combination of both ascites and the prominent veins, it is invariably both hepatic veins and IVC are occluded. You can see from a distance and diagnose. So some of the patients, actually the first case, I'll just show you this case. He was being kept in MD exams 5 times. He had been kept in MD exam as cirrhosis of liver. Accidentally, he came to me. I asked him, he said, I am being treated for cirrhosis. Just show your abdomen. I saw that abdomen. No, this cannot be IVC. It has to be IVC and hepatic vein obstruction. So here, all the hepatic veins were occluded. And you can see that circle thing there. That is actually the accessory. Entire hepatic venous outflow is through accessory hepatic vein is draining into the IVC below the level of web. So this is a web. When there is a web, we do an injection above and below in AP lateral, see the web thickness, see whether there is any contrast penetration. Contrast penetration is very encouraging that there is a track which needs to be probed. So how to do it? I start with a multi and a thermostrate. Multi won't stay there because it wobbles, there is no support. Then I take a Mullins, it gives better support. Then you probe it. You can go through the track like this sometimes. So most of the times you just need to keep probing and then you will be successful. Once it is done, we typically we use the Acura or the Inouye balloon, because the reason is when the compliance characters are such that when you dilate this balloon, the distal portion of the balloon dilates. Then you pull it against the web. Then you continue to dilate, the proximal dilates, and the web is caught in between. And the least compliant, the toughest portion of the balloon breaks the web. And then when the web is broken, you have a result like this on table. So when you have a result like this, I just leave them alone. And you can see that on table, there is complete, the gradient goes away and the veins disappeared. So obstruction is relieved. Some of them come back with restenosis. He came back with restenosis 6 months later. So what we did was stent it. So I reserve the stent for restenosis or for long occlusions. So this is an example. This lady actually had 2 loss of pregnancies. Very interesting. So the reason for loss of pregnancy is pelvic venous congestion because of IVC obstruction. So here the therapy was stenting, but she conceived and had 2 successful pregnancies later. That was very rewarding for that lady. So now some of them have total long segment occlusions like this. For example, this, they had, in fact, before referring to me, they had tried in 2 different centers. Almost 15 years he was living with this IVC obstruction. Then he was referred. So he was having a long segment obstruction. Here, see, the probing will not help. You need to have some sort of sharp recanalization. This is, I use so that is actually the Mullins, but now I have, after trying with the softer wires, now hard end of the thermo, that goes through. Once it goes through, because there will be some soft thrombi in the middle, which you can, if you can engage, then you can go through. Once you go through, then you daughter it and then do the same, steps, balloon dilate them, and you need to stent them. And these stents will remain patent for a long time. This is my observation. For example, this is a 40 millimeter long IVC occlusion. You see here. So always I go close to the occlusion and inject so that, get the anatomy well, understand the, see here, lower portion you look at, there are multiple collaterals. To engage into the occlusion, which is the key for recanalization in CTOs, is, difficult thing here. But you look at this nubbin, this is encouraging. So in this case, straight away I go from the internal jugular vein, and I have taken a broken needle with the, Mullins assembly and partially maneuvered into the top half of the occlusion, then exchange it for a softer wire, and then I snare out. Once I cross, I snare out from the femoral and do the procedure from the femoral vein. So you dilate them and then serially, and then do balloon dilatation serially, but eventually you'll have to stent them. So this is the kind of results you get, and the IVC syndrome disappears. So they do well. So you need to be very careful. So this is, in fact, this entire length of IVC, whatever you are seeing is collaterals which are draining into the SPC through azygous system. So whatever here you are seeing here, you are not seeing the IVC. Actually, there is I'll show you here. You see a line there, that is the occluded IVC. Whatever else you are seeing is collaterals. So here it took about 4 or 5 hours to, go through and then serial 2 long, stents to entire length of IVC recanalized. But you have to be very careful regarding the clots below the obstruction. Below the obstruction, there can be clots like this, which can be, CT identifies this. When you have a clot with an obstruction above, don't treat the obstruction, treat the clot first. What you do, see, this is the clot there. You give see that if it has cleared, in this case, it was partially cleared. There were some adherent clots. So what we did here, next stage is to stent them. So whatever adherent clot is there, you just stent it. So it gets trapped between the stent and the IVC wall, and then anticoagulate them, it goes away. So you are avoiding the embolism also. Some of them are very hard. At the end of procedure, you may end up like this. If you try to, in the same setting, if you try to, you may have perforation. It will be very painful. So when there is extreme pain that you know that adventitia is, causing pain, you stop and then go back after 2-3, months. It yields very easily. The same thing. In fact, if you look at George Joseph, he does for the aortic the same thing. Takayasu, you leave it, call them back after 4 to 6 weeks or 8 weeks, then you redilate, they open up well. So this we have seen in the IVC side also. As I mentioned earlier, these webs are associated with the hepatic venous obstruction. For example, here, all hepatic veins were occluded. The accessory vein which drains below the level in the lower part of the IVC. So normally hepatic veins drain here, close to the RA-IVC junction, but here all are occluded. Accessory hepatic vein opens up. Remember this. This opens into the lower IVC. So by relieving the IVC web, you may not have treated. If that also has got a web there at the junction between the hepatic vein and the IVC, you need to treat it so that, venous hypertension in the liver goes down, the portal hypertension goes down. So be aware of this. So this, over time, I understood this anatomy and physiology. So here again, the web, you can get into the hepatic vein when there is a web which is non-occlusive like this. There's a critical stenosed web. So this, you can treat it with a stent implantation. So the edema resolves rapidly, but there are situations where they are occluded. If the hepatic vein is occluded, you cannot enter from the IVC side. How do you do it now? So here, percutaneously through hepatic tissue into the hepatic vein you enter. That's what I have done here. So under Doppler guidance, you enter in through the percutaneously through the liver tissue into the hepatic vein proximal to occlusion, and then you go through this occlusion into IVC. This needs sharp recanalization. This I have done through using Chiba needle and then stenting it. Then here I am actually doing it with I think this is a Broken-Brow needle I have used. So to cut through in this case, and then ultimately you need to snare out that wire. You use this percutaneous approach only to get access into hepatic vein to cross, but you snare out the crossed wire from the IVC either through internal jugular or from femoral vein. Do your intervention from the jugular vein or from the femoral vein, but not through the hepatic from percutaneously. This is only for entering, crossing. This you close the track using gel foam or coil so that it doesn't bleed into the peritoneal cavity once you remove the sheath. So these are few case examples, different ways. Hard end of the wire, either Teflon coated or Terumo, or so you can. This I do live demonstration every year to keep the youngsters updated so that they learn and they practice. So different ways of going through the occlusions. So, but you be aware of that they can come back with restenosis. For example, what we have done in the past, hepatic IVC, they can come back with restenosis like this. You need to have a good follow-up. If they come back with restenosis, then you so in this case, again, Broken-Brow with needle had to be used to cut through that, fibrotic occlusion and then redilate them. They do well. So this is a treatable causes of, these are treatable causes of cirrhosis. For example, this is one of the, in fact, 1995 we did first actually. Second time we came back with restenosis, which we treated. And then again, third time he came with re-restenosis at the edge. So we had to bridge between. So entire length of IVC is stented, but they are patent at 30 years, it is patent. Even now he is 81, he is doing well. He is a retired superintendent engineer. He is doing well even today after 31 years. So this was in fact the second case which we did. That time we did not have the, we had the Tagarno and then used to cut and mount to show the people actually. Again here, Broken-Brow needle with Inouye. This came back with restenosis. You can see that fibrocalcific restenosis And initial attempt while doing this case, we had gone through the wall of the IVC and the broken bone needle. That you see here, that had caused a pseudoaneurysm over time. So now we had a web with a pseudoaneurysm. This as a part of Asia Pacific meeting, we did live demonstration. We used a stent that was a narrow neck pseudoaneurysm. So with when I stented this, the narrow neck closed down. We treated not only the web, the pseudoaneurysm also disappeared. So it's a, these are rare cases you may come across, but these are the ways to treat. This is one thing which I am finding very common now, central venous occlusions. So the post-dialysis, I think all of you will see it in future because more and more dialysis patients will come. The central veins get occluded, and then because there is a AV fistula, high flow, then these limb swells and the skins can get excoriated with venous ulcers because of the high venous pressure. So you need to recanalize these cases to maintain the AV fistula and also take care of the venous hypertension-induced skin changes. So example, a left innominate vein stenosis, you cross it. Typically, we just balloon dilate and leave them because it doesn't need stent implantation for such cases. Only if you have long occlusions, then you need stent implantation. Stenosis, short segment occlusion, don't stent. So this is another example of, the balloon dilatation and then a good result, we leave them. See, this is how they come, virtually like an elephant limb. And this is one of the longest occlusions. You can see from the almost is the axillary vein from the beginning of the subclavian till almost the ostium of the innominate vein. An entire length of innominate vein is occluded. So here, in fact, you need to take first attempt we failed. We went back with the second attempt. You can see here the wire loops in the occlusion, and the looped wire knuckles through the the occlusion. So this is one technique which I have found useful. If it knuckles the occlusion and opens up the lumen. So this is one thing which I have seen in venous occlusions. So once you do that, you have the veno-venous loop, and then by snaring out and then do the serial balloon dilatation and then stent them. This is another case which this is a SVC syndrome, but the SVC and bilateral innominate veins are occluded. So in such cases, what we do is try to recanalize at least one. If you can recanalize both, it's good. Here you can see here the wire knuckles, one with the sheath and dilator for support, and then I try to pass the wire loops and knuckles through the occlusion. That I have exteriorized from the left subclavian. Once we serially balloon dilate and open up one limb from the innominate into SVC, and then retry the other side also. Other side I needed the broken bone needle to enter through, and then I could recanalize that also. These are long procedures which needs patience and perseverance. Then two stents into SVC, we have recanalized. The beauty is 18 years, diminished vision, headache, swelling goes away in 24 hours. The thing is, you see it immediately, results. This is again the right innominate and IVC, both in the same patient, CKD on maintenance hemodialysis with fistula failure. Now, so you want to recanalize this, but you have to go through this IVC occlusion. So we treated the IVC occlusion first and then went into this. We had to use sharp recanalization with broken bone needle. And then serially, once we crossed it, then we did that Atlas balloon. I use 14x40 regularly for dilating the innominate veins because the diameter of the innominate veins are quite large. The same balloon I used for the IVC. And then you can see that is the, recanalized with the stent implantation because this was long occlusion. So sometimes you have SPC syndrome due to bilateral innominate vein, then you treat them with, both innominate veins treated with stent implantation. You see this was one of the earliest cases which we treated with SPC syndrome, who was unable to lie down because of the severe edema. Here, we had to intubate, ventilate him because the third space volume started moving into the central circulation, causing pulmonary edema. So 4 days he was ventilated. Every day we removed dialysis through dialysis for 4 liters. at the end of 1 month, he was like this. So these are, again, another case of SPC syndrome. Again, dialysis dependent, SPC is occluded. You don't have to treat both. You need, if you can cross and then treat to one side, you see this one, the edema resolves rapidly. So it's a very rewarding procedure. So in this particular case, left innominate vein, on that day we did not have the atlas. Semi-compliant balloon we used, it caused perforation actually of the vein. So what we did was on site, we used a Ty-Shak balloon, took out the shaft of Ty-Shak balloon, and then mounted it on a bare metal stent, sutured with a Vicryl, and then we treated that, a customized covered stent. Restenosis is an issue. You need to have a diligent follow-up, do a, repetitive dilatations whenever the patient comes back with restenosis. This is one aspect you should be aware. Follow-up program should be strong when you are treating these cases.
Sorry to interrupt, Dr.
Sorry.
Srinivas. We are running short of time.
Yeah,
Please
okay.
wind up.
Okay. I'll go. So the DVT is another, scenario where there are many ways to treat now, thrombolysis plus mechanical devices. But there are some scenarios where you have to stent pelvic venous obstructions. When we identify, you have to stent them. Now, fortunately, we have Inari catheter available for us in India. See, for example, this is an Inari catheter through which you can treat the massive pulmonary embolism. You can see here bilateral. You can retrieve the clots, the pulmonary embolism, and the shock reverts quickly. Chronic venous insufficiency, which are untreated, if you recognize them, you can stent. The ulcers get relieved. Say, for example, this is an 8 years ulcer due to chronic venous insufficiency, wherein you have the IVC and the iliac veins occluded. You identify them, you treat them. You see, like in this case, IVC is reconstructed. The wound heals rapidly in days. Years together, he was having. So to conclude, endovascular therapy has a role in venous diseases. You have multiple venous diseases which you can identify, you can treat them. One is IVC obstruction, another is hepatic vein occlusion, SVC syndrome, central venous occlusions, pelvic venous occlusions in DVT, and chronic venous insufficiency. These are some of the areas where a cardiologist also has a role, I feel. You can, or you train your interventional radiologist, because you are the best to do interventions according to me. So it is less invasive, good efficacy, and midterm patency are very good. Long-term patency, we need multi-center registries. We need to form collaboration and then study them. Thank you. Thank you for the opportunity.
Thank you very much, sir. Though it's a very interesting topic, but we'll take questions later on. The next speaker is Vipin Kumar from Ruben Hospital, Patna, and he will show the cases on carotid artery intervention.
Thank you, sir. Carotid artery lesions are major risk factor for stroke, and interventions are required, either CEA or carotid artery stenting. Slides are not to prevent recurrence of stroke and complications. So also few cases. This is a 70-year-old male. He presented with recurrent CVA and also had exertional angina class 3 with history of seizures. And you can see CT angiogram showed left internal carotid artery 100% occlusion with right common internal carotid artery about 80 to 90% occlusion. So he was surviving on only one carotid artery, which was also 90% occluded. And here you can see the angiogram of left common carotid artery system, which showing left side ICA was completely occluded. And the other side, you are seeing the right common carotid artery angiogram, which showed ICA obstruction about 90%. And his coronary right RCA was occluded, and LAD was also had about 90% lesion. So he was only had LCX was normal only. So first There was a embolic protection device was deployed, Imbosil NAV 7.2 mm in distal ICA, and it was gently dilated after placement of embolic protection device with a 2.5 10 coronary balloon, and then I have deployed this carotid stent system 7 to 10 into 40 millimeter. He had brief brady and syncope, which was treated with injection atropine and IV fluids. And it was gently dilated again with 520 balloon. And this was the result. There was some vasospasm near the embolic protection device system, but flow was there. There was no deficit, neurological deficit, only had brady and little bit pre-syncope. So this was the final result after removal of the this system, and there was slightly vasospasm, and after that this LAD was treated with coronary stent. Also, the another case is a traumatic gunshot injury patient came with a, he had a bullet inside the carotid artery, right carotid, and there's a huge hematoma in the neck. You can see here. And in this also, the whole neck was filled with a hematoma, and carotid was bleeding. Actually, the hematoma was compressing and it was preventing further bleed. So this was treated with a vascular graft, 10 to 57 millimeter high vascular graft balloon, is a balloon expandable stent. And this was occluded. And another case is the Takayasu arthritis. Here you can see the patient had bilateral subclavian occlusion and one carotid occlusion, and he was surviving only on one carotid artery, which was having 80% occlusion. So only one carotid was supplying his both hands through reverse flow and brain. The arch angiogram you can see. So in first stage, we have stented left common carotid artery with 840 self-deploying stent, absolute proof after pre-dilatation. And here we have not used that protection device because it was Takayasu arthritis. And in different stages, I have opened this both subclavian also with both antegrade and retrograde approach. And this was the final result. So whom to intervene? The current recommendation is symptomatic patients with more than 50% and less than 99% stenosis with ipsilateral ischemic symptoms attributable to carotid lesion, and asymptomatic patient with more than 70% and less than 99% stenosis. Carotid revascularization is recommended. And in any individual case, the risk and benefits of revascularization, CEA or carotid artery stenting with medical therapy or medical therapy alone should be considered. And carotid artery stenting is reasonable and less invasive option compared with CEA for preventing stroke in patients with optimal stenting strategies. That is the use of embolic protection device, qualified operators, and appropriately assess procedure risk before carotid artery stenting. So there are certain high risk features for CEA and high risk features for carotid artery stenting, like aortic arch calcification and calcification at the stenotic site or thrombus at the stenotic site. These are the contraindications for carotid artery stenting, whereas CEA high risks are like some clinical risk factors like MI patients or angina, heart failure patients, or surgically inaccessible lesions like at or above C2 level, or ipsilateral neck irradiation. So these are the features which we consider before going to which patient requires CA or CAS. And this is the treatment algorithm for carotid artery disease, which I told earlier, the recommendations. And I've compiled little practical points, things to consider during carotid artery stenting. The first is proper indication before taking procedure, and patient selections is important. aortic arch tortuosity and calcification, lesion tortuosity and calcification, a relative contraindication for carotid artery stenting, and presence of thrombus will be absolute contraindication. Use of embolic protection devices, and before EPD deployment, no pre-dilatation should be used. Only few cases where very tight lesions, where EPD cannot cross across the lesion before dilatation. In those cases, seriously CEA should be considered, or otherwise very gentle dilatation with 2 mm balloon can be done, but there is a risk of embolic stroke. Balloon sizing is important. Initially, we pre-dilate with a smaller balloon, 2.5 or 3 balloon, and very gentle balloon dilatation, just opening of the balloon with a 4 to 6 mm balloon. And final result you accept even with residual stenosis less than 20%. And while doing it, be cautious of sheath in common carotid artery after EPD deployment, because if you can dislodge the sheath in aortic arch, it can pull down along the filter and it can injure the lesion site and can lead to stroke. EPD dwell time must be minimal, and while balloon dilatation, you be ready for bradycardia and hypotension. And in that case, usually we pre-treat with 0.5 ml of atropine and 1 ml we keep ready just after dilatation. Post-stenting, you should check flow, and sometimes if there is a cessation of flow or a unmoving column of blood, then aspiration of that blood should be required. There are sometimes vasospasm which can be treated with NTG, and peri or post-procedural seizures can occur that can be treated with anti-seizure medications. Thank you.
Nice presentation, Dr. Bipin. The sequence of, the intervention when we have a combination of a critical coronary and carotid, especially in that, when the contralateral is occluded, maybe stenting LAD would have been more safer, stenting LAD and getting because the RCA also was occluded, distal LCX also there was a lesion.
Yeah.
That would have probably been more stable for the carotid intervention. That is one aspect. And the Takayasu case was very well done, no doubt about it, because you could get 2 vertebrals plus 1 carotid.
Yes.
I think the other carotid, even if it remains occluded, the patient will remain asymptomatic over time. That's our observation. Thank you.
Thank you, sir.
Thank you, Dr. Bipin, for showing such nice cases. Now we invite Dr. Sisir Misra for a left axillary artery CTO revascularization case.
Slide, please. Slide, please.
A 74 years old diabetic and hypertensive male with history of inferior wall ST elevation MI underwent primary PCI for RCA, which was uneventful. At the night, we got message from the duty doctor regarding non-recordable of BP in ICU. Perplexed, we went there, rushed to find out bounding pulse and normal BP in right upper limb, but absent radial and brachial on the left side. It was revealed by the patient that he had long-term history of pain in left hand and was frequently taking painkillers after multiple consultation from physicians and orthopedic surgeon. He had TVD for he went unstaged PCI of LAD LCX in the same hospital admission. Peripheral angiography was done after 15 days, revealed left axillary artery total occlusion just beyond shoulder joint level with reformation seen just above brachial level with severe slow flow distally. Lesion had abrupt cutoff suggested of thrombus. This location being unusual for atherosclerosis, well collateralized, so must be long-standing CTO. In view of symptomatic disease, he was taken for recanalization of axillary artery. Peripheral CTO management protocol. Taking clues from CTO crossing approach based on plaque cap morphology trial, Saab et al. Developed CTO classification. This classification characterized plaque cap morphology. This underlies differential approach to CTO based on cap morphology. There are 4 types, 1, 2, 3, 4. In type 1, we have concave proximal cap and distal cap. In type 2, we have concave proximal cap. In type 2, we have concave proximal cap and convex distal cap. In type 3, we have both sides convex proximal and concave distal cap. And type 4, we have convex proximal and distal cap. Coming back to our case, this patient had type 1 cap morphology, hence we decided to recanalize the axillary artery and to grade from right femoral approach. Challenges were our relative inexperience in managing peripheral CTO cases. We had to rely on bony markings for final placement of stent. And also lack of sheath longer than 55 centimeter was a drawback. Moreover, we had to be prepared for thrombolysis in case of slow flow or no flow in view of probable thrombotic lesion. Seven French femoral access was taken. JR was taken through 55 centimeter long sheath. Initially tried to cross with J-tip Termo, which did not cross. Then we took Fielder FC coronary wire and took help of roadmap software of Siemens. This was the thing. With some maneuvering, was able to cross the lesion. Not common. Pre-dilatation was done with 1.2 millimeter balloon, 2 millimeter and 2.5 millimeter NC coronary balloon. तो दिख नहीं रहा इसमें। दिखा वीडियो प्ले करना चाहिए इसमें। ये तो प्ले करने वाला नहीं। J-tip Termo was first we dilated with 1.2 millimeter, 2 millimeter and 2.5 millimeter NC coronary balloon. J-tip Termo was now could cross with through the lesion. JR was taken over it and Termo wire was exchanged with 0.35 amplage stiff wire. Then it was dilated with Mustang balloon, which was size 5 into 40 at 4 atmospheres. The lesion was stented and post-dilated with EPIC assistant 6 into 80 millimeter. Post-dilatation with Mustang 6 into 40 mm balloon was done with good result and good distal flow. This was the final result. So I summarize in short. First, we tried with Teremo wire, which did not cross. Then we took the Fielder FC wire and we dilated with, serially we dilated with 1.22 and 2.5 mm balloon. And after that, we could exchange with Teremo wire, and then we took the JR catheter. Then we took extra stiff wire. Over that, we used Mustang balloon. And after dilatation, we stented with EPIC stent. And last result is this, as we are showing. Thank you.
Are you over?
Yes.
Thank you, Dr. Shishir. Thank you very much for your lucid presentation. So we move on to the next speaker. Last of this session is for the stenting in intrahepatic Budd-Chiari syndrome. It will be delivered by Dr. Anupam Bhamani, the head of the Department of Cardiology at AIIMS Patna. Dr. Anupam, please.
Thank you very much, organizers, for giving me this opportunity. So Dr. B.C. Srinivas has already shown a very similar case in his presentation. Stenting in intrahepatic. So as we know, Budd-Chiari is a situation which is associated with very high morbidity and frequently mortality also. My disclosures in this case, I would have not been able to do this case if radiologist had not helped me. This was a 23-year-old lady presented with vague upper abdominal pain and discomfort for 6 months and mild abdominal distension. Labs were mildly elevated liver enzymes and elevated INR. Bilirubin was nearly normal. Ultrasound showed mild hepatosplenomegaly, minimal ascites, predominantly restricted to pelvis, mildly altered liver parenchymal echo texture, and with diffuse coarsening of the parenchyma. There was a tight stenosis web at the hepatic venous confluence and IVC junction with multiple veno-venous collaterals. So with this ultrasound, radiologist approached me if something could be done percutaneously. Pre-procedure ultrasound showed there was a tight web. I think because of the lightning, it is not visible. So there was a tight web, as we can see, between the turbulent flow. Turbulent flow is in the SVC where the hepatic vein is supposed to open, and the blue flow on the upper side of the arrow, that is the confluence of the hepatic vein. Thank you. Yeah, thank you. So this is the confluence of hepatic vein, and this is IVC, and in between there was a web which was complete, showing complete occlusion beyond the confluence of hepatic vein. Same thing, measuring the size of the web, it was about 1.3 millimeters. Then we did one transjugular venogram, IVC venogram, which showed that there were multiple collaterals entering in, and these were entering into liver, but there was no communication between the hepatic veins and the IVC. Transjugular 10 French access was taken with a sheath which was positioned in IVC near the opening of hepatic vein. Here we can see this was kept here to be safe so that when we perforate from the liver through the hepatic veins, we know where the IVC point is, where we should perforate with some hard end of the wire. Hepatic venogram was taken with percutaneous access taken into the hepatic vein, and then with simultaneously seeing both the catheters, we could know that this is the point where perforation should be made for entry into the IVC. Access into IVC using hard end of the 032 Terumo wire puncture was done, and with that, the Picard catheter was advanced into the IVC. Next step was to exteriorize this wire with the help of a snare into internal jugular vein. Snaring of wire was done into the jugular sheath. Now through and through access with Terumo 035 wire was there from exterior to exterior outside the liver and here outside the internal jugular vein. But it was not possible to advance the bulky catheter and stent onto the Terumo wire. So it was required to change over to the super stiff antegrade wire through SVC. Picard catheter. Now for doing this, we again needed some continuous access from here to here. So Picard catheter was advanced over the Terumo wire through hepatic vein, and the catheter was exteriorized through the SVC sheath. Hence, an external to external loop was established. Following this, super stiff wire was advanced from superior to inferior. Now we had a super stiff wire loop over which hard, bulky hardware could be advanced. Here we can see that hard wire is inside the catheter. And super stiff 038-inch wire was advanced from IJV to hepatic vein, creating an external to external loop. Balloon dilatation of the stenosis was done. Balloon was advanced from IJV. Even after balloon dilatation, the collaterals persisted. So we realized that it was necessary to stent this lesion. A self-expanding stent 12 by 40 millimeters was deployed across the junction. Immediately after the stenting, collaterals disappeared. Post-procedure, day 4, good opening of stent with absence of turbulence and communication between the hepatic vein and inferior vena cava was demonstrated. Post-procedure, lifelong anticoagulation is necessary in these cases. Clexane was given for 2 days till the INR of 2, almost approximately 2 was achieved. Prophylactic antibiotics were given during the procedure. Gastroenterology team was handed over the case for further follow-up and to prevent further encephalopathy, which is common in these cases. So take home is that in such cases, there has to be periodic follow-up. Lifelong anticoagulation has to be maintained. Reintervention is sometimes actually frequently needed. So close follow-up is required. So far, these procedures have shown good short and midterm outcomes in most of the studies. Long-term follow-ups are still required. Thank you.
Yeah, well done, Dr. Anupam. Actually, yeah, that's the way to do, because you'll have to go percutaneously, and then because occluded hepatic veins, you cannot enter from the IVC. You have to go through the percutaneous approach. I think, yeah, having an interventional radiologist or radiologist who can guide you for the Doppler guided puncture of the hepatic vein and getting access, that is the key. And next is, I think you can do, as a cardiologist, you can definitely do a sharp peak analyzation and get into IVC and then snare it out, as you did establishing a veno-venous loop between hepatic vein, either from the internal jugular or from the femoral. You can complete the procedure. But what did you use for closure? Did you use the gel foam or
Gel foam.
Gel foam. That I think that is the key. Either gel foam or a coil. you'll have to use and then close the tract, liver tract. Yeah, well done, well done.
Thank you, sir.
There is one question from Dr. Srinivasa. Sometimes in renal cell carcinoma, the IVC becomes full of either thrombus or cancer cells. And the surgical oncologists want to take out the tumor or nephrectomy and tell us to, in OT, to take care of this thrombus to take out. It's very difficult for a surgeon to go on bypass, and you cannot cannulate the IVC from RA because this is full of thrombus or cancer tissues. So is there any way out by intervention to?
Any of those cases? No, I have not done. No, they've asked me to treat the, tumor embolization. They've asked me to do because to reduce the, the arterial blood supply. But on venous side, I have not done anything. Renal vein thrombosis, pharmacomechanical approach, I have recanalized few cases, but not in the setting of renal cell carcinoma. But renal vein thrombosis, I have treated with, selective renal vein cannulation and pharmacomechanical approach, just gentle balloon dilatation and keeping a catheter, giving catheter directed thrombolysis and clearing the clot. That I have done.
With this, we come to the end of this session, and stage is handed over to the next mentor, moderator.
Next session is imaging and physiology session. And as you know, this imaging and physiology is now a integral part of any cath lab. So we have 3 eminent speakers and 1 case presentation in this session. So I'll call upon our speakers and chairperson to sit on the dais. Dr. V.G. Samuel Thompson, sir, please come. Dr. P.K. Sahu, sir. Dr. D.S. Chadda, sir. Dr. Arvind Kumar. Dr. Nishant Kumar Abhishek. Please come on the dais and sit on the chair. And I'll call our first speaker, Dr. V.G. Samuel Thompson, sir.
Sorry again to remind you, please do not talk. People sitting behind, कृपया आप लोग बातचीत ना करें, काफी disturbance होता है. Please maintain silence.
Sir is head of department of cardiology department in Christian Medical College in Vellore, and he has keen interest in imaging and physiology and peripheral vascular diseases interventions. And he has done his imaging training in Adelaide, Australia, and after his coming in from Australia, he has started this imaging program in CMC Vellore. So, sir.
Thank you. At the outset, I'd like to thank the BIC organizers for this wonderful conference, and also my gratitude for having me here for this meeting. A shout to my junior colleagues, Vipin and Ashish, for being at the forefront of BIC. So over the next 10 to 12 minutes or 15 minutes, it's my endeavor to take you through IVUS image interpretation in practice. I'd just like to know the speed of my presentation, just to know how many use any form of imaging in your lab, in the cath lab. Excellent. So there is a mix. So I will just strive to go through the very basics first. So these are the 2 consoles which are available for us in India as of now. Outside Thermo is also available. This is the Boston console, and this is the Volcano. And these are the 2 compatible catheters we use. So for basic understanding, we have a mechanical mechanical console, which uses the prototype is the Boston, and the solid states with the volcano. So the mechanical catheter, it's a single element which sort of rotates on its own, rotates, and depending on the catheter you use a frequency of around 40 to 60 megahertz to get a good resolution. With the Boston, because you have a standardized motorized pullback in millimeter per second, you can get a length assessment. But the downside, a slightly bit more in terms of preparation. You need to flush hard, you have to flush clean, make sure there is no air bubble interface between the sheath and the catheter. Meanwhile, the solid state is a non-rotatory catheter. It's got fixed phased array, 64 elements, rotates around 2000 RPM. The frequency is around 20 megahertz. The pullback is not as elegant, but you have control over it because it's a manual pullback. The near field imaging is poor because we always use the ring down facility, which sort of masks what the near field close to the catheter. No flushing required. It's just a plug and play. Very, very useful to use. So most of my pictures here, which I've shown, are from the Volcano catheter platform. Coming to interpretation of IVUS images, I must apologize, all shades of gray. So knowing what? So basically, once you enter the IVUS, you're oriented towards the ostium of the coronary artery. The objects are described as viewing the face of a clock. So from 12 o'clock to round to clockwise to 12 o'clock, we use landmarks inherent to the coronary arteries and the vessel structures adjacent. We use branch origins, the pericardium, the transverse sinus, the venous system, calcifications. Important to know that veins may come close to the main branches. They might cross, but they never join. So moving on. So this, unless we know the blood which traverses through, how it looks, we might not be able to make much sense of the vessel wall. So I have two cartoons here. One is the black blood. So moving blood, if I go back and play it again. So that is the dark speckle of suggestive of a normal flowing blood, whereas, excuse me, and this is the bright speckle because the stasis flow, it appears more hyperintense. This is a branch which is flowing well. This is a side branch which is sort of TIMI1 flow. Moving on to understand the IVUS images again, moving from inside to the outside. You have the lumen with the dark speckle, what we talked about. It's limited by the luminal border, the intima. You have the media, and outside of the EEM, we have the adventitia. Make note of this. We always look at this echo density to compare rest of the structures. When it's limited by the intimal, this is the lumen area. When it's limited by the external elastic lamina, then that is the vessel area. And what is between this constitute the plaque area. Now, briefly about measurements, I'll just take you through the area stenosis and the plaque burden. The area stenosis is measured at two different points. You have a reference segment at the linear normal where there's no plaque buildup, and the lumen area at the site where there's a maximum plaque buildup. So how do you calculate the area stenosis? Is the lumen area at this point minus the lumen area at this point divided by the reference lumen area. Whereas the plaque area is remember this at the same point where the lumen and the plaque occur. So it is this area minus this, and given as a percentage gives the plaque burden. So moving forward, we need to be able to identify some structures which you commonly encounter on pullbacks. So what about the pericardium? It's highly refractile, and you can see the spokes which are vertical. These are spoke-like reverberations, and then it's complemented by the back and forth movement of the heart, which gives that movement. The pericardial space, especially when you pull back from the left main, from the LAD into the left main, you'll see this sometimes known as the triangle of Brooke, where you have the LAD, the circ, and the great cardiac vein forming this triangle. So it's important to identify this because these are inherent landmarks which you are going to use. Coming to interpretation of the plaques. So as I said earlier, always look at the adventitia and then compare the rest. So you have a hyper-intense kind of a structure that is the adventitia because of the increased collagen and the elastin. Going inside, this is the area between the luminal border and the EEL. You have the plaque and media. Many a times you may not be able to differentiate this, but you compare with this, the density is isoechoic. So you say that is a fibrous plaque. What about this one? You have, again, you look at the adventitia, that is this density. You compare here, it's much more refractile. This is a calcific plaque. We'll come, how to describe it will come over subsequent slides. Soft plaque, again, look at here, that's the adventitia. You see the plaque, it is less echo intense. That is why this is soft plaque. Now, attenuated plaque is similar to what a soft plaque is, but you see, you can see through it. Here, it's the sound waves deeply attenuate. You cannot see beyond. That is suggestive of a lipid core and necrotic core. Echolucent plaque, again, you will see that in the plaque, there is a echolucency. What is echolucency? Again, compared to the adventitia, it is echolucent. This may be a fibrous with the echolucent area, either necrotic or it could be lipid. And this is a mixed plaque. When you say a different consistency, you have fibrocalcific components, lucency, and then some calcium. What does plaque rupture look like? You see, you want to trace the intima. There is a gap in the intima. There's a crater-like thing, and maybe a thrombus lurking here. That is a plaque rupture. And finally, a thrombus. You see, it's moving. It's in the lumen wall, and you see the varied consistency and attached to the lumen. That constitutes a thrombi. So having been that, so just a little bit more stress about calcium, because many years management strategy for coronaries hinges on that. The superficial calcium is closer to the lumen. Superficial calcium closer to the catheter or to the lumen. The deep calcium is away from the lumen and towards the adventitia. That constitutes a deep calcium. Dissections are important to understand. So again, how do you identify them? A breach in the intimal continuity. Then you need to describe the axial extent, whether it goes into the media or the adventitia. Depending on that, we call the terminology. And again, the longitudinal extent is important. What is a significant dissection now? Within 5 millimeters of the stent, extends into the media, has an arc of over 60 and more than 3 millimeters length, which has a clinical significance. Moving on, intramural hematoma can be within the EEL or outside the EEL. When this is intravascular, that is extravascular, echolucent structure again, partially compromising the lumen in this case. Again, see, can happen after a iatrogenic balloon dilatation. You see a pullback from here. You can see a hematoma. There's a narrowing of the lumen, which you can see here. So there's a big hematoma, however, is still within the EL, and again, it's an intravascular hematoma. Coming to post-stent cases, sometimes you encounter this. This is the stent border, and this is the intimal border. There's a space between. You can demarcate or delineate clearly with the what we call the chromoflow technology in the volcano IVUS. That's the space beside. It is ominous if it is more than 0.4 millimeters and longitudinally extends more than 1 millimeter in length. That what you know what malapposition is. We'll currently come to what we accept as a stent expansion criteria to know optimal stenting strategy. Basically, it means a lumen area of more than 80% of the average lumen reference, or an absolute area of more than 5.5 millimeters squared. Many studies in meta-analysis says that more than 5.2 for a drug-eluting stent, the restenosis rate is around between 0.5 to 0.6%. So that is good enough. And for the left main, for the proximal left main is 8, and for the distal left main is 7. So nothing is complete without able to discriminate at least some artifacts. So this is what we call as a stent goes. What you're seeing is reflected onto here in the opposite side. It appears as a malapposition in this pose, or sometimes can be mimic a dissection. So it's important to know this artifact. And non-uniform rotational distortion, NURD. This is unique for the mechanical system. When you have a rotatory component, what happens is the catheter gets stuck inside the sheath, either because of a tightening of the hemostatic valve, a tortuous guiding or a guiding catheter, acute bend, calcific lesions, defective imaging catheter, kinking of the imaging sheet. What happens? They get stuck here. There's a wide sweep of that area, but the other area is not well covered. You can't do measurements with this image. So to summarize, I know I've spoken through a lot, but it's because of brevity of time. So to summarize, this is the stent border, the dotted pink. This is the vessel lumen. So you can see there's a malapposition. This is the EEL. So what is inside this area constitute the vessel wall, vessel area. This constitute the lumen area. So this minus this is the plaque and media buildup. You have malapposition here. You can see a calcific, which is superficial because it's closer to the lumen. So again, you describe all the structures like the face of a clock. So IVUS utilization in current practice, intermediate lesion assessment, the answer is probably 2B, because it is not really very useful. You would use a functional study, either FFR, IFR, RFR, etc. For complex angioplasty procedures, there is enough evidence, multiple trials, ultimate, long XPL, and the Renovate complex study, all showing that in complex lesions, actually the IVUS provides a mortality and a morbidity benefit. Instant restenosis to characterize the plaque, what kind of debulking device you want to choose, IVUS extremely helpful. Choosing debulking devices. And finally, a culmination of all this, the left main intervention, the most complex of coronary interventions, you need the help of IVUS. So even though I've said, can you use the IVUS for an intermediate lesion? You could, especially when you don't have a FFR or IFR. If the lumen area is less than 4 on an IVUS, and you also look at the area stenosis, which is more than 70%, a plaque burden more than 80, and a lesion length than more than 20, it sort of correlates with an FFR less than 0.8. More than 4 by IVUS, again, it depends on the size of the vessel, but it's a very simplified algorithm, differ revascularization. What about the left main? We have multiple studies, starting with Torres from Spanish registry, from Jasti, from Kang, less than 4.8 in Asian population is said to be significant, but always use a double check. I would say that your whiskers should be up between 4.8 to 6 because you don't want to miss a significant lesion. Use a combination if feasible. So having said the basics of image interpretation and to look at some artifacts, let's do it. So let's see an actual case which happened a few days before I came. This was an 80-year-old octogenarian who came with unstable angina, declined by the surgeons, and the patient also refused surgery, so I had to find a way out. Angiographically, it looks like a 011. That is what it shows. I've shown you frugal views, especially because I'm going to use IVUS for this. So having done that, that is the pullback, and we are going to see the pullback from the left main. So that is the diagonal there. That's the septal coming here on. You can see a calcium plate, which was initially deep, becoming superficial, going around 270 degrees. There is what I told the triangle of Bruchek coming up. There's a significant plaque, the circ coming in, significant plaque in the distal left main, and the plaque of calcium extending onto the ostium. What about the circ? Good area for a landing zone. You can see a sort of a vein coming, not joining, going off. There's a branch with joint. Then there's a plaque buildup, mostly kind of a fibrous with some calcium specks. There's the LED wire coming in. If you watch closely, I'm going to show you this again. Please watch this area carefully. You're going to see something, which you'll see probably in the angiogram as well. So I've had two views of my angiogram. I've had two pullbacks from the LED and the circ. What am I going to do? Practical aspects. I'm going to look at landing zones. I'm going to look at debulking strategy for my circ and for the LED. What kind of strategy, and all obviously with an aim to choose the appropriate stent and optimizing the stent for long-term durable outcomes. So this is anybody who does intervention for the left main will know this. The proximal left main, the distal left main, you break it down, the polygon of confluence, the circ ostium, the LED ostium. Once again, this is the Achilles heel of left main intervention. And usually the POC is defined as this polygonal structure in the longitudinal view. So having done two pullbacks, I've got the references for you. So the left main, at no segment was it fully normal, but the closest which we could get was like a 5 millimeters for the left main. LED reference just proximal to the LED diagonal and the septal I showed you was around 4.5, and the circ was 4 millimeters at the distal landing zone. And also showed you these plaques which came upon. The ostium of the LED. We saw the deep plaque which was started as a deep calcium, a single plate becoming superficial, and then sort of almost 270 degrees of that LED ostium. Also note there's some degree of negative remodeling of the LED at this point. This is the circ, a large plaque buildup, but mostly like fibrous. So how did we go about it? So this is what I told you to look carefully. This is the LED wire coming out. You can see that kind of a small crater here at this point, which corresponds to that small ulceration in the main left main, what you see on the superior aspect. So how did we go about it? This is the we thought we'll debulk the Circ ostium, lot of fibrous plaque with a Wolverine, and the LAD was very calcific with the 3.5 IVL, and then subsequent good non-compliant post-dilatation to set the bed ready for stenting. The technique was a DK crush with use the Circ as the side branch. So this is the post. So we said that is a good landing zone. That is exactly where we have entered. There's around plaque of probably around 30% here. The LED stent well approached at some slum under expansion. This is where the Circ comes in. You can see the polygon of confluence there. Some asymmetric expansion, but it's acceptable, and then extend right to the ostium. Circ pull back, good apposition of the vessel to the vessel, coming back, the polygon of confluence here, and then we did a pot. You can see it becomes circular here and extending right up to the ostium and covering one strut into the aorta. So this is the areas which we've got. So we've got an area of 20.5 in the proximal left main, and 19.5 in the distal left main, a POC area of around 21.7, Circ ostium of 9.4, and the LAD ostium around 14.2. And if you were to believe me, this is the angiogram, final angiogram after the procedure of the left main Circ bifurcation. So this brings us to, we've sort of planned, we looked at landing zones, we've debulked, and finally we said optimize the stent. So look, going forward, when you use bifurcation, when you're committed to a bifurcation, what you should understand, it carries a restenosis rate of 25%. Missing from here is the DK crush data, which is probably around 10 to 12%. But where does the restenosis occur? It occurs at the Circ ostium. In crossover strategy, the restenosis rate around 6%. Again, the maximum occurs at the Circ origin. The safest bet is if you don't have a lesion across the bifurcation, you have only an ostial or shaft length, restenosis rate is very low. Two more slides. Again, if you have a side branch lesion which is complex, embark on a straight up on a two-stent strategy, DK crush. If you have simple lesion as described, less than 70, less than 10, go with a provisional strategy if the side branch is easily accessible. If not, you embark on these. A few words on bifurcation when it comes to treating as the side branch. If you have a plaque like this, beware on IVUS. If it is more towards the LAD like that, when you dilate, it is going to pinch your Circ. So that is called the eyebrow sign.
Please
and then
conclude, sir.
when you have a last but one slide, if you have a plaque shift, what is the difference between a plaque versus a carinal shift? You use a size, the distal vessel bigger than the side branch or more than what is the distal reference. You get this. When you have a carinal shift, you have a vessel decrease in size, lumen decrease in size, whereas in a plaque shift, it's only the lumen which get compromised. So predictors of side branch loss, more than 50% angiographic stenosis, or more than close to 60% plaque burden of the side branch, ostial MLA less than 3.7, more than 60-degree calcium, and a post-intervention less than 4 millimeters, you think the results won't be as great. Take-home message, IVUS never competes functional. It complements physiology, guides and ensures landing zones, characteristics of lesion, plaque modification strategies, optimizing stent outcomes with numbers objectively, and good long-term outcomes in complex lesions. Thank you. And I take this opportunity to take questions if there are any. Thank you.
Thank you, Professor Thompson. You have taught us how to use, when to use IVUS during PCI to get perfect result. Wonderful talk. Questions, answer, comments will be at the end of the sessions. Now, may I invite our next speaker, Dr. P.K. Shahu, Senior Intervention Cardiologist, Apollo Hospital, Bhubaneswar. He is also convener of National Intervention Council, which annual conference is going to be held from 26th to 29th this month at Mumbai. He is the convener of NIC. Please go ahead, sir.
I have my slides. Thank you, Bihar International Council, for giving me an invitation to be a part of this program. In fact, after Dr. Vijay's talk, things are much simpler for me. And I'll just try to take you over because this is something, a very controversy. When you have both the images, both the devices in your lab, what is to be used and where it is to be used. So when I say that IVUS versus OCT, whether to use which to use, It is sometimes like choosing between your wife and your ex-flame, that what has to be chosen and what has not to be chosen, to whom you have to be more loyal. Now, this is not a debate that I am taking, that I am telling IVUS is good or OCT is good. For example, if I show you this diagram, for those who do not know the difference between crocodile and an alligator, how will you differentiate it? The best answer to give it is the crocodile is next to the alligator. So that solves the problem. So be very tactful in your reply, because it is just like the two complementary systems that you have to use. So when to use IVUS and when to use OCT, I'll quickly go through certain cases to show. Autoosteal lesions to start with. For example, this is a case in which there is an osteal leftman, and here I will prefer to use an IVUS, because you see this is a case that has been done pre and post. For all osteal LMCA lesions, the best thing to use is an IVUS. That should go. Now, this is how the osteal looks like, very severe osteal lesion, and you have to get it done with an IVUS. Now, why not an OCT? Because OCT can be done, but clinic blood from the autoosteal junction is problematic. So IVUS is the choice. The second session, LMCA. Now, LMCA, we have to be very careful, because as Robert Bryan had said, we are, as interventional cardiologists, these cardiac surgeons are always looking at us whether we can give them good results. So LMCA is not just a tubular structure. We have to see that IVUS is to be used, because IVUS is beneficial. But when do you use it? All LMCA interventions. It is immaterial what to use. Now, especially borderline LMCA, osteal LMCA, shaft and distal LMCA. There are figures which have been quoted by Dr. VG, and also they have given the final figures. But this is the current data that we says that we should at least achieve 10, 8, 9 in LMCA, LAD, CIRC, which is the current data. And you have to aim for the wider it is, the better it is. For example, if I show you this case where there's a shaft lesion and this thing also, the LAD is diseased, and you just do the IVUS in these cases, you will know that you just cannot leave the stent from the shaft, from the LMC alone, and put another stent in the shaft. So you have to go for a two-stent strategy. A cutting balloon was done, and finally, this is what we achieved after putting the stents. So a post-cutting balloon analysis will show you whether your stent has expanded well or not. You can see the cuts also very well when you use the IVUS to decide whether your cuts are good, and finally you get a good result. Now, this is a post LCX to LMCA. You have to take 2 runs to know. You can see the confluence very nicely over here, which clearly shows that you have achieved a good and the carina is good. So post POT, you can see this is the results where you have achieved almost more than 14 you have achieved in the final LMCA. So IVUS does a good job in these such cases. Now, if we try to see, when we see an angio and when we go to imaging, there is almost a change in plan for 74% of the patients. So it's very important that imaging is a must. For me, for all osteal cases, it's LMCA, IVUS is a choice, and beyond that is this OCT. So this is my take-home point, that where I use IVUS and OCT in LMCA, I prefer to use IVUS in the osteal. And definitely, if given one device, it will be IVUS, it will not be OCT. Now, so this osteal leftman is somewhere we have to be very, very perfect by using an IVUS. And usually the OCT cannot detect anything more than 5. So anything more than 5, you need an IVUS. Now, there's very little data on OCT on leftman. The only data we have is on IVUS. So IVUS is a standard protocol while doing LMCA stenting. The next lesion are bifurcation lesions. As VG had said, whether the side branch will be compromised, single or double stent strategy. The eyebrow sign he has shown you how it can get pinched out. And definitely you can predict on IVUS, but OCT is a very good predictor. You see the carinal tip angle less than 50 or the BPCT length less than 1.7. You can decide whether to go for 1 stent or 2 stent. For example, this case, if you do a run on the OCT, you can see what is the BPCT angle and the carinal angle. You see this fits into just one single stent. And that is what I did. I did a single stent over here. I did not go for a double stent. Now, this is a pre and the post with a single stent. You can see all the side branches flowing well. Next is that when do you need a 2-stent strategy? Again, let us see whether we need a 2-stent strategy. This is a case where there is a non-leftman bifurcation, and you can see that diagonal is a big one, which is occluded. And if I do an OCT in this and try to calculate the BPCT angle and the CT, this thing that is angle, length, you will see that this fits exactly for a two-stent strategy. So here I went with a two-stent strategy, and you can see the pre and the post images, where you can say with the DK cross, the results are good, and OCT help over here. And so there's a post-PCI LED OCT run, which you can see that clearly that is good apposition, and the side branch also you can see is well opened up on the 3D reconstruction. And finally, if you take a run from the diagonal to the OCT, you can see that the confluence is very well, and it can be seen good that you have done a good job. There are no overlapping of struts at the carina. Now, if you ask me bifurcation, what is good? Both are useful. You can use either IVUS or OCT. Now let us come to calcific lesion. Calcific lesion, actually, there are scoring criteria for both on OCT and IVUS, but if you see a calcific lesion of a circ, so this is a circ where you can see that it is a very calcium, is there a lot of calcium is there, also deep calcium is there. And in these cases, intravascular lithotripsy is good, because if you do a calcium quantification, you see the arc is more than 180 degrees, that is more than 50% of the whole artery is calcified. And then the thickness is more than 0.5 millimeters. And on top of that, the length is more than 5. So if you do this calcium scoring, the score comes to 4. And when it comes to 4, you have to take a higher modality for debulking. And that is why, based on the algorithm, you either go for lithotripsy, which will be the best ideal thing, and that is what was done. In fact, the post-lithotripsy fractures can be very well visualized. You can see the calcium fractures have occurred. And now you know that your debulking has been done well, and you can go ahead with the stent. So these are the fractures that you can see. And finally, stenting was done. And this is a post-stent which shows the expansion is very well. So for calcific lesions, as I said, you can use IVUS, you can use OCT, but most importantly, even if you use an OCT, especially the 60 megahertz, you can see similar cuts. This was a case which was done, both OCT and IVUS was done, and you can see the cuts very well demonstrated on a 60 megahertz IVUS or on the OCT. Next, you can see the stent apposition over here also. They're quite well visualized both on OCT and IVUS. So in bifurcation, is immaterial whether you use an OCT and IVUS, but selecting a single stent or a double stent strategy, OCT does help in fact. So now this is a post-dilatation after the NC. You can see, for example, if you have a stent in-stent restenosis, you can see this figure in the middle where you can see that the stent has not expanded. And for these cases, OCT is very good. In fact, you can know what is the cause of non-expansion and what is to be done. And usually OCT penetrates calcium best compared to IVUS. So in calcified lesion, of course, OCT is something which can be preferred better than IVUS, but IVUS is also a good tool because calcium is best penetrated by OCT. So I would prefer in calcified lesions to go for an OCT. Balloon uncrossable lesions, definitely it all depends, because you were seeing a tram track calcium on fluoroscopy, and then going by the algorithm, either you use a rota or a orbital. And after this, the post-rota images, you can see how the OCT looks like. You can have debulked something over here at the various stages in that case. And that is after NC balloon dilatation, you have seen that you have enlarged the vessels well. And based on the enlargement of the images that you can see on OCT, you can put your stent and you can see that the stent has expanded very nicely. You can see a white marker all throughout showing that your stent is expanded well. Now, this is a post-stenting analysis which clearly shows that the stent is well expanded. Now, when to use IVL, in fact, this is for cases which has got a high scoring. In fact, the IVUS scoring has changed now. And if you have to use the IVUS, don't use the standard IVUS. Always it is like Dr. Chadha was telling, we used to go and move the antenna to see what is there. So you use the HD IVUS. In HD IVUS, the quality is better and you can see better things. For example, this is one case of calcium where I have done the OCT and the IVUS, and you can see the images. But you can not appreciate when you see the IVUS images, you will see that there is totally dark behind the calcific area, which clearly shows that definitely your this thing that is calcium is deep, and you can measure the arc, you can measure the thickness, you can measure the length. And this is after the OCT has been done in the same case, where you can see the cuts very nicely and the expansion, which I had shown you in previous. Now, in calcific lesions, how do you know in calcific lesions? You have to see if there are denervations due to calcium, scoring systems are there, so OCT is preferable. Now, when you come to ACS, ACS is a subset what to use. I would always prefer to use an OCT because you can know what is plaque erosion and what is plaque rupture. Because if it is a plaque rupture, you have to go for a stent. I'm not going into these details, but this is a case of a plaque rupture in OCT, and see the images on IVUS. They're not that good, but still then you can appreciate on IVUS also the same case where OCT and IVUS has been done, and it shows a plaque rupture where you have to put a stent. Similarly, in a plaque erosion, you can see the OCT images of plaque erosion, and you can also see the IVUS images of plaque erosion, where you can see that there is a chunk of eroded material where no stent is to be put. So this is how you can decide and put this patient on pharmacotherapy. And the advantages of OCT is that you can know whether there is red or white thrombus, whether there is erosion or rupture. So OCT scores on it. When you have ISR, in ISR, definitely this is a case where you have done an ISR. 2011 it was done, 2025 at 24 it came with an ISR, and in the ISR you can clearly see that is more of a fibrotic lesion. You can see the fibrosis, and you can see it's a long segment, undersized stent had been put, significant luminal narrowing, homogeneous and extensive pneumointimal proliferation. So here you have to debulk it, then with a cutting balloon, then with the NC balloon, put a larger size stent, and then see for stent expansion. That was what was done. A cutting balloon was used, and after the cutting balloon, what we did was, this is the OCT post ISR stenting. You can see how the stent has expanded, and the previous stent is not visible at all. So in ISR cases, you have to also to see whether the stent coverage is proper or not, whether there is new atherosclerosis, and this is best visible on an OCT. Imaging in BRS, definitely there is nothing to doubt. OCT is the best. For example, in CTOs also, flushing is required during CTO cases, so OCT is not preferred. IVUS is to be preferred. And if you do an IVUS, you can know where the proximal cap is, and you can puncture it. Renal failure, undoubtedly low or no contrast PCI. It is reality, and you have to use saline flush for renal protection. And the best thing is to do multiple wires, and by marker wire technique, put the stents. And finally, you can do literally the case with hardly 3 to 5 ml of contrast. Then contrast load may exacerbate renal function, so IVUS is preferred. The last subset, detecting complications. For example, this is a pre-OCT of a chronic stable angina. The stenting was dissected. There was an extensive dissection by the balloon. There was a big arc of dissection. And then what was happening was that we had to use OCT to see what has happened. Another complication of a dissected LMCA, which was done in another center, they dissected the LMCA and they had sent the patient. The patient was in cardiogenic shock, got salvaged. You can see the dissected LMCA. And here, when you do an IVUS, you can clearly see, you can do an OCT, you can clearly see the images and how you can size a stent and put another stent for it. For example, this is the pre and post PCI of the LMCA, which was dissected because of the guide catheter. And this was the image that was seen. So in complications, sometimes OCT does come of help. Now, detecting malapposition and under expansion, this is under expansions where you don't expand it, and this is malapposition, and these are best detected when you do an OCT. And for example, this case comes within 15 minutes of an antival MI, and when we do an thrombosuction, we do a stenting in ACS, and what we see, you see the red marks, these are unopposed stents. So here we have to, this is an unexpanded malapposed stent. You have to post-dilate this, and after the post-dilatation, you can see how well this stent has expanded, and the final job is done. So apposed and well expanded. So IVUS or OCT, whatever you use, it is a third umpire. You appeal for the third umpire, and there is basically no tug of war between OCT and IVUS. You have to know where to use it. To simplify it, if it is morphology, length, diameter, etc., I'll use OCT, but if it's for a CTO, LMCA, oscillation, advanced CKD, I'll use IVUS. And all these have been given a class 1A indication, and it's very important that you do not know what is the color of the cat, because the color of the cat does not matter as long as it catches the mice. So whatever you use, you try to use something, whether it is an OCT or IVUS, your mice has to be caught. Thank you very much for the patient hearing.
Any questions? Very nice overview of IVUS versus OCT, sir. Very nice images. So there is no question. We'll proceed with the next lecture. Overview of NIRS IVUS, a new modality by Dr. D.S. Chadda, sir. It doesn't need any introduction in Bihar now. And always ready to come to help us, and a few of the workshops he has done. I have privilege to work with him 2 times, and he is a master interventionist in mostly in modification of calcium and all the strategies, sir. And also he is a son of soil. He's from his initial days, he spent in Ranchi. At that time, it is a part of Bihar.
Thank you, Vipin. Yes, I spent quite a lot of time, not initial days. First 18 years of my life was in Ranchi. So happy to be here. All right. Thank you, everyone. Happy to be here. So I'm over the next 15 minutes talk about NIRS. You know, last couple of years been very good for imaging. It got the kind of recognition which it deserved. So in 2024, ESC made it class 1 for the lesion subsets which are listed here. And in 2025, ACC/AHA made it class 1 for the ACS. So in nutshell, we've come around, and there's a lot of work which was going on, and now it's got the stamp, because this was important, because when in a peripheral center, someone would go and ask the administrators, 1-point reply was used to be, no, it's not indicated, whether they understand any guidelines or not, but this was the reply that most of the operators got. Well, Dr. Sahu gave an excellent talk on IVUS versus OCT. This is the ACC statement on imaging. ACC says that all cath labs should have imaging, and because this is essential for complex lesion subsets, and we need to educate people. But either of the 2 modalities is good, but if you're choosing one particular modality, then IVUS is probably the best modality to start imaging in any given center. This is the summary of Dr. Sahu's talk. They are kind of equal where the plaque morphologies are concerned, but in subsets where there is osteal lesion, left main, and in CTOs, IVUS definitely scores. And we know that in certain patient subsets where there is renal failure, LV dysfunction, IVUS definitely scores over the OCT. Well, this basically implies it has got wider application, but IVUS definitely has got a learning curve. OCT is much easier. You can easily interpret the images. IVUS needs a little bit of tutoring. This is the new system which is available, and I've been using it for more than a year and a half now. It's the Mercator system. It's a dual pro imaging system. That means you get twice the information with single catheter. You will not only get to know the plaque morphology, you will also get to know about the plaque composition. So 2 things simultaneously you get in a co-registered manner. The Mercator IVUS system is slightly different. It's different because it's got 3 pullback speeds instead of 0.5 and 1. It also pulls back at 2. It's got bidirectional movement. The camera moves on its own. With a click of button, the camera comes back to its original position. It's got a wider range, 150 millimeters. It's a very sturdy catheter. So the pushability is good, and especially in angulated tortuous segments. And it produces unmatched imaging qualities. I'll show you some cases. Now, NIRS is the essential component of this machine. NIRS is nothing but near infrared spectroscopy. Now, what is the advantage? The advantage of NIRS is that it specifically localizes the lipid pool in a given lesion. So, and this was validated in 2008. When they did the cut sections of the cadaveric coronary arteries, and they found 95% sensitivity, specificity of NIRS in picking up lipid pools. Well, how it does it? It basically transmits the near infrared light, and the light is reflected back, and on a probability score between 0 to 1, anything above 0.6 is marked as yellow. So whatever you see as yellow is the lipid pool. So it characterizes the composition of the plaque within the coronary segment. Now, not only it detects, but it also quantifies it. You know, lipids will appear yellow and non-lipid segments will appear as red. And if there are few artifacts or the guide wire artifacts, they will all appear black. Now it quantitates on a scale to 0 to 1000, and this is called the LCBI. It is called Lipid Core Burden Index. So you can see in this given figure, it also marks the segments which have got maximum lipid as max LCBI score. So if the LCBI score is, if the yellow figure here you see is about 824, it implies that 82.4% of the plaque here is made of lipid. Well, these are the landmarks on the development of NERS. It's got the FDA approval in 2008. It got the IVUS NERS as a dual imaging modality, got the approval in 2010. In 11, it got a CE mark, and it's also got the Japanese PMDA approval in 2014. So what I'm trying to show here is that it's not an investigational or a new modality. It is approved globally and it's a recognized modality. Let's see its application. Well, in ACS, the first subset, we know that all the future coronary events are linked to the non-culprit vessels. So plaque stability, instability exists in the non-culprit vessels also, which increases the MACE rate. So knowledge of composition is very, very important. We image, but what happens is that when you image, IVUS and OCT cannot tell you what is the character of the plaque. If you can see negative remodeling, you can see lipid-laden plaques, but you do not get to know whether these plaques are going to rupture at a future date or not. So in this, we have a modality which can tell us that these are lipid-laden plaques, and these plaques can rupture at a later date. Now, to study this, this was one of the major trials which happened. This is called the LRP study. I'll just give you the summary of the trial. This had about 1,500 plus patients, and they looked only at the non-culprit lesions, and they analyzed and looked at the event rates. What they noticed was that the event rate at the end of 2 years was about 9%, and NERS score of more than 400 not only predicted a vulnerable patient, but it also told us that these were the vulnerable segments which can give rise to event. To conclude, this trial said that doing interrogation of the non-culprit vessels is pretty safe. There is absolutely no problem. And you can stratify these lesions, and you'll be able to use the max LCBI score as a predictor for future events. Now, subsequently, if we pool the LRP and the PROSPECT 2 studies, what came out was that if you have high lipid plaques, this given subset of patient is at high risk of events, so you need to do something. So what one can do is that you can take the prescription out of the cath lab into the OPD and continue them on lipid-lowering therapies. I'll show you some case examples. This is an ACS patient. He had come with anterior wall MI, a lady who's got disease, and we did the IVUS NERS pullback. So what you get is a parallel image of the NERS as well as you get the IVUS image, what is called as a chemogram. You can see a very nice calcific plaque with reverberations. And you also see circumferentially yellow and red rim moving around, which tells you now at this point of segment, you have a lot of lipid burden behind the calcific plate. And the NERS, if you see the chemogram here, the max LCBI score was around 1000. So this was a calcium-laden plaque, lipid-laden calcific plaque, which was seen in this given individual. Now, what happens is when you dilate such plaques, you get immediately a lot of slow flow, and this is what was seen, a lot of slow flow seen in this segment. And this was the, I hope it runs. No, it didn't run. 1 second. Sorry, it's not running. So we stented this segment. The LCBI score came down to about 475. This is probably because of the distal embolization. Now it's running. So this was the post stenting images. The quality of images are very high quality and they're beautiful. I'll show you a couple of more cases. And this was the final run of this individual. Now, what message we get out of this is that, you know, you can have lipid-laden calcific plaques causing ACS, but they can be mistakenly labeled as stable plaques because it is the lipid which causes instability. If you have more lipid in the plaque, that means there is more instability in that given plaque. And this, compared to the calcium-laden plaque, is an ACS of a young individual where there was a little bit of thrombus burden. And if you see the nurse images of this given case, what you can appreciate here is that pristine vessel where media, adventitia, lumen, everything is seen. Now you see a thrombus burden. You see between 2 o'clock to 6 o'clock position, there is a huge thrombus burden in the vessel. But there is no atherosclerotic plaque. This is a classical example of plaque erosion leading to ACS in a young individual. So this is the image. You see the media like a rubber band. You see minor plaque here, and you see a thrombus. So this is a classical IVUS image of plaque erosion in a young individual. And you look at the LCBI scores, they are below 400, 338. That basically implies hardly any plaque burden in this given individual. Now, in ACS, there is a gradation of LCBI score. In TEMIs, the score is higher. In unstable angina, it's on the lower side. You can identify the lesions by looking at the NERS score. Okay, the NERS score is high. This might be the culprit lesion. You can also identify your landing zones of the stents through this. And most importantly, you can optimize the prescription. We really don't know how long this patient needs lipid-lowering drugs. And in the OPDs, this gives you an objective evidence that, okay, I'm going to use the lipid lowerings for a little longer period because he's got high LCBI scores. Well, Yellow study and the Pacman AMI trials both showed that if you use statins for long, it increases the fibrous scrap thickness and it helps in stabilizing the plaque, and it is well exemplified and it should be put into practice. Now, we use NERS also for stratifying the calcium lesions. Can NERS peep through? We know that IVUS and OCT do not peep through the calcium plates. OCT gives you the calcium plate thickness, whereas IVUS kind of creates an acoustic window. So IVUS and NERS cannot tell us much more about plaque behind the calcific plate. In NERS, we can do that. NERS has been used transcranially to assess the cerebral oxygen concentration, and it characterizes the composition of the plaque behind the calcium plate. Now, if you see this case example, if there is a lipid plaque within the calcium nodule, and there is a plaque behind the calcium nodule. NERS is going to tell you there is lipid in this calcific plate, but it cannot localize. It cannot tell you whether it is behind or within the calcium plate. But the important message here is that more the NERS score, more will be the calcium burden, as was seen in this study. So high lipid content means that there's going to be more calcium at a later date. Now, I show you a case example of a distal left main and an osteoproximal LAD disease. These are some beautiful IVUS NERS images. Now, you see this is a pullback from the LAD to the left main. Circ is joining at around 12 o'clock position. You can see a very well-defined plaque, and you see now a calcific rim which will come, and behind the calcium ring, you will see circumferential lipid pool, correct? So we do the pullback from the circumflex side also, and the circumflex pullback, now it's merging, the LAD is merging, you see the guide wire coming, and you see the plaque burden. Distal left main again has got a calcific plaque. It shows circumferentially there is lipid behind. All we did was we used NC balloons. We didn't even use cutting balloons in this given case because the LCBI score was very high, about 554, and we got a very good results on provisional stenting. Well, yet another case, this is the case which showed a calcific nodule. You can see in the proximal part of the LAD. This was a nodule which was in the proximal part of the LAD. And if you see the evolution of calcific nodules, it is very clear that the initial stages, it's all lipid. You have some macrophage calcification, edge calcification, and then it progresses on to become a thick calcific plate. So spotty calcium, eggshell calcification to hard shell calcification. These are deformable till the time it's eggshell calcification. It's non-deformable beyond that. That means you need the atherectomy tools for a non-deformable nodule. So NERS signal can tell you that what you're dealing with is a deformable calcium nodule. So that's the advantage of NERS in your clinical practice. What we did in this case, this was a NERS, max LCBI of 816. We just used a balloon and deformed this nodule. And you can see very rarely you get to see these images that you are dealing with a calcific nodule in a native coronary artery where post dilatation you get slow flow. So that's what we noticed, and it's also kind of published in the data. Higher the NERS score, more are the chances of this lesion having slow flow. Well, this is post-stenting, and this was the final angiogram. So the basic algorithm which we've proposed using the NERS is that if you see a calcific plaque which is balloon crossable, you can do the IVUS NERS imaging. If not, then you need some atherectomy tool to make it balloon crossable. Then do the LCBI scores. If the LCBI scores are high, all you need is NC balloons for dilatation and you'll get optimal stent expansion. If the LCBI scores are low, then you need the atherectomy, either rota, orbital, or you need cutting scoring balloons for optimal stent expansion. And we've been following this algorithm to the hilt, using LCBI scores in our calcific diseases. To summarize, I would say that IVUS NERS is a new modality. It's slightly different. It's got a dual imaging. It tells you composition as well as the plaque morphology. It's got a bigger range. It's got higher speeds, bidirectionally moving catheter, a very sturdy catheter with very importantly good reusability. The advantages are that it helps you not only detect but also quantify the lipid content. It tells you about the plaque composition, and how does it help? It kind of predicts the events at a later date. It characterizes the plaque composition and takes the prescription out in the lab. It helps you stratify the calcific lesions and helps you select the optimal tools for atherectomy. Well, this is going to find increasing use in the times to come. I'm told that NERS is coming along with OCT as well, so that you'll have a dual modality working, wherein it's important for you to know the plaque composition, which has got a sick implication. We need some more trials in this direction, and once we'll have much better utilization of this new modality. Thank you.
Thank you, sir. As usual, your presentation excellent. Any questions, comments from our?
What will be your recommendation for non-FFR positive lesions with high NIRS score or?
I didn't understand.
It's non-significant lesions. If the plaque you find vulnerable in this case.
Nothing. Optimal medical therapy. You basically, it tells you if we do it in our lab when we are doing STEMIs, we get them back for optimization. We also check non-obstructive plaques in the other segments, and we document the LCBI scores in these segments. If the LCBI scores are anywhere more than 400, we recommend high dose statin at least for 1.5 to 2 years. You know, in yellow trial, they did a follow-up at the end of 8 weeks, and they showed that there is a reduction in the LCBI score. The follow-up did not show reduction of LCBI, but it showed thickening of the fibrous plaque, the fibrous cap of the plaque. So what is important here is to stabilize the plaque. So it helps you detect segments which have got very high lipid content. The bottom line is that when you have a necrotic core, in this necrotic core, if you have lipid, events are going to be there. If there is no lipid in that core, there are going to be no events, even if the plaque ruptures.
Thank you, sir. Ashok, Dr. Ashok Kumar from PMCH to present his CD related to the topics of these sessions. This is the last talk of this session. Thank you.
Yeah, thank you for giving me 2 minutes extra time to show my case. Just a moment, please. ये करूँ आ गया start करो ना. Okay. Actually, this is very interesting because I requested Dr. Ashish to give me 2 minutes only. Just I have to show this case to our august learned audience, because I still failed to explain all the things of this angiogram. So please start my presentation, please.
Meanwhile, Samsad, you want to ask some questions? The time? Okay, just wait. Any? If it is late, then Samsad, you can ask questions to Dr. Chadda.
No, there are no cutoffs. You must understand that LCBI score is meant to stratify this given individual, whether he is at risk of future events or not. The cutoff value is 400, correct? It stops at that. You stent a given vessel based on few characteristics. Number one, you have to have an obstructive lesion. Number two, the MLAs at that site have to be significantly low. Number three, if you're using physiology, that lesion has to be meeting the physiology criteria. Number five, if you are looking at the plaque burden using IVUS, the plaque burden has to be more than 70%. Having said that, LCBI is not used to decide whether you have to stent or not. LCBI is just a predictor of future event. LCBI tells you that there is a plaque buildup here, and whatever the number which you get, if you take 10 out, is the percentage of lipid in that plaque. Higher the lipid content in the plaque, more of the chances of future events. How can we prevent that? We can only prevent that by optimizing medication. In a busy clinical practice, what happens? We put everybody on 40 statin or 80 statin. When they come for follow-up at the end of 2 or 3 months, depending on how busy you are, you alter the prescription. If you're very busy, you say continue all. If you're not very busy, you have some time and the patient requests, oh, there's a big drain in my pocket. You say, okay, make it 20, because you will agree with me, in most of our patients, even with 20 statin, the lipids come down drastically. So this gives you an objective evidence to chase in the OPD, and it also improves the compliance of the patient. You can tell this patient that, please, your scores are very high, you are at risk of future events, please continue your statins. So this is just a kind of a objective assessment of the plaque composition, which is a predictor of MACE at a later date.
Yeah, I will go very quickly. 52-year-old male came with angina on report from last 2 months. Everything was okay except tobacco chewer, and TMT was inconclusive. So I directly took him for angiography. And this is the result. There is significant osteal lesion and some plaque in osteoproximal LAD. Apart from the left system is okay. And you will see in same angio, RCA. RCA is quite normal, but giving some collaterals towards left circulation. So this is my angio. And so I labeled it as osteal 80% and a straightforward referred for CABG / IVUS guided left main PCI. But after 1 week, patient came to us. We want to go for bypass. Then we took him 7 French guiding from femoral root. And this is again the same. So we decided to do first IVUS. And surprisingly, IVUS was normal. And this is the IVUS run. There was some plaque in proximal LAD, but that was not significant. And osteal left main was normal. So then we do manual manipulation and manual IVUS run taken, and that was also normal. This is osteal LAD, and yeah, circumflex. There was some plaque in distal left main, but this is soft and ostea. Is quite normal. So yes, sir. And even after hooking with guiding 7 French, we gave during angiography, we had not given anti. And so we deferred it because luminal area was quite high. And again, we thought that we must have missed something. So we went for CT angiogram, and that was also normal. So there was no lesion, and finally we left the patient. So I want to hear from you. So should every left main ostial patient prior to referring to any surgery, any angioplasty, IVUS is must? Sir, you can see from here. This is our this video, I think. And yeah, this is from guiding. Here also you will appreciate the left main ostial lesion even after giving NTZ. I have not taken right suit from guiding, but this is there. This was there. Pardon? Yeah, there was a 20 millimeter mercury fall of blood pressure, and there was no backflow. So this is my thought-provoking case. Thank you, Ashish, for giving me time. And
Yes, thank you. This session is over now. I request Dr. Ashok to start the next session, inviting chairpersons and the speakers. PK Sahu, sir, you please stay.
yeah, so this is the last session, pre-inauguration, and session is number 5, coronary plaque modification. I would like to request PK Sahu, sir, to stay on the stage. Next, I would like to invite Dr. Viveka Kumar, sir, from Delhi. Next, I would like to invite Dr. Professor Ravi Vishnu Prasad on chair. Dr. Ravi Vishnu Prasad, sir, please. Dr. UC Samal, sir. Dr. Professor UPC Samal, sir. And Dr. BV Bharti, sir, to conduct the session. Thank you. Over to chairperson.
We'll invite Dr. Sahu to speak on imaging in classic calcified lesion, case-based discussion.
Thank you, Chair, Professor Samal, and all the dignitaries on the dais. In fact, this will be imaging in calcified lesions. Now, you see, the first article that was given by Andreas Grunzig, out of the 5 cases, one of these cases was very calcified. So calcification is not a problem that we are facing these days, but it has been since the days of 1978. And what happens when you do not prepare a lesion, you do not know the calcium? This is a problem that happens in stenting calcified lesions. It is underexpanded stent, and then all the problem starts. Now, when I did the IVUS in this OCT in this case, you could see that the middle part of the stent has not expanded. This was basically because our bed preparation was not done. So subsequently, it was very important that when you start dilating this patient, 2 problems can occur. Most importantly, there can be dissection or perforation, and you can have no reflow. But you will have to agree that imaging has made a big change in this. And as I had showed you in my previous talk, whether you use OCT or IVUS, you can know the calcification. And when you use a modality, you can know whether you have done a proper debulking. Now, calcium comes in 3 shapes: concentric, eccentric, and nodular. And it is very important to know how to diagnose severe calcium on IVUS. If the arc is more than 270 degrees, then definitely it is severe. And if it's less than 270 degrees, possibly it is not severe. Then go for the length. The length is also an important predictor. Now, whether superficial or deep, if you get a thin calcium, you'll have reverberations. If there's a thick calcium, there'll be deep acoustic shadowing, like in gallbladder stones you see in this thing. So this is very important. And most importantly, whether you know nodular or non-nodular or eruptive, This is what a nodular or eruptive calcium shows and non-eruptive. You can know whether an eruptive calcium is there or this thing that is non-eruptive calcium is there. This scoring system is known to all of us, but definitely scoring systems changed. Just to take an example, this is from the book or the atlas that we have written. In that you see the calcium score, you give 1 point for the circumferential calcium, more than 360 degrees. You give the length 26 millimeter, 1 point. You give this thing that is vessel size more than 3.50 points, and you give this thing 1 point if the calcified nodule is present. So based on this, the calcium score is 3. So you have to go for an advanced calcium preparation. So this is how IVUS helps in calcium. And OCT follows 3 steps. Number 1 is site, whether it is superficial, it is deep, or it is nodule. Very simple. This is the first step that you do. The second step is whether it is eccentric or concentric. Because it's eccentric, your stent won't expand that side. If it's concentric, even the lumen is large, then you have to start debulking it somehow. Now, there is also scoring. For example, if the length is more than 5, if the diameter is more than 50%, and if the thickness is more than 0.5, then you have to go for an advanced ablation technique. So now this is very well known to us. Let us come to some case examples, just playing with balloons. Now, when do you choose a balloon? So this is a reformed smoker, 62 years, diabetic, dyslipidemic, and you can see there is a tight lesion. And when an OCT was done, it was clearly seen that the OCT showed deep calcium and plus some superficial calcium. So this was the OCT findings. So this states that the deep calcium was not that much, so I can escape only by giving a cutting balloon. And after the cutting balloon, I could just put a NC balloon. And after the NC balloon, put the stent, the result is fine. So imaging helps you in deciding whether the stent has been put to okay and what is the debulking method. Now, in this case, again, I saw that after putting it, there was an area of malapposition. You can see the malapposition and underexpanded stent. So it indicates that I have a lot of things to do, although the angiography was looking very good. And then this was a malapposition that has taken place, and this was under expansion. And then what I did was I had to use, this is the same thing, I don't want to waste time. Then further post dilation with an OPN NC balloon, and after dilating with the OPN NC balloon, you can see how it has expanded well and how the malapposition, the malapposed segment has been well apposed. So pre and post OCT is to be done to know whether you're doing a right job. And definitely angiographically it was looking good, but it was mal-expanded, mal-apposed and under-expanded. So final result, all is well. You can see that everything has expanded well. And the simple thing was that you could know only a balloon would do your technique. You don't have to go for a costly device. Now, balloon uncrossable lesion, for example, this is a case with a strongly positive TMT. It was balloon uncrossable. So as I had sodium tram-track calcium, and here we need to do a rota or an orbital. So rota was done with a 1.5 burr, and after the rota, you can see the OCT images of the rota. That is, we have debulked, but still there is some amount of calcium. Now, if you see what is the effect of rota on IVUS, you see pre-rota, you will not get such a lot of reverberation. Once you do a rota and again do an IVUS, you will see the reverberations, which shows that you have really debulked it. If you do not see these reverberations on IVUS, remember that you have not done a good rota. You go to upsize your burr and you do a rota so that your bias is towards the calcium and you can do a good job. Now, this was again after the rota, the post NC, and this is the post NC results, which shows that we have expanded the lumen, done a good bed preparation, and now finally do a stent and do the pot. And this is the post-pot results where you can see it is fully expanded well and the results are nice. So this is just to show one case. Now coming to nodular debulking, as I showed you 2 images, that is one is a pre-bulking where you can see on IVUS, and this is the post-bulking where you can see the node has been shaved off. This is where IVUS helps you in knowing whether you've done a debulking or not, and accordingly choose your stent size and this length. Now, beyond atherectomy, we know IVL is something which is very good for various subsets, deep calcium and especially SOU calcium, where nodular calcium can be used. And we know there are different types of nodules, the eruptive nodule and the non-eruptive nodule. The non-eruptive nodule has a fibrous cap. The eruptive nodule does not have a fibrous cap, but has a luminal thrombus. Now, when we get ablation for calcium nodules, it may be rota, it may be orbital, it may be ELCA, or maybe IVL. So any of these modalities are there, but you have to be very judicious based on imaging techniques, how to choose what. Or else you can have a combination of rota with IVL, combination of orbital with IVL, or combination of laser with IVL, or even just use a plain high pressure balloon or a cutting balloon. So these are various strategies or multimodalities that you have to use to see that you debulk the calcium properly. For example, let me show this case. This shows a coronary angiogram of, in fact, is a member of the parliament from our state. This gentleman came with ACS, but if you see the right side angio, first I thought it must be a thrombus because he presented with ACS. So it looks something like a thrombus. Then I thought I should get my OCT catheter inside, and this is what I saw. It was a large nodule that was sitting there. So this is a nodule which you see in the second circle that you see. The nodule is quite large, 360 degrees calcium. So this made me feel that, no, I have to use something, a bigger device. Possibly, best thing would have been to use a rota first and then go with an IVL. But because when I did the scoring came to around 2 points. 2 points on arc, 1 point on thickness, and 1 point on length, making it 4. But there was this nodule which you can see at 34 millimeter. You can see there's a big nodule. So what I did was basically first it was wired, then just tried to see whether the NC balloon just tries to give way. But the NC balloon did not give way. There was a waste. So I went directly straight forward with the Shockwave and did a POT PDCA. So this is the Shockwave that has been given. We delivered around, I think, 100 pulses totally. And after delivering the 100 pulses, I tried to see what did the IVL, what did the OCT show. You can see the beautiful cuts that have happened in the calcium. These cuts are very good to see the cracks that shows. And this gives you a confidence that now my stent will expand. And this is what we did. After the IVL, we followed up with an NC balloon with a 3.5 into 15 NC. And after the NC, post-imaging, after IVL and NC, this was again the image pictures. So the expansion was good. And next that we went ahead was to deploy a stent. And we could know the size of the stent, and it was deployed, and the POT was done. After the POT, again, the final imaging was done with this thing that is OCT. Here you can see the third image. You can see the stent has not expanded. It is almost eccentrically expanded. But so long your MLA, the MLA here is 9.21. So once the MLA is good, you need not go on expanding because you might do a rupture over there. So this is how a calcium nodule has to be dealt. You first pass a simple balloon, see how it expands. If it doesn't expand well, then you know it's a nodule. Your imaging will tell you, and then you go ahead with the stent. So this is the pre and the final results, which shows that there was a spot calcium nodule, which could be done well with a lithotripsy balloon. So lithotripsy has to be used basically when you have a concentric calcium, where you have to debulk, or if your stent is underexpanded. But do not use an IVL if you have recently stented it, because the drug will the stent will get spoiled. Or else if there is peri-stent calcium is there. So these are certain issues that it is to be used. And that is certain myths regarding IVL in nodule. But the myth is that atherectomy is the ideal tool for modifying nodular calcium. You do a rota or an IVL, but the bias is very important. But clinical evidence says that you can safely do with an IVL, as I did in this case. And these cracks can be very well visualized, as I had shown in my previous talk, and the expansion is well. So how to approach a calcium lesion? Number one, meticulous analysis of your IVUS or OCT image is essential before planning strategy. Study your images properly. There's no hurry. Don't be biased by the angio. And basically, once you have a calcific lesion, do a calcium scoring. I agree, it is not always easy to do a calcium scoring, but overall you can have an idea and then choose your device to bulk. Don't make the patients pay much, because spend on the this thing that is your imaging, and that gives you a result. Now, when you don't do an imaging, it literally leads to a disaster like the Titanic. It doesn't know that it had to strike a big rock so that it finally had problems. So intravascular imaging helps in managing calcified lesions in a very calculated manner, and safety is there, and finally to get to good results. Thank you very much for the patient hearing.
Thank you, Dr. Sahu, sir, for his excellent talk. Any questions, any queries from the floor? It will be discussed at the end of the session. Thank you, sir. The next master speaker is Dr. Viveka Kumar from Delhi. He is the senior interventional cardiologist and also the vice chairman and the chief of cath lab, Max Hospital, Delhi. Over to sir.
Well, so my job has been made quite easy by Dr. Sahu, that, how to tackle the calcium. So we need to look at what are the things which are available. So everybody in their cath lab would have different tools available to them, and we'll touch upon them one by one, that what are the tools and which is suitable for particular given case. As Dr. Sahu has already told that, there are certain things, different kind of calcium. So they come into various, thickness, length, depth, and eccentricity. So the calcium could be nodular, could be adventitial. It is within the calcium which is much more problematic. So the more within the lumen, within endothelial, the calcium is going to cause problem. This has already been discussed, that severity of the calcium has to be assessed well. So that is why managing the calcium, we need to be really, really very good in imaging. We need to know what is happening and what is the extent of calcium. So we can do with either IVUS or NIRS IVUS, or we could do with the OCT. And we need to classify whether the calcium is really deep, it is circumferential, less than 270 degree of arc, and then whether the nodular calcium is there or not, because they all need different tools. So if you look at the complication of treating calcified lesion, this falls one of the most complex category of interventions, and there are a lot of complications happening because of this. The basic reason is that if lower success rates, a lot of things which is peripherally, if you do not have access to rota or orbital, the patients have to be referred for surgery, or they need to be sent to centers where these tools are available. And they also may damage, what Dr. Sahu said, that the polymer coating of the stent. So long-term outcomes, so acute and chronic outcomes of the stent is also not good in the given case. And then what are the complications? So you can see that the patients where the calcifications are high, we have data from Horizon AMI and acute cardiac calcium, and there all the hard endpoints like death, cardiac death, myocardial infarction, target lesion, revascularization, MACE. You can see this red bar is the severe. The severe the calcifications, the worse the outcomes. Almost 20%. So every 5 patients, 1 patient out of your 5 would go to have a repeat intervention if we have not tackled the calcium well. So let's look at the things in our armamentarium. What are the things which are available? We can go with the common, our workhorse balloon, which is balloon-based devices, so what we call a specialty balloon. So we don't have to, we can go to the non-compliant balloon, high pressure NC balloon, and open balloons, which are really go up to 39 to 40 atmospheres and can crack the calcium. We can use the cutting balloons. So cutting balloon has resurfaced, and that has done the job in many situations, and a scoring balloon on the same principle, which has got a more fibrous attached on the balloon. Then we have got atherectomy device. So one place where, we call it non-crossable lesions, where the rotational atherectomy and orbital would go do the trick. And then we have got the laser. And then a new tool, which is not so new, but now, which is a, bailout, and bails are out, and it is a specialty balloon to its core. It's called intravascular lithotripsy. So these are the things which are available to us, and we can use them. Non-compliant balloon is our now regular stuff, and imaging can guide us that which tool should be used. So you don't have to struggle and waste a lot of balloons, balloon ruptures, and all those things. If we have the data from the imaging, we can really, find out that whether high pressure balloon can do that job or not. So NC balloon would do the job where you do not have more than 270 degree of calcium, and this situation, it will be really helpful. Cutting balloon again does the job by cutting in different corners. So they have got 3 blades, and this is much more superior. In fact, many a times you need cutting balloon post atherectomy also. The post, we have got rota cut data where it had shown that the outcomes are much better. The scoring balloon is similar principle what we have got with the cutting balloon, but it has got non-blade things, which is a much more fibrous thing. So the trackability of these balloons are much better. So in tortuous things, it can go quite easily. When you look at the rotablation, this is something which is still, despite the availability of orbital, many cases where the orbital may not go in non-crossable lesions, very heavily calcified lesions, the rotational atherectomy is the savior. And this is something which is there for quite some time, very old device, but definitely still with good modification, it is doing our job. And then we have got orbital atherectomy. Now it is available to us and we are doing it on a regular basis. The advantage is that one size fits all, rather than like an rotablation where you have to upsize from 1.25 to 1.5, 1.75 and 2. So this here, it becomes much better because it wobbles, eccentric head wobbles, and it can even modify the adventitial calcium also, something what we do with the IVL balloons. Then we have got now access in our lab to the laser atherectomy also. So it uses pulse wave ultraviolet laser catheter that is effective in treatment the long calcified lesions, even in patients who have got the calcium non-crossable kind of thing also there it can be used. And it is 3 methods it does: tissue ablation by photochemical, photothermal, and photomechanical. So however, the laser atherectomy is highly expensive tool, so it adds a couple of lakh rupees extra to our patient's pocket, which is already burdened so much. And then, as it has been shown, is the lithotripsy. So it works on a sound wave where it breaks the calcium. So when we do the imaging, you can clearly see the cuts. And the beauty is that sometimes if you have not, if you have a stented and stent is under expanded, there post stenting also it can be used, but it probably could remove the drugs coated on the balloon. So IVL shock wave is something which is ideal, and it is. So there are many cases which we had received initially when the IVL was available in a limited places, limited centers, that people had done rotablation in periphery, and artery was quite big, almost 4 millimeter, and they could not put the stent because this calcium did not break. 360 degree of calcium arc was there. We did the IVL, good expansion, and this is the tool which is very simple to use, just like an balloon, and you deliver the therapy through this. Now with this, you can easily open all the lesions. So definitely with the availability of these tools, we have now access to. So in our lab, fortunately, we have got all the tools available, but you may not have always availability to. So it is a growing problem in our intervention now because the population is aging and more people are living for older age. And as the age increases, you would get more and more people coming with the heavily calcified lesion. So, complications, it has to be looked at in pre-PCI situation, because if you are trying a balloon and calcific part does not open, so in pre-PCI there is the risk of difficulty in complete balloon dilatation. It can cause a stent delivery problem would be there, and dissection is a big problem because the place where you want to expand may not expand, and then the calcific area might dissect, and long dissections have been seen, especially if the balloon ruptures. The jet of the contrast which is there in the balloon can dissect the whole artery, patient may collapse. And then even if you have put the stent, the expansion and penetration of the stent is not great. So this is again, if we look at the case, so this is a patient who had a heavily calcified right and the left system, and there, we have to, even on fluoroscopy, you can see that the patient had significant amount of calcification. So the imaging would be very important because it helps in pre-intervention of interventional sizing, lesion morphology, significance of the lesion, apposition during the intervention, apposition of the stent, post-dilatation, geographic miss and dissection, and post-stent also it is important. We should not finish with the post-stenting. So when we are doing the imaging, we need to be doing all the things properly. Pre-intervention, we must do it. The peri-intervention and post-intervention to look at the treatment strategy and the complication. And this has already been discussed, at how to assess the calcification. There are different score we can go by, whether the patient has got,
360-degree calcification, whether the nodule is there or not. And then the correlation between the angiography and IOS, you can clearly see that on conventional angiography, how much we miss. And when you do the OCT, again, you find the similar thing. So thin calcium and thick calcium also we need to look at, and then the calcified nodules also has to be looked at. So what we do is that we need to strategize our plan on treating these patients. So when we choose the non-crossable lesion, we have got two armamentarium, Rota ablation, what we call, now we have got access to what we call Rota Pro, much easier to use, much more sleeker. And then we have got orbital, which is CSI Diamondback. So this is a, crown oscillates in orbit path. Lumen size could be, here we need to go very slow. So the slow flow is lesser because you create a very small particle in the vessel, whereas in rotablation, the diamond cuts in a bigger size particle. So the slow flow, no flow is much more commoner. But this is something which is go to the tool device in patients where it is non-crossable lesion. Again, the advantage of this is that the rotablation scores in non-crossable lesion because of the front cutting, whereas the Diamondback has a circumferential cutting. So sometimes this proximal part may not cross at all, but definitely the outcomes are equally good. If then we can polish the lesion with the cutting or scoring balloon to get a more size, and after that, so in situations where we have got calcium in ostial place or very fibrotic or in small places, we should try and use these scoring and cutting balloons. And how does it work? You can see that the mechanism, it creates some cuts there, and that is why it is so popular, and we use it in drug balloon technology. So you create a spaces where the drug would adhere and would cause much more effective outcome in these situations. Wolverine or cutting balloon has got, it would create cuts in different places at the angles where the blades are, and it can modify. So even after the, atherectomy devices. So we have got now practice of what we call rota cut. So you do the rotational atherectomy and then do the cutting balloon. So lumen gain is much more. And even you have data for more than 9 months, that is the imaging based data that shows that the outcomes are much better. See, the endpoints are much better and the lumen gain is much more effective. And then rota cut, this trial also had shown that the calcium fracture and stent expansion is much more robust when you combine these technologies. So I'll show you one case where this is a patient who had a severely calcified bifurcation. You can see LED diagonal. We had to do first, debulk it, and then because nothing was going, then we did the imaging. You can see there is a heavy burden of calcium, almost 360-degree arc of calcium extending right up to the left main. So you need to have a good strategy for that. You did the ballooning. After that, we did, NC balloon, high pressure NC balloon, plaque modification. And you can see that the post cut, there was a expansion, the lumen gain was much better. So you never should venture putting a stent unless you have got full 1-to-1 expansion. So once this expansion was done, we tried to put a stent, and then post stent, we could see that the stent MS there was good and the stent expansion was good. So once that is achieved, otherwise you can again go and do a robust post dilatation to achieve the maximum stent expansion and the apposition. And once that is there, then you can be satisfied that, okay, this is a good result. So and we have got long follow-up and the patient is doing fair. This is again another patient, very difficult surgical refuse, and because of the poor lung condition. And here, even to track the wire was very difficult. So we did halfway, the wire was kept, and we did an imaging. You can see extensive calcium right up to there. And then we had to do a rotational atherectomy. So we did a polishing right up to the mid distal LAD, 1.25 millimeter burr, and then upsize the burr. And again, so with the rota, you have to upsize the burr. But this is the problem which is commonly we face, that there is a no flow in a LAD, which is a big LAD. So we had to push a lot of vasodilators in distal bed. And after that, we put the stent, and you can see post stent, we got a good lumen. And then the patient had good TIMI flow, and long-term outcome is also quite good. So tortuous calcific lesions are again very, very difficult in these situations. So in the interest of time, I'll go to the last slide. So the conclusion is that, ladies and gentlemen, that the The coronary calcium is something which is an Achilles heel of interventional cardiologists. The coronary calcification represents a major challenge associated with adverse outcomes after PCI. To avoid the stent failure, optimal plaque preparation with whatever tool is suitable based on the algorithm should be done. Intracoronary imaging and determination of coronary calcification, severity and characteristic are the keys to the guiding further treatment decisions, and the decision relating to which modification technique to be used is based on the numerous anatomical and technical factors, including the location of the lesion, the concentricity of the calcium pool, operator's familiarity, expertise, and local device availability. Because if the device is there and you're not familiar with that particular device, you should not use it, because that is going to do more complication than good to the patient. So thank you very much for your kind attention. If there is any question, I'll be more than happy to answer that.
Thank you, Dr. Viveka, for crisp and clear presentation of how to manage the calcified lesion. The question and answer will be after the end of session, sir. The next speaker is Dr. Ashok.
Next speaker is Dr. Ashok Kumar. He is the associate professor at PMCH and also the consultant cardiologist at SDNA Patna. And he will show his case. Over to Dr. Ashok.
First of all, my apology. I just forget to call the chairperson of this session, Dr. Neeraj. Please, Dr. Neeraj, sir. Yeah. So now coming to my case proper. I have followed the principle of Dr. P.K. Sahu, sir, and used some armamentarium from Dr. Viveka, sir, to do my case. So this is 61-year-old male, known case of calcified TVD, and came from some other center to us with recent anasthenia, having diabetic, hypertensive, non-alcoholic, but tobacco chewer. He was advised CABG, hemodynamically stable, troponin was positive, echo was normal, syntax score was 27. So we took the patient for angioplasty, and artery was heavily calcified. So we see first the angiogram. This is the right system and this one is the left system. You can appreciate heavy calcification, tram track like, and tightest part in mid LAD. So first we decided to do RCA. We did IVUS run. And in distal part, there was not much calcification, but mid and proximal part, there was heavy calcification. And the calcification was maximum about 270 degree in proximal and mid part. So you can see this calcification. Yeah. So that was heavy calcification in mid part. So we decided to do a cutting balloon. As Viveka sir has rightly said, we use a Wolverine 3x15 mm to cut this calcium. Multiple times we cutted it. And after cutting, tried to negotiate the stent, but that was difficult and failed to negotiate the stent even after taking body wire. So we took the help of guideliner and a distal stent 2.5 into 32 drug-eluting stent, and proximally 3.5 into 48 mm deployed, followed by this was pretty good result. Then distal, there was a narrowing, so we post-dilated with 2.75 into 12 mm NC. Then again took IVUS run, but in mid part, there was maleposition under expansion of a stent. So we took 4 into 12 mm NC and again did post-dilatation over here in mid part. And this was the final result of RCA. Sorry. Then coming to the left system. First, we tried to negotiate IVUS, but failed to negotiate IVUS. Then we exchanged directly with support of microcatheter to rota wire and did take the 3 cycle of rota run with 1.5 bud. And after that, there was good result. But even though in mid LED, there was concentric calcification that has been seen in IVUS, and the calcification was 360 degree. So here we decided to take IVL, and we did IVL 3 into 12, 4 cycle, each of 10 pulse. And then we did from mid part to ostial, and there was good landing zone in ostial part. Then finally took drug-eluting stent 3 into 38 from ostia, deployed it, and then post dilated with 3.5 into 12 NC. Good apposition and decent result. Even apposition was good. So this is final result. Thank you.
Dr. Ashok, you have done all the calcium oddities in this case. Yes. Any
Thank you,
comments,
sir.
Any queries? Now over to next speaker. Next speaker is Dr. Vikas Kumar from Fort Patna. He will show his case. The topic is rota cut in tortuous RCA.
Good afternoon, all dignitaries. Myself, Dr. Vikas from Ford Hospital, Patna. I feel very privileged here, standing. We done a case in Ford Hospital in a tortuous RCA vessels rota cut. Now starting with the case. Patient 57-year-old, non-diabetic, non-hypertensive, admitted with the recurrent chest pain, and on investigation found TROP-T was negative, echo was normal, echo was the normal, ECG showed inferior leads, T-wave inversion in the inferior leads. On angiography, we saw the double vessel disease. There is a 60% lesion in the LED mid part. Left main and LCX show the normal. RCA show the proximal and mid part significant disease. We planned PTCA to RCA. On attempting the PTCA to RCA from the radial route, however, due to the calcium and tortuosity, we were unable to cross the lesion. We were unable to cross the lesion with the non-cutting balloon. Even after the distal balloon anchor, the guideliner was unable to cross the proximal bend. This is the slide. We saw the proximal and mid part significant disease. This is the video. This is the second video. So we changed the guide catheter from JR to AL, distal balloon anchor and the guide liner, but we again failed. Then we planned next rota ablation in the next setting. As we don't have the rota in the cath lab at that time, after 2 to 3 days, again we take the case in the cath lab for the rota ablation. The rota ablation from the right femoral axis, burst size is 1.5 The guide catheter was the JR. Sequentially, pre-dilatation was done with the Wolverine cutting balloon, which is 3.5 into 10, and the non-cutting balloon 3.5 into 8 with the guide liner support. This is the video. This is the rota videos. Then we put the stent, the size 432 and 420 were deployed from mid part to ostium. As while deploying the proximal stent, there was a slow flow in the whole system. On close observation, we saw that there is a dissection in the mid part of the stent. Then on the dissection side, there again, we deployed the stent in the distal part. The stent size is 0.5 into 38, and the final result is that. Thank you. And the real hero behind all this is Dr. B.V. Bharti sir and Dr. Sushant Pathak sir.
Thank you, Dr. Vikas. I think now it is open for the audience for any interaction. If not, let us conclude the session.
Now it's time for the inauguration ceremony, just for 15 minutes, followed by lunch. So I request Dr. Sanjeev Kumar, Mr. Darvesh Jha, please arrange quickly for the inaugurations. Prepare the stage, guys.
वाह, अरेंजमेंट हो गया। वह क्या बात है। जेठ की इस तपती दोपहरिया में आयोजकों ने कार्डियक साइंस के नवीनतम ज्ञानों से ठंडी बयारों का क्या शीतल, खुशनुमा और स्फूर्तिदायक वातावरण तैयार किया है। इस शैक्षणिक समागम में CSI बिहार चैप्टर के बिहार इंटरवेंशनल काउंसिल 2025 की तरफ से मैं डॉक्टर संजीव कुमार आप सब डेलीगेट्स, फैकल्टी और अतिथियों का दिल से स्वागत करता हूं। पिछले कई दशकों में मेडिकल साइंस में खासकर कार्डियोलॉजी एक ऐसी विधा है जिसने तकनीकी दृष्टि से अभूतपूर्व तरक्की की है और इंटरवेंशन हृदय रोगों के इलाज का आधार स्तंभ हुआ है। तो 3 साल पहले CSI बिहार चैप्टर ने यह निर्णय लिया कि इंटरवेंशन की भी हम अलग से काउंसिल करेंगे और इसी के तहत आज बिहार इंटरवेंशनल काउंसिल का ये 3रा वार्षिक अधिवेशन है और इंटरवेंशनल काउंसिल को इस स्तर तक लाने में जिन कार्डियोलॉजिस्ट और इंटरवेंशनल कार्डियोलॉजिस्ट और कार्डियोलॉजिस्ट का कार्डियक सर्जन्स का रहा है, उसमें से कुछ को मैं अभी आमंत्रित करूंगा स्टेज पे। हमारे पास सीनियर और पूजनीय हैं और कुछ जो सामने बैठे हैं, इन सबों की तरफ से ठीक है। तो सबसे पहले मैं
आमंत्रित करता हूं आज के चीफ गेस्ट डॉक्टर प्रोफेसर यूसी सामल, जो कि वरिष्ठतम कार्डियोलॉजिस्ट के रूप में अभी हमारे प्रदेश में हैं। पटना मेडिकल कॉलेज और नालंदा मेडिकल कॉलेज में प्रोफेसर एंड हेड ऑफ द डिपार्टमेंट मेडिसिन और कार्डियोलॉजी के रह चुके हैं। सर इस सूबे में एक जाने माने विशेषज्ञ फिजिशियन हैं। इनका लाइफ है कि एक छोटे से गांव में उड़ीसा में अपनी स्कूली पढ़ाई शुरू करने के बाद इतने ऊंचे स्तर तक पहुंचे अपनी प्रतिभा, अपनी क्षमता और अपने व्यक्तित्व के कारण। तो सर आज की इस कार्यक्रम में चीफ गेस्ट के रूप में आपको पाकर हम भावविवल हैं। अब मैं अपने गेस्ट ऑफ ऑनर को इनवाइट करूंगा, डॉक्टर सुनील कुमार, निदेशक डायरेक्टर इंदिरा गांधी इंस्टीट्यूट ऑफ कार्डियोलॉजी। डॉक्टर सुनील कुमार सर। नेक्स्ट डॉक्टर बीपी सिंह, जो एक्स प्रोफेसर और एचओडी रहे हैं इंदिरा गांधी इंस्टीट्यूट ऑफ मेडिकल साइंसेज पटना के, और बिहार सीएसआई के पास्ट प्रेसिडेंट्स भी हैं। एग्जीक्यूटिव कमेटी में रह चुके हैं नेशनल सीएसआई में, और इस सीएसआई के वाइस प्रेसिडेंट भी हैं नेशनल। सर ने आईजेएमएस में कार्डियोलॉजी और इंटरनेशनल कार्डियोलॉजी को स्थापित कर आज देश के एक ऊंचे संस्थान के रूप में पुरस्कृत किया है। उसके बाद मैं दूसरे गेस्ट ऑफ ऑनर को इनवाइट करूंगा, डॉक्टर एस चटर्जी। ये भी वाइस प्रेसिडेंट हैं सीएसआई बिहार में। अगर किसी कार्डियोलॉजिस्ट का बहुत श्रद्धा और इज्जत से नाम लिया जाता है इस प्रदेश में तो डॉक्टर एस चटर्जी हैं। लोग इनके पास आने को, इनसे सीखने को, इनके सानिध्य में आने को अपना एक सौभाग्य मानते हैं। और अब मैं आए कुछ नेशनल सीएसआई के वरिष्ठ सदस्य, डॉक्टर एम.के. दास कलकत्ता से आए हैं, पास्ट प्रेसिडेंट सीएसआई नेशनल। आपको भी इनवाइट करूंगा सर कि आप स्टेज पर आएँ। इनका लेक्चर भी सवेरे हम लोगों ने सुना। और दूसरे वरिष्ठ हृदय रोग विशेषज्ञ दिल्ली से आए डॉक्टर विजय त्रेहान। डॉक्टर विजय त्रेहान सर, अगर आप यहाँ हैं तो प्लीज़ स्टेज पर आएँ। डॉक्टर भारती, डॉक्टर विजय त्रेहान को बुलाइए। डॉक्टर भारती का डॉक्टर विजय त्रेहान से बहुत सानिध्य रहा है, साथ में उन्होंने काम किया है। उसके बाद में चेयरमैन साइंटिफिक कमेटी अभी बिहार इंटरनेशनल काउंसिल के डॉक्टर रवि विष्णु प्रसाद, चेयरमैन साइंटिफिक कमेटी, प्रोफेसर एंड एचओडी आईजीआईएमएस के कार्डियोलॉजी विभाग के पटना में डॉक्टर विष्णु अभी एडिटर भी हैं बिहार जर्नल ऑफ कार्डियोलॉजी के। उसके बाद मैं बुलाऊंगा प्रेसिडेंट सीएसआई बिहार, नन अदर देन डॉक्टर के बरुण, द डायनेमिक लीडर ऑफ सीएसआई, डॉक्टर के बरुण, एडिशनल डायरेक्टर आईजीआईसी पटना। सर अभी थे यहाँ डॉक्टर के बरुण। डॉक्टर एन सिंह जरा इनको बुलाइए ना। उसके बाद मैं बुलाऊंगा अभी चेयरमैन ऑर्गेनाइजिंग कमेटी डॉक्टर अरविंद कुमार, जो आधार स्तंभ हैं इस ऑर्गेनाइजेशन के, अभी मेरे सहयोग में खड़े थे, आप ग्रहण करें स्थान। उसके बाद सेक्रेटरी सीएसआई बिहार डॉक्टर उपेंद्र नारायण सिंह, पटना मेडिकल कॉलेज में कार्डियोलॉजी के विभाग अध्यक्ष हैं। यंग, डायनेमिक, एवर इंथुसियास्टिक, और हर काम, हर आयोजन, मरीज के ट्रीटमेंट से लेके कॉन्फ्रेंस तक सब करने को तत्पर रहते हैं। और अब मेरी आवाज़ है द डायनेमिक सेक्रेटरी, ऑर्गेनाइजिंग सेक्रेटरी डॉक्टर आशीष कुमार झा। तालियों गड़गड़ाहट से इनका स्वागत किया जाए कि आज जो हम लोग यहाँ पर हैं, जो आज इतनी ज्ञान की गंगा बह रही है, इन्हीं कंधों की बदौलत, मजबूत कंधों की बदौलत बही है। और अब सर के बोलूँ सर आप, और मेरी आवाज़ डॉक्टर और सीएसआई के पूर्व प्रेसिडेंट, पटना मेडिकल कॉलेज के पूर्व विभाग अध्यक्ष के डॉक्टर बीपी सिन्हा सर। डॉक्टर बीपी सिन्हा साहब आप यहाँ आए तो चले आइए। और अब मैं आवाज दे रहा हूं अपने पुराने मित्र, हमारे जूनियर रह रहे हैं लेकिन क्षमता में, प्रतिभा में हमसे काफी बड़े, और इस प्रदेश की कोहिनूर हैं कार्डियोलॉजी में, डॉक्टर आर डी यादव, जो दिल्ली से हैं। आप इस धरती के लाल हैं, देश में कार्डियोलॉजी में बिहार का नाम रोशन कर रहे हैं। आप यहाँ बैठे त्रेहांस सर। तो अब इनॉग्रेशन सेशन को आगे बढ़ाते हुए मैं सबसे पहले चेयरमैन ऑर्गेनाइजिंग कमेटी और पास्ट प्रेसिडेंट CCI बिहार डॉक्टर अरविंद कुमार से उनके स्वागत भाषण देने के लिए आमंत्रित करता हूं।
थैंक यू संजीव, बहुत अच्छे से आपने संचालन किया मंच का। So I'm extremely privileged and delighted to welcome you all, especially the legendary of cardiology on the dais, Professor UC Samal, Dr. SS Chatterjee sir, Dr. MK Das, past president CSI, National CSI, Dr. विजय तेहान सर, जो कि इंटरवेंशन कार्डियोलॉजी में इनोवेटर हैं पूरे वर्ल्ड में, डॉक्टर आर डी यादव सन ऑफ सॉइल, प्रेसिडेंट के वरुण, सेक्रेटरी UN सिंह, एक्स HOD PMCH डॉक्टर वीरेंद्र प्रसाद सिन्हा, डॉक्टर BP सिंह सर, मेरे बड़े भाई हैं गुरुदेव, डॉक्टर आशीष झा, डॉक्टर रवि विष्णु, एंड ऑल guest speakers coming from nations and abroad, all CD presenters, all delegates, fellow delegates, and कैश लैब के जितने टेक्नीशियन एंड स्टाफ सिस्टर सब लोग हैं, सबका मैं स्वागत करता हूं, मोस्ट वेलकम। एंड आई कॉन्ग्रेचुलेट डॉक्टर आशीष कुमार झा स्पेशली, who has organized this conference in such a wonderful manner. So this will help in the growth of intervention cardiology in Bihar. This is the third annual conference after the success of 2 conferences in the past. This is wonderful conference, and all of you have learned. You have already witnessed first half, what a beautiful scientific program he has made. And I trust me, and I hope the second half will be more interesting, more informative, more interactive. With these words, I end here. I again thanks you all for coming here, being a part. Next.
अब मैं आयोजन समिति की तरफ से आप सभी महानुभावों का पुष्पगुच्छ देकर सम्मानित करना चाहूंगा। तो वॉलंटियर से अनुरोध है भी विशिष्ट जनों का बारी बारी से से स्टार्ट कीजिए डॉक्टर जी। अब मैं मुख्य अतिथि, विशिष्ट अतिथिगण और सभी सम्मानित सदस्य जो यहाँ पर उपस्थित हैं, सबसे अनुरोध करूंगा कि माँ देवी का आह्वान करते हुए इस पर उनकी कृपा बरसी रहे, दीप जलाकर कार्यक्रम का उद्घाटन करें। डॉक्टर UC सामल सर, डॉक्टर BP सिंह सर, डॉक्टर SS चटर्जी सर, डॉक्टर MK दास सर, डॉक्टर विजय त्रेहान सर, डॉक्टर RD यादव और सब हमारे ऑर्गेनाइजिंग समिति के सदस्य।
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्म विचारसार परमां आद्यां जगद्व्यापिनीम्
अब कार्यक्रम की औपचारिक शुरुआत के साथ, जैसा कि हम सभी जानते हैं, पिछले 19th सेंचुरी के लास्ट दशक में पटना में इंटरवेंशनल कार्डियक और कार्डियक सर्जरी की शुरुआत हुई थी। जीवक हार्ट हॉस्पिटल में पहली बार, और उसके बाद सरकारी क्षेत्र में IGIC में, उसके बाद कई हॉस्पिटल्स ने, मगध हॉस्पिटल, उसके बाद फोर्ड हॉस्पिटल, रूपन हॉस्पिटल के साथ कई हॉस्पिटलों ने शुरुआत की। सरकारी क्षेत्रों में 4 हॉस्पिटल्स में आज हो रहे हैं। तो इन सब का लेखा जोखा शॉर्ट में हमें बताएंगे चेयरमैन साइंटिफिक कमेटी डॉक्टर रवि विष्णु प्रसाद। द BIC डाटा प्रेजेंटेशन बाय डॉक्टर रवि विष्णु प्रसाद।
जरा वहां से ऑन कीजिए, मूव हो रहा है, मूव कीजिए और मूव करके देखिए।
Good afternoon. It is great privilege for me to present the first BIC data 2025. The journey of modern intervention in cardiology was really started in 1998 when the Jeevak Hospital, Kankanbagh established the first cath lab and the first heart-lung machine. And the first angioplasty was done by Dr. Pramod Kumar sir, and also the first BMB and the first bypass by Dr. Ajit Pradhan. Previously, before 98, there was also the cath lab in the IGIC, but it was not with the image intensifier. So in 2000, the Indira Gandhi Institute of Cardiology, the cath lab was installed. This was first in the government sector, and subsequently every year there one cath lab was there. From 2004, Heart Hospital, 2012, even in the periphery, the Bhagalpur has the first cath lab, Ruban 2014, and 2015, the Indira Gandhi Institute of Medical Sciences have cath lab, and subsequently 2018 and 2025, it has also the second and third cath labs. And 2018, the AIIMS Patna, the Foray Hospital, and the last, the big Apollo Hospital, the cath lab was installed. This was the Patna data. In the centers outside the Patna, that around 28 cath labs are there till now. And from Patna, it is every district has a cath lab. So the centers which are performing the interventions are nearly 50. In the Patna, it is 22, and outside Patna, it is 28. And there are 5 government centers which have a cath lab, IGIC, IGMS, AIIMS Patna, PMCH, Railway Hospital, and the 12, and they have all, and that out of which the 12 have the well-equipped CTVS centers. If you see this chart, from 98 to 2015, there was 1 cath lab every year, and there was sudden rise in 2020 to 25. Every year from 2020 to 25, there were 10 cath labs in our state. Recent cath lab was installed in the January 2025 in IGMS, which is the biplane cath lab with a state-of-art cath lab with inbuilt OCT, IVUS, and EP system. Also, if you see the exponential rise in the, there was exponential rise in the DNB cardiologists, and around total 120 to 125 DNB cardiologists are there in our state. In early 1990, there were only 5 cardiologists were there, and by the end of there were 10 cardiologists. And you see this bar diagram from 2020 to till now, there is an exponential rise of DM cardiologists from around 50. Also, we have DNB courses which are started from IGMS. The 3 DM candidate seats are there from 2019, and 3 batches have been completed. And next year it will be raised to the 5 seats. AIIMS Patna has 2 DM seats, while the IGIC, PMCs, and Ford have the DNB super specialty seats. Now coming to the BIC data, the data are collected from the 15 centers out of the 50. If you see the last from January 2024 to this 25, January to 25, the total coronary angiogram has been done so far is that 20,000, while the total angioplasty is around 7,500, and the primary angioplasty is around 1,500. And the rescue angioplasty done in 227 patients, and use of thrombosuction is around 321 patients. Now coming to the complex cases, the left main is around 200, bifurcation is around 300, and CTO 300 cases. And if you see the data, the imaging either in the form of IVUS, OCT, or FFR, it is quite significant. It is around 600. ROTA is used in 19, ROTA orbital or IVL is used in the 97 cases, and the IVP is used in the most of the cases in 40 cases, and Impella is used in the 2 cases. And most interesting, the DCB, the drug coating balloon, is used in around 700 cases. Now coming to the BMB, around 300 patients were treated with the BMB. Peripheral angioplasty is 40 patients, aortic intervention 5, and the tower was 2. Congenital interventions in either ASD, PDA, VSD, RSOV, BAV, BPV, around 150 patients. Coming to the pacemakers, the total single and double PGR is around 2,000, while the conduction system pacing was done in last year around 125 patients. And leadless pacing was done in 2 cases. ICD around 85 were implanted, and the CRT 52 cases. So this is the first in kind of the data that we have shown the encouraging results. Data from all the centers are required. Thank you.
थैंक यू डॉक्टर रवि विष्णु। तो इस तरह से हमने सफ़र देखा, 2 सेंटर से शुरू हुए पटना में कार्डियोलॉजी का सफ़र आज शतक सेंचुरी पार कर चुका है कार्डियोलॉजिस्ट के नंबर को अगर हम देखें तो बिहार पटना में, और दर्जनों से ज़्यादा कार्डियक सर्जरी सेंटर हैं और 40 के लगभग जैसा इन्होंने दिखाया कैथ लैब सेंटर हैं। तो अब मैं सेक्रेटरी CSI बिहार डॉक्टर उपेंद्र नारायण सिंह से अनुरोध करूंगा कि अपना वो सेक्रेटरियल भाषण दें।
Respected dignitary on the dais, off the dais, all the delegates, and all speakers, presenters who came, took the pain to come different part of the country and the different part of the state of Bihar, and some international speaker also. So thank you all for making this conference a great success. Dr. Professor Ravi Vishnu Prasad just presented the data on the interventional cardiology, so how our state is progressing in interventional cardiology. We have rose from the scratch, and now we have great increase in the volume of interventional cardiology. We are have a cath lab in almost all the district of the different part of Bihar. As a CSI, also conducting some educational activities, regular CME programs in the different part of Patna and also in periphery also. And we are also doing some research activity, some registry on the heart failure and acute coronary interventions. Thank you all.
थैंक यू डायनामिक सेक्रेटरी सीएसआई बिहार। और अब हमारे बीच उपस्थित हैं सीएसआई के नेशनल पास्ट प्रेसिडेंट डॉक्टर एम.के. दास सर, जो इंटरवेंशनल कार्डियोलॉजिस्ट हैं कोलकाता के। मैं आपसे अनुरोध करूंगा कि आप कुछ आशीर्वचन दें।
Good afternoon and namaskar to all the dignitaries on the dais and off the dais, and also who are present today and yesterday. Really, I am congratulating from the core of my heart to the Bihar Interventional Council for organizing this magnitude of fantastic scientific works in the form of the interventional meeting. Really, I give a big round of applause, and I also request everyone through the Bihar Interventional Council Organizing Committee. Having said this, from the CSI point of view, I'm really happy to see the exponential growth of the organizational side of Bihar Cardiological Society of India branch. And like the exponential curve of the interventional procedures that are being carried out throughout the state of Bihar. So Bihar is going in the right direction, and it's now very much in a claiming position to claim for the national meeting, either interventional meeting or other meetings, and I'll be with them for their claim. With these few words, I congratulate everyone once again, and thank you very much for a very, very successful conference. Thank you all.
थैंक यू सर। सर का फ्लाइट है, अभी इनको जाना है, इसलिए इनका पहले किया। अब मैं बुला रहा हूँ हमें नेतृत्व प्रदान करने वाले डॉक्टर के बरून, सीनियर कार्डियोलॉजिस्ट एंड एट प्रेजेंट प्रेसिडेंट सीएसआई बिहार चैप्टर। आप आके इस कॉन्फ्रेंस को अपना आशीर्वचन दें।
गुड आफ्टरनून एवरीबॉडी। कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया के इस तत्वावधान में ये तो इंटरवेंशन काउंसिल जो है विशेषज्ञों का सम्मेलन में देश विदेश राज्य और राज्य के बाहर से आने वाले सभी विद्वान चिकित्सकों का हार्दिक स्वागत है। पहले बिहार में डीएम कार्डियोलॉजी धारक बहुत कम होते थे, लेकिन आज स्थिति ये है कि डीएम कार्डियोलॉजी धारकों की संख्या केवल डिग्री धारक नहीं, कार्य करने वाले अनुभवी चिकित्सकों की संख्या बहुत अधिक है। आज बिहार में कैथ लैब बहुत ही खुल गए हैं, पर्याप्त मात्रा में खुल गए हैं, और ये बिहार इंटरवेंशन काउंसिल का जो कॉन्फ्रेंस है, सम्मेलन है, ये बहुत ही सक्सेसफुल ढंग से हो रहा है। और मुझे लग रहा है कि यहाँ जो आए हुए हमारे बिहार के विशेषज्ञ चिकित्सक आदान प्रदान जो कर रहे हैं वो काफी सराहनीय है, काफी लाभवर्धक है। अब मैं सभी लोगों से यही अनुरोध करूंगा कि अब नेशनल इंटरवेंशन काउंसिल के लिए प्रयास करें। हमारे एम.के. दास साहब आए हुए हैं, अरविंद जी भी हैं, बीवी भारती जी भी हैं, सभी लोग प्रयास करें ताकि यहाँ के विशेषज्ञ चिकित्सकों के द्वारा नेशनल इंटरवेंशन काउंसिल का भी कम से कम हम लोग शुरुआत कर दें नेशनल कॉन्फ्रेंस से। एक बार तो इंडियन कार्डियोलॉजी ऑफ कॉन्फ्रेंस नेशनल हो चुका है, क्योंकि यहाँ काम में कोई कमी नहीं है, चाहे वो इंदिरा गांधी इंस्टीट्यूट ऑफ कार्डियोलॉजी हो। मैं विगत 40 वर्षों से इंदिरा गांधी इंस्टीट्यूट ऑफ कार्डियोलॉजी में कार्यरत हूँ। आज इंदिरा गांधी हृदय रोग संस्थान बिहार सरकार का एकमात्र सरकारी संस्थान है जहां आधुनिकतम तरीके से हृदय के मरीजों का इलाज किया जा रहा है। प्रतिदिन कम से कम 5-7 एंजियोप्लास्टी करते हैं। हमारे यहाँ 12 डीएम कार्डियोलॉजी वाले डॉक्टर हैं। हर साल दो डीएनबी के डॉक्टर आते हैं। हमारे यहाँ राउंड द क्लॉक जो इमरजेंसी चलती है, हर समय बेड फुल रहता है। ये दिखलाता है क्योंकि वहां पर कोई पैसा लगता नहीं है, हर चीज फ्री ऑफ कॉस्ट है। आयुष्मान का लाभ हो, मुख्यमंत्री सहायता कोष का लाभ हो, प्रतिदिन 5 से 7 मरीजों का पेसमेकर लगाया जाता है। प्रतिदिन कम से कम, बहुत सा दिन तो ऐसा भी हुआ है कि 20 से 25 एंजियोग्राफी इंदिरा गांधी इंस्टीट्यूट में हुआ है। ओपन हार्ट सर्जरी हो या क्लोज हार्ट सर्जरी हो या डिवाइस क्लोजर जो बच्चों में है, हर एक 15 दिन पर किया जा रहा है। ये बिहार सरकार का एक अनूठा नमूना है कि सरकारी अस्पताल में भी बिल्कुल आधुनिकतम तरीके से, बिल्कुल फ्री ऑफ कॉस्ट मरीजों का उपचार किया जा रहा है। धन्यवाद।
बहुत धन्यवाद सर आपके इस दमदार संबोधन के लिए। और अब मैं बुलाना चाहूँगा डॉक्टर एस चटर्जी, पास्ट प्रेसिडेंट CSI बिहार, और नए कार्डियोलॉजिस्ट के लिए एक प्रेरणा स्रोत। सर आए अपने ओजस्वी वक्तव्य से हम लोगों को संबोधित करें। डॉक्टर एस चटर्जी।
Good afternoon, everyone. Actually, today I remember 1993 December when I was selected for DM course in AIIMS Delhi. And when I was taken, I mean, those who were selected for DM course at that time, the HOD took all those candidates to the director's office. And in the director's office, the then director of AIIMS asked me that you are from Bihar and there is no cath lab in Bihar. What will you do over there after taking the training? And my answer was that I will be working, I will be a catalytic force for the development of cardiology in Bihar. And today I feel that I'm successful to some extent. When I came here, there was no cath lab. And the first cath lab was, of course, established at the Jivak Heart Hospital, where late Jwala Pradhan Sahab and his son Ajit Pradhan and Dr. Pramod, and with him Dr. Arvind, who started the invasive cardiology and cardiothoracic surgery at Jivak. And after that, with our great intervention, Dr. S.N. Mishra, whom I convinced him to start a cath lab over here, and we had a cath lab in 1999. After that, we know the history. I took this opportunity also to pay my tribute to my mentors, Professor Sivnarayan Singh, under whom I worked during my MD medicine, Dr. A.K. Thakur, Dr. Vishnu Jain, where probably most of you do not know him, but he was the first cardiologist, trained cardiologist in Bihar, who came after doing his fellowship in Buffalo Institute, and probably nobody knows over here. But he was a very, very gentleman. He had a great effort in my career. And then, of course, Dr. A.K. Thakur, who started the non-invasive cardiology, Dr. S.N. Mishra, who brought the cath lab at IGIC, and I should not forget the name of Dr. R.K. Agrawal, DM in Bihar, who came from PGI Chandigarh as back as 1983. Before that, after doing MD, we all were thinking only of MRCP and FRCS. After Dr. R.K. Agrawal came over here, we understood the importance of DM. And then, of course, after a decade or 2 decades or 3 decades, we have got 100 DMs in Bihar. So this is a great achievement for the state. Thank you.
Now, there is a special mention. We are privileged to have Dr. Riyaju Hayashi, Director of Cardiovascular Medicine at Daikoi General Hospital in Japan. Please sit down. So he has been our international faculty and guest of our country. So on behalf of CSI Bihar chapter and Bihar International Council, we intend to honor him and to felicitate him. I invite the 3 topmost interventional cardiologists of India, Dr. Vijay Trehan sir, who is already on stage, and my call is for Dr. B.C. Srinivas from Bangalore and Dr. Viveka from New Delhi to please come over here. And I request our organizing secretary, Dr. Ashish, to please accompany Dr. Riyaju Hayashi to the stage.
Actually, Dr. Raijo Hayashi came after our request on CTO. He's one of the pioneers in CTO in Japan, and Japan is known for CTO cases. He's a young cardiologist, but very well known for CTO cases.
ये हमारे मिथिला का पाग है जो हम प्रतिष्ठा के रूप में अपने मेहमान को पहनाते हैं, और एक मिथिला पेंटिंग का शॉल है। May I request Dr. Riyaju Hayashi to say a few words?
Thank you. I'm Ryozo Hayashi from Japan, and it's a great honor to be here. So I'm a Japanese expert PCI operator. So I have the much the nightmare case and very complex cases experience. So I would like to share with my experience with you. So thank you so much for inviting me to this excellent conference. Thank you.
Now, coming to the last phase of inaugural ceremony, may I request our chief guest, who requires no introduction to this August gathering, Professor Dr. U.C. Samal, who has been a past president of CSI Bihar chapter and president of Indian College of Cardiology also. He was professor of cardiology and general medicine at PMCH and NMCH. He has established Department of Cardiology at NMCH, and his life is itself a message to all of us. So, U.C. Samal sir, please.
Good afternoon. The August gathering here, the delegates and also young cardiologists, those who have put in a lot of effort in having this conference, and particularly I like to name them because it will be unwise on my part if I do not really mention their name and do not really appreciate their effort. President K.K. Varun, Dr. Arvind Kumar, who is the most dynamic person amongst the younger ones, and Ravi Vishnu, the chairman of scientific committee, Nishant Tripathi, chairman reception committee, Ashish Kumar Jha, most dynamic, and possibly he has called me 5 times to come to this place in different occasions. And UN Singh, of course, is the secretary, and B.V. Bharti is dear to me, and Ashok Kumar very, very close to me. I know how much they have worked, how much the effort they have put in to make it successful. Abhinav Bhagat is a student of mine, and then I could find that he is very much there, and finally the Vinith Kumar. This is not enough, but the best thing that has happened here, that we have roped in the best of the India over here, those who are really elegant, performance, interventionist and teachers, and also the doctors. And to name them also, first of all, Narsimhan also got connected with us, D.S. Chadha and B.C. Srinivas, my dear friend from Jayadeva Institute of Medical Sciences, and my most favorite and good friend, Dr. Bijay Trehan, a great teacher, a dynamic performer, and Praveen Chandra, of course, he has not come. M.K. Das, of course, he is a doctor come leader amongst us, and Vivek Kumar, dear friend of mine, known to me for last several decades, and he is elegant faculty, and also then comes Vijay Thompson. I know him for such a while, but certainly we have got 2 faculties from the prestigious institute like CMC Vellore, and the other one is Professor John Jacob. And P.K. Sahu from Orissa, my state, I know he is the most reputed doctor amongst the practicing one, and he is also dynamic, and also he does most of the good work at present. And here, if I do not mention the name of Dr. Pramod Kumar, who is a mentor of all younger doctors over here, who has given real dynamism to all. R.D. Jadhav, and he is a constant visitor and promoter of our society, and also finally Nirav Awasthi. And with these words, what I want to mention, that the conference is rich and richer when the people of elegance and eminence do come and participate and embrace the occasion. And this is, I think, the best thing that we have done. Today we have learned so many things, and the younger people have learned much more. And I understand all the benefit is certainly should be dedicated to people of Bihar, to whom this service should go. That's what my final wish. And with these words, I thank all of you for giving me this opportunity to be called as a chief guest, though I am one of the guests, host rather, for this occasion. Thank you very much.
बहुत बहुत साधुवाद सर आपके इस प्रेरणादायी उद्गार के लिए। और अब आखिरी में मैं यही कहना चाहूँगा कि धन्यवाद ज्ञापन कोई महज औपचारिकता नहीं होती, ये आयोजकों के दिल से निकला हुआ एक उद्गार होता है कि कैसे एक बड़े यज्ञ को इतने लोगों के समर्पण और समर्थन से सफल बनाया गया। तो मैं आज के डायनेमिक ऑर्गेनाइजिंग सेक्रेटरी हार्ट हॉस्पिटल के इंटरवेंशनल कार्डियोलॉजिस्ट डॉक्टर आशीष कुमार झा ऑर्गेनाइजिंग सेक्रेटरी को अभी बुलाना चाहूँगा कि आए और आपकी जो फीलिंग्स है वो धन्यवाद के रूप में अपनी भावनाओं को व्यक्त करें।
First of all, I would like to thank the CSI for giving me an opportunity and putting faith in me for organizing this humongous conference. And thanks to all my teachers. Rehan sir is there, and so many, my Vijay Samuel sir was there, John Roshan sir was there. So many master faculties from outside who came here Dr. Pratap sir is here. Thank you all for coming here. Then I would like to thank the cardiologist from Bihar, Patna. Pramod sir is here, Dr. Ved sir is there. I got support from each and every one of you. And thank you all the my juniors, seniors, and colleagues for coming here. Thank you. Thank you, sir. And I would like to invite you all for dinner in the adjacent hall and lunch in the adjacent hall. And
Senior faculty, faculty.
there is only 15 to 20 minutes time for lunch.
Please stand for the national anthem, please.
डॉक्टर आशीष कुमार झा सब लोगों को धन्यवाद दे रहे थे, बहुत अच्छी बात है, उन लोगों ने जो जो उनको सहयोग किया। लेकिन मैं कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया बिहार चैप्टर से के तरफ से डॉक्टर आशीष कुमार झा को इतना अच्छा, सक्सेसफुल, पीसफुल और लाभदायक कॉन्फ्रेंस के लिए बहुत बहुत बधाई देता हूं। धन्यवाद।
और आप सबसे अनुरोध है कि राष्ट्रगान के लिए खड़े हो जाएं।
हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
Requesting you, please have a lunch. Please finish it, if possible, in 20 minutes. And by 2:30, we will try to start our next session. So requesting all you, please finish your lunch and assemble in this hall by 2:30.
सर सर नगेंद्र भैया सोर्स लैपटॉप सोर्स
लगाइए पर लगाइए
देखिए गया
आगे दिखाइए वहां दिखाइए वहां दिखा दीजिए एक बार साइड पे दिखाइए
हॉल पे सर को चेक करवा दीजिए
साइड पे हो रहा है
हाँ ये सर
आगे ना प्ले हो रहा है ना ठीक है चलो ठीक है ठीक है थैंक यू हाँ निकाल दीजिए बहुत से हैंग ऐप तो कोई भरोसा नहीं कई कभी है ना कुछ
Hello, check. Hello, check, check. Hello, check. Hello, hello, check. Hello, check, check, check. Hello, check, check.
preponing the CTO and stable CAD session. So I'd like to call upon stage the chairpersons for this session, Dr. N. Pratap Kumar, sir. Dr. Raju Hayasi, please. Dr. B.B. Bharti, sir. Dr. Pramod, sir. Dr. UN Singh. Dr. Sandeep, sir, I think is there. Okay. So I would like to invite chairpersons to invite speakers, introduce speakers and their talks. Thank you.
Hello.
Can somebody?
So the first speaker is Dr. N. Pratap Kumar from Kollam. He's a expert in coronary intervention, especially in complex coronary artery disease and the CTO. He will speak on integrated approach to the CTO, a case-based discussion.
I think, yeah, they have to tell them that it is not STEMI session, it's the last session. Slides. Showing a different
Off
slide.
the light on this. What is
Go to the last session. Tell them to session. Yeah. They are confused. You are confused. Yeah. No. You are confused everyone. Okay.
It's always a great pleasure to have Dr. Pratap amongst us. He's a proctor, mentor for all the complex kind of cases. And we are very happy once again to have him here and to listen to him what he has to say about anti-grade CTO.
Dear respected chairperson, and actually once again I should thank the Bihar Intervention Society for inviting me to give us small work on the anti-grade CTO escalation. Can I go to my slides? I'll be showing a case how we have done. A 41-year-old male patient with an ischemic heart disease of 18 months. He is not a diabetic, hypertensive, not a smoker, no family history, eco-normal. This I have done in 2023 IGCTO live case. So I just wanted to show the case fully, but I'll take time within my time. They actually given a case of an RCS CTO with the left system is normal. If you look at carefully, I have taken a 7 French AL catheter to the right system and an EVU 3.5 to the left system to start with. So we should have a dual angiogram is important. So the first thing is actually you have to take a dual angiogram with the 2 catheters, and then you should see the retrograde collaterals. What I have done is actually I have taken a microcatheter with initially polymer jacketed wire, that is filled Rep-C wire. So I tried to take a filled Rep-C wire with a microcatheter that is fine cross. So I shifted, I knew that it is not crossing. The first wire I tried to use was an XTR, which is actually polymer jacketed, but it is actually can take the soft tissue channels. So I tried to do that. If you look at very carefully, I am in trouble. It is not crossing. I thought there is a small trickle of flow from the distal vessel. If you look at the left hand projection, you can see that the flow is there. I thought it is very easy, but it is not. Though, then the problem is actually then I just again keeping the wire there. I was in a confused level. The wire is not going at all. Tried for nearly 5 to 7 minutes. Then I decided that I will escalate the wire to the next one is Gaia second wire. So I took a polymer jacketed wire with a fine cross. Then I tried an XTR wire. Then third, actually, I tried with a Gaia second wire. So the next is actually, even then the wire is not going. You can take a next wire or you can increase the support. Support increase can be by an anchor wire, anchor balloon, or a buddy wire technique. You can do a retrograde intervention. And I was guided. But I should confess that there is no interventional collaterals. So I tried a wire, actually, there is a wire, filter FC wire I have taken. You know, we are in India, so we should look at the cost also. Even though it was a live case, I have taken. So the initial first wire I have taken, that was actually taken into the corners branch as an anchor balloon. So I took an anchor balloon. Anchor balloon should be a balloon size, vessel size balloon, which is not to increase to a high pressure. You can take a 6 to 8 atmosphere. I took a 2 into 12 balloon into the side branch of cornus artery, which can occupy that. Then you can see that the wire actually, I have taken the other wire out. Now, some progression. But I'm not sure that I'm in the vessel. You can always check. You're having a catheter there, and I can always check. But there is no progress. So the next thing is I am checking from the right side. I understood that I have no progress, but there is some progress, but we are not sure that we are in the vessel or not. So next, you can take a different angle to see that we are in the luminal part. I have taken the projection to the RAO projection to see the vessel. But here the problem is actually when you see the RAO projection, when you have an excellent circumflex with a lot of OM vessels, then you will be confused that your vessel may not be seen. So that is actually checking in different angle is a must. So the next thing is actually I am in trouble. Nothing is seen, boss. Oh, I should have taken my laptop and come here. That is why Japanese Hayashi was very clear that he will connect only his laptop. No, boss, you have to go back. This is the last shot. Can I go back? If you're okay, I will go and take my laptop from my room and come.
While they are trying to fix it, can I ask a few questions?
Otherwise, let the Hayashi take the talk. I will bring my laptop and connect it. Not a big issue. Otherwise, I can answer the questions. So because the time will go away, you will not allow exceed the time limit.
They got it now.
Okay, next, go, next. I crossed that one. I crossed. Okay, now the next, no, just back. So the next wire of choice was the Gaia second is there. So I tried another wire. It's actually the Gaia 3 wire. So if you see, look at the distal vessel, which actually I am totally out of the lumen. If you look at very carefully on this side, I am totally out of the lumen. So my distal cap is totally out of the lumen, even though there is a catheter. So I was thinking that next. So I have to either withdraw the wire or I can do a parallel wire technique. So I have taken the third wire as the parallel wire. So when you are actually, distally the wire is out of the lumen, The next choice is a parallel wire. So in parallel wire, the principle is you should take a better or a more complex, more actually, भाई आप बाहर जाइए, please. You go out and talk. You can take a more tougher wire that actually I decided to take a Miracle 6. So the next thing is, when the Miracle 6 and 2 wires and 3 wires together, sometimes you may have problems. So I decided, you can see the wire is buckling out. Next. I cannot operate, that is why I'm asking you. So the parallel wire technique, Miracle 6 wire, next. You can go to the next projection. So the left guide, this is another problem. The left guide came out. Why the left guide came out? When you do a retrograde intervention or when you have another catheter, you should actually fix the catheter. The catheter is not fixed. You keep a wire there. So these are all happening during the live case. So I should immediately fix the catheter. Next. So I'm just showing everything. I recalculated. These are all live cases and you will get only 1 hour time. You have to do the case. I'm actually fixing up. You see, when you are in pressure, you will have problems. Then I'm taking a guide wire. I'm just fixing up. You can see that. These are all not important in C2 intervention. During C2 intervention, the other catheter should be fixed by keeping, next. I just kept a wire. Now I kept a wire into the circumflex and then kept that one. Now the next wire I have to take is a Congress Pro 12. I removed the Gayatri wire. Miracle 6 wire I kept there. I decided to take a Congress Pro 12. That is actually the next wire. You see Filrev C, XTR, Gaia 2, Gaia 3, Miracle 6, and then Congress Pro 12. So now the Congress Pro 12 is actually here. So I think I am progressing, but I'm not sure about that. You can see that wire is coming down. Next. Next. So the wire is actually, the wire crossed little more here. I understood that the wire crossed little more, but I have to see that whether I am in the true lumen. I have to check from the other system. Now I'm checking from the other system. Next. Wire crossed little more. So now you can see that actually this I have taken into different angle and checking because you are not sure that you are in the lumen or not. Here the problem, looking like you are in almost in the line with the vessel. Now in the other angle, if you look at wire, the distal end of the wire is out of the lumen. So the distal end of the wire is out of the lumen. So I have crossed some more, but I have distal end is out of the lumen. Next. So other wire, I switched to Miracle 6. So 2 wires are there. Seesaw technique. You can push the one wire. Then with the help of the wire, I took the other wire. The Miracle 6 I wire. Actually, I understood the Miracle wire is not able to do that. So again, not in the lumen. So the 2 wires are there. So the Congress Pro 12, I decided, I de-escalated the Congress Pro 12. I understood the proximal cap I crossed, but the distal cap is not crossed. So I de-escalated wire into Gaia second wire. Now, if you look at very carefully, the Gaia second wire is progressing a little more easily. So if you look at this projection, now I'm checking, I am actually more confident that I am almost in the lumen. So the Gaia second wire, de-escalated wire progressed. Once the de-escalated wire progressed, so it actually bent, the Gaia wire bent distally. You understand it is a tortuous, bended CTO segment. So I decided to de-escalate again. The de-escalated again means I try to take a wire of, this is actually a cyan black wire, much easier wire, but actually a de-escalated. So this wire, so you can see that the wire is in this second part, you can see the wire easily gone down. Once the wire is gone down, oh, totally gone, man. Looks like in the true lumen, I was in the true lumen. Now it is in the true lumen. Then the 2 into 10 millimeter balloon, we have to do an IVUS to understand whether we are in the true lumen or not throughout. That too, it is in the live case demonstration. So totally wire was in the true lumen. It created some subintimal hematoma, but it was totally in the true lumen. Once it is in the true lumen, so I just understood the vessel. So the RCO staining strategy, it is a 3.5 vessel and a 4.5 vessel proximally. We decided to take a balloon dilatation 3 millimeter, approximately 3 millimeter balloon. Then we took a 4x38 stent proximally and a 3.538 distally and 3.510 distally. And finally, we finished the case with the 2 stent strategy, and this was the result created. And then finally, we have to check whether the IVUS run is okay. No proximal dissection. RCA post IVUS run is very good. And then we produced a good result. You are actually, this is also not moving, man. Can you just next go ahead? So the result, actually we got an 8.2, 8.3 next. 9 next. So 11 next. So we got an, so the first wire actually, my approach is X3R, then a Gaia 2, Miracle 6 or UB3. You can have a third wire as Gaia 3 or a Congress Pro 12. We use Gaia Next 2 now. And always with a microcatheter, retrograde injection is mandatory in a C2 intervention. You can have a parallel wire technique or a redirection of the wire. Next slide. So the antegrade approach is single wire technique or a parallel wire technique. If the actual retrograde, you have to, he will be talking next. So wire crossed, but not in the track, then what should be done? You can have a redirect the wire. You can have a parallel wire technique or a dual lumen catheter or IVUS guide puncture. Next. So this is a case actually in RCA circumflex CTO. Gaia first not entered. Gaia first not entered, but the Gaia 2, you can look at that. This is actually out of the track. There are 2 things you can do here. You can actually redirect the wire. Can you just press to move it? Boss, can you just press it to move it? Oh, no, last one. Okay, move. Okay. Completely collapsed. I should have done a different one. Actually, I redirected the wire, went down. So this is one technique, especially with the Gaia wires. Gaia wires actually a torque is there. You can do that. Next one. Or you have to go for a parallel wire technique. The lesion is not crossed with filter FC. Gaia second tried. Then the next frame you can press. Frame you press, then you will understand. Next frame you press. I am helpless. So the basic concept of parallel wire is actually original wire will prevent the entry of the additional wire into the subintimal space. So redirect the wire inside the body of the CTO and puncture of the distal fibrous cap. Distal true lumen which we visualize by collaterals or by angiogram, and high operator scale is required. So the second wire is actually advanced next to the original wire. It should be through a second microcatheter. We call it's a seesaw technique. If it is without a microcatheter, we call parallel wire technique. You can use a dual lumen catheter also. Parallel wires can be used in multiple ways. I'm not going into details. So wire used actually, the stiff and highly torqueable wires are used. The second wire should be a Gaia wire or Congress Pro Miracle 12. Stiff polymer jacketed wire also can use. Second wire should be stiffer than the first wire, and it should have a superior torqueability. So in this case, actually the Gaia 3 wire. So the second wire I used as a parallel wire technique is a Gaia 3 wire. The wire is actually crossed easily. I'm not going into that. The wire crossed. And this is actually a dual lumen catheter technique. Advantage, intraocclusion tortuosity. First wire stretches the vessel and favorably modifies the curve. That is actually, it's a parallel wire technique. This will be an angle vessel. It stretches the vessel and make the wire to go. This is another diagram taken from Gerald Werner. So you can use multiple catheters like Crusade is only catheter available. Sasuke is available with very few people. It is available with Hayashi, not with everybody. You can use these techniques for other purpose also. Crusade is available. I'm not going to details. So this is actually the Crusade technique. You have kept the wire there. That is actually the wire into the septal collateral. And the second wire will come. You can actually just wait 4 seconds, it will come. Then second wire actually taken the wire through the 2 gaps and gone down and then finish the case. So this is actually a parallel wire technique. You can actually keep the microcatheter into the side branch and dilate and then create a path, and then through that path you can actually pass the wire down and then finish the case. This is actually, the problem is the parallel wire technique is actually enlargement of the subintimal space can be created. Excess rotation can wrap around the wires. These are the 2 things to be very careful about that. Remember, switch to a parallel wire technique is never in the last choice. It should be done immediately if you fail. Thank you. I'm sorry for the miscommunication of the slides, and that is not my problem.
So I don't know if the management allows us to ask questions, everyone will be, it's all right, we can.
Please feel to ask questions. That is what they told.
Yeah, good. So 2 questions. One is that, we have heard a lot about the HDR techniques these days. How friendly you think it is, and what is your take on that?
I have done 2 cases of HDR. HDR is actually not a bad technique, but you should understand that you pass a wire and keep a lumen there, and you keep the microcatheter in the middle part and then inject 0.5 ml of contrast that actually stretches the microchannels of the vessel, and then you can take more polymer jacketed, actually a flexible wire like Filter or Whisper or any wire of that sort, and then push the wire, it can cross. But actually, if you analyze very carefully, HDR is actually a modified form of a Carlino technique, which initially was used even in the subintimal space that is created and passed the wire. This is actually, we are telling it should be exactly in the middle part of the lesion and create a 0.5 ml of contrast, not a very high amount that will cause more dissection. And I've tried 2 cases only for the sake of telling that I also did that. Both the cases were luckily successful.
Any comments or questions from the audience? Dr. Hayashi wants to say something?
Okay. So great presentation. Thank you. And the key point of the anti-gravity method is stabilizing the guiding catheter. So you put the anchor balloon at the conus branch. So you use a fine field FC to the cross to the conus branch. Is it? No?
No. Actually, I've taken the Filter FC was not the wire I tried to use. Actually, the wire which I used into the side branch.
Okay.
Initially, when I took the wire as the Filter FC to take the microcatheter into the proximal part of the CTO segment, the same wire I used for the anchoring technique. You can use actually a normal workhorse wire is better rather than a Filter FC. If you are not handling Filter FC well, it can cause perforation and dissection.
Okay. One more comment. So in the case of the first case, RCCTO, you engage the guiding cutter to the LCA, and during the procedure, the LCA guiding cutter disengaged accidentally. Yeah.
No.
No.
During the procedure, our left catheter was disengaged.
Yeah. Why?
Unknowingly disengaged. So I just again re-engaged. What I was telling that keep the left catheter engaged. Better to keep a wire in one of the branches.
Yes.
That is what is to be done.
Yes.
I'm just giving some messages.
So we have to avoid making dissection at the LMCA. So I strongly recommend to put the wire to the
one of the branches.
Yes.
That is what I told. Yeah. Okay. Thank you.
Thank you, Dr. Pratap, for a great lecture. Lot of learning points. Now, We have to wait for a few minutes, it seems, because of some technical problems that we are having. So
No, no.
Dr. Ashish has informed me that in the meantime, we will felicitate the speakers. So can we go ahead, Ashish?
Which?
Yeah.
No. This is a presentator mode, please. No, please switching the. Excuse me. Oh. No. No.
Ashish, why don't we finish the felicitation in the meantime?
I would like to invite Dr. Pramod sir, Dr. B.V. Bharti sir, and Dr. UN Singh sir to felicitate Dr. Pratap sir, please.
डिस्प्ले में क्या चाहिए आपको? आप बोल दो ना डिस्प्ले में क्या है?
No.
Like in his screen, he wants to be the primary. Second screen.
Very nice look. Actually, I got the study from this place also, Nasik also. Nasik also I got. It's naturally from Dr. Pramod is actually a big thing. Actually, the same thing from Nasik. Today I was in workshop.
So I think we can utilize our time. I can ask Pratap another question. There has been talks that every CTO you must have a CT coronary angio done before you proceed. What do you think, Dr. Pratap?
Every calcified CTO, every tortuous CTO, every ambiguous CTO, you should have a CT angio, not every CTO. So if if you have a CT angio, that will definitely help to understand that the CTO track and CTO length. Sometimes you may see it's a very calcified CTO, but maybe a short CTO, and there will be a calcium spec, which these are all can be identified by the CT angio. But CT angio is a very good tool to understand before doing a CT intervention. But most of the time, people will not be willing, or rather their financial status will not allow that. But if it is available, if it is good, that is actually available, an excellent tool to do that.
One other question, sir. What are the type of CTO, an experienced CTO operator like you will not touch? This should not be also absolutely done.
That is actually a very difficult question to answer. I will never decide not to touch any CTOs, number one. Number two, sometimes in a very long CTO, where totally ambiguous, and your distal end actually, especially for the RCA, PDA, will be well seen, and there is nothing you can see from a long CTO, where interventional collaterals are not very clear. Those type of CTOs usually Even then, I give it a try and then only I'll tell no.
There is any rule of viability test?
Are you ready?
There any rule of viability test? Viability test for before.
Viability, actually, the patient actually that ischemic area is or viability is not available, then CTO intervention should never be done. So the patient actually having a refractory angina, TMD strongly positive, single vessel CTO, definitely to be done. So the viability is a must in every case. Otherwise, it is not. But viability testing is a question mark. That is a $1 million question. You know. Hayashi, please.
Yeah, please go ahead.
Okay, thank you.
Yeah,
So-
so Dr. Hayashi has already been introduced. It's a great pleasure to have you here. And I will request you to go ahead with your lecture.
Thank you, Chairman, and it's a great honor to be here. And I'd like to start with my presentation about the Littlewood method. So this is my UI. So the Littlewood method has many important things to consider. So however, today I only have the 30 minutes for presentation. So that I focus on these 4 topics. So first one is background. So outline even today, the CTO PCR remains technically challenging, and the anti-gravity method still has only a suboptimal success rate, and even the expert Japanese operators. So the Littlewood method has improved the success rate of the CTO PCI. This data is from the high volume center in Japan. Please focus on the primary anti-gravity approach. So the initial success rate of the anti-gravity approach is 82%. Then the failure group of the anti-gravity method was switched to the retrograde method. And 53% of the retrograde method lead to success. The retrograde method added another 7% of the success rate to all of the group. And therefore, it is clear to that the retrograde method is an important technique for improving the success rate. So I move to the next topic. So I'd like to explain the type of the retrograde method. So retrograde method is classified into the 4 groups. So first one is kissing wire. So the kissing wire technique is applied for the facilitation of the anti-gravity wire into the distal true lumen, in which the retrograde wire is used as the target for manipulation of the anti-gravity wire. The second one is the retrograde wire cross. And this is when the retrograde wire is directly passed into the proximal true lumen. And it's useful when it is not possible to make anti-gravity preparation. So third one is a cut technique. This technique is very rare because this method needs to cross the balloon by a collateral channel. So of course, that collateral channel damage is caused when delivering the collateral channel. Yes, collateral channel. So the final method is the reverse cut. With the reverse cut technique, the connection is made by the anti-gravity ballooning. So resulting in a passage of the retrograde wire into the proximal true lumen, and in the case of the long and the hard region and the unclear vessel course, the knuckle wire technique can be the key to the solution. From the published data, the reverse cut method is used predominantly in the real world setting. And my personal experience also supports this. And the next topic is when to select retrograde. So I failed the anti-gravity method and is being unable to establish the anti-gravity method is definitive factors. And probable factors include the austere CTO and the long CTO greater than the 40 millimeter lesions. and severe toxicity or unqualification. So it means high JCTO scores regions. So this is my little PCI for a non-CTO case. Please check, see my angle. The angle shows the severe stenosis in the osteum of the LAD. And the contact feeling from the antegrade. So this case is not CTO, but just has a severe stenosis as proximal LAD. The RCA has a quarter flow to the LAD via septal branch. So an attempt to recognize the LAD region with the antegrade method was performed. And it was difficult to cross the wire to the ostium of the LAD, and the wire easily deviates into the circumflex. So because of the acute angulation from the LMCA to LAD. So after the treatment of the RCA, middle RCA, so I switched to the retrograde method. So manipulation of the retrograde wire via September. No point. Okay. Okay. So next step, the wire, the retrograde wire leads to the distal cap of the tight region. And the general retrograde method has 4 types already I mentioned. So, for region crossing, in this case, the antegrade preparation was unable to establish. So because of the LMC to the LAD as the acute angulation. So the only the option was the retrograde wire cross. So the retrograde wire could pass to the LMCA through lumen according to the information obtained from the IBUS. So I put the IBUS, no, wait. So you can see the IBUS here. I put the wire to the highlighter branch and across to the IBUS. So using the real-time IBUS information, I negotiate the retrograde wire to the LMCA proximal true lumen. So after externalization and predilatation, DS was implanted. So this is the final angio. The yield a good result, and the procedure was successfully completed without any complications. So the final topic is how to achieve smooth and safe externalization. So what is externalization? So we pass through the CTO region from the retrograde direction and then externalize the wire out from the antegrade guide. This is called the externalization. So what's the advantage of externalization? In the case of the CTO, it is difficult to deliver the balloon and other devices due to the severe qualification or toxicity of the region. Externalize the guide wire be able to provide maximum support for the delivering a balloon and the other devices. So why can we say such a thing? So let's think about the mechanism of balloon passing through a region. There are several factors involving in the force required for a device to pass through a region. But the main issue is the wire slipping out. So if the tip of the wire can be secured, that issue can be resolved. So in other words, if the externalization is possible, a maximum backup can be achieved. So now, please let me speak on how can we make externalization easier. The key element of the externalization is inserting the retrograde wire into the antigrade guiding cutter in order to achieve the rendezvous. So I'd like to proceed with the discussion emphasizing these three keywords: homemade snare, guide extension cutter, and the trapping balloon. But today we have a time limitation, so I will explain about the homemade snare today. So next time I will explain the other keywords. The type of externalization can be divided into two categories based on the rendezvous point inside the coronary or outside of the coronary artery. So if the rendezvous point is outside of the coronary artery, homemade snare plays an important role. So I'll explain based on the case example. The patient underwent PCI for RCA ostium 6 years ago. The DS in the RCA had been occluded. As you can see, that there is a lift septal collateral from the LAD to the PDA. The circumflex is normal. This is a summary of the RCA. The center had been occluded at the proximal end of the RCA. The occlusion length was about 30 millimeter. Unfortunately, the stent protruded approximately 3 or 4 millimeter from the origin of the RCA. So no guiding cutter, including a diagnostic cutter, could be engaged into the RCA. So we had no option to go through with the antigrade method. So fortunately, LAD had a good septal channel. So it was easy to establish the retrograde method. After sometimes the retrograde wire seen black with carbide was able to catch the aorta. So next step was to catch a retrograde wire from the antigrade guiding cutter to achieve the externalization. So in Japan, these snare devices are available. Ensnare and gooseneck snares. So sometimes we use the ensnare and the gooseneck snare, but these are expensive, even the insurance can cover. So I'd like to present the homemade snare as a useful snare. The cast of the character, the guide extension, and a normal balloon, and a normal wire, property wire. First, I extended the wire approximately 30 millimeter from the tip of the balloon to make a bend. With the wire bend, insert to the exit port of the guide extension together with the balloon. So advance to the tip of the guiding extension and trap the tip of the wire by expanding the balloon inside of the guide extension. So pushing the wire makes a snare loop bigger. The push on the wire makes pulling on the wire the snare loop smaller. So we can adjust the size of the snare loop freely. The retrograde wire easily went through the snare loop, and the homemade snare was able to catch the retrograde wire. The size of the loop is crucial. A homemade snare can the loop larger, make it easier to catch the retrograde wire. So in cases where the antigrade guiding cutter cannot engage, the snare becomes a key point. So I will provide the success rate of my own CTO cases over the past 5 years. So as well as the ratio of the case successful with antigrade approach versus retrograde approach. The success rate average around over 90%, and with retrograde approach being performed in roughly half of the cases. So in order to maximize your success rate, it is important to master the retrograde method, including externalization, reverse cut, and other techniques. So this is the last slide. The mastering the retrograde the method is essential due to its usefulness. So the smoothness with which the rendezvous can be achieved is crucial. So I hope today's my lecture will be useful for your CTO PCI from tomorrow onwards. Thank you.
Great talk, sir, for the beautifully describing the different technical aspect of the retrograde approach of the CTO. Now, question to anyone on the floor can ask the questions. Any questions?
Yes, question. Mike.
With so much success rate in CTO in Japan, what is the, percentage of people who are going for bypass surgery?
Sorry?
In Japan, the number of people or percentage of people who are going for bypass surgery in Japan?
So maybe 20% of the patient go to the bypass because so I think that the rate of the CBG is low compared to the other countries because of the Japanese people preferred less invasive. So many okay.
Sometimes in the past I heard, I don't know whether it's true or
So the
not.
mic is actually,
Yeah.
can't hear, sir. Close, mic too close. Close your mouth. Yes, sir.
Yes. I have heard in past, I don't know whether this is true or false, that the Japanese people feel that if you open your chest, the soul goes out, and therefore they do not prefer bypass surgery. Is it true?
Sorry? Just one.
Japanese Hayashi.
Yeah.
Japanese people feel that if you open your chest, your soul will go away.
No, just kidding, sir. It's a kidding.
One thing you should understand that the number of CTO intervention they do is very little numbers. And number two, why Indians are not interested in doing CTOs? You have 15 cases. You are actually allotted time for the cath lab is only 4 hours. After that, you have to go and practice in your clinic. So you are jumping to do a CTO for 10 minutes is not the point. They spend 3 hours or 4 hours. They are coming to India also to learn CTO by improving their skills. Why? Because they don't have that many cases, sir. And that is why, number one, even our numbers or CTO will come down drastically in another 10 years' time if you do primary PCI for all the patients. Earlier, people were not doing angioplasty. A lot of patients were doing thrombolysis, failed thrombolysis, especially for the RCA cases, coming down for CTO. Now they will come and finish if you give them chances to do that. Even if you look at these numbers at 2025 in a year. So the numbers are very less, but they spend time. They spend time to understand and analyze the case. If we do the same thing, we can also create success. One question to Hayashi.
Yep.
Which are the wires you use for channel crossing?
Okay. So I prefer to crossing the septal, collateral channel. I use 003. So first choice is 003. And if the failed, I switch to the Xion, not Xion Blue. But in the case of the epicardial channel, I just only use 003 because maybe compared to the other countries, the people, the Japanese coronary is very fragile, so easy to the making perforation. So we have to choose a very soft wire. So this is the reason I choose a 003.
Actually, they use only 003 because they think that Japanese coronaries are fragile like them. Our coronaries are actually very strong, so we can use Cyan Black, even XTR for our purpose. Hayashi.
I know. I saw you use Cyan Black. Yeah, I know.
I use Cyan Black. Thank you, Hayashi. Wonderful talk, and we will go to the next talk. Actually, he is felicitated now or later?
You will felicitated later. The next presenter is case presentation.
Case presentation.
That is Dhananjay Kumar.
Now, Gaia Next is actually having three coils are there, three coils interwoven. The other one is a single coil. So there is a chance of break in that Gaia 2 wires. Actually, the Asahi will finish all the Gaia wires in Japan. Now there is no Gaia wires in Japan. They use only Gaia Next. We will finish our Gaia wires, then they will make Gaia Next available in India also. They have to finish it off, The stock should be finished. I use Gaia Next in my cath lab. Not everybody get Gaia Next, and Asahi is not giving to everybody. Gaia Next is a much better wire, and it is stronger also. Gaia 3 is actually nearly 6 gram is there. I think there is a case by Dhananjay Kumar.
Good afternoon, everyone. Basically, we all have witnessed the calcium is a big challenge, whether it is visible or not visible, or visible angiographically, or visible with imaging. So this is the first case, a 55-year male with new onset chest pain, hypertensive, dyslipidemic, non-diabetic. His ECG and echo was normal, but TMT was positive. This is his angio. The LAD was normal with mild plaque in the proximal segment. The LCX was critically stenosis, and the RCA was totally occluded. It was calcified from the proximal segment, osteoproximal segment, diffusely calcified, and a total occlusion from the mid part. There was good collaterals from the retrograde, but I opted to go with anterograde. The osteoproximal segment was critically stenosis, so I chose JR guide rather than any support guide. And with the microcatheter, fine cross microcatheter, and Filter XT wire, I progressed to some extent, but escalated the wire to Gaia 3, and then I crossed the lesion, and somehow I crossed the microcatheter through the calcified segment because it was not taken there. But with some torque, although I used to avoid torque in fine cross microcatheter, but it crossed the lesion. But after the high pressure balloon inflation of the HP 0.75, even the 1.5 balloon was not crossing the calcified lesion. So I prefer to give rotational atherectomy to the whole calcified segment. After the orbital atherectomy, after the orbital atherectomy and high pressure NC ballooning, this was the initial repression, and this was how the imaging looks like. So you can appreciate how densely calcified the segment was, and yeah, again with the repeated cycle of slow and by cutting and high. This was the final preparation. This is the imaging. This is how the rotation orbital atherectomy can cut the sand out the calcium, and after the cutting balloon, you can easily appreciate the fragmentation of the calcified segment. And this was the PDA was given after preparation a regulating balloon, and finally this was the outcome of this case. Now going to the second case, this was a total occluded left LAD from the ostium. LCX was stenosed, and the MS was also stenosed. There was a retrograde from the RCA, but for the there was some fine channel and some appreciable calcium angiographically, but I was not feeling any difficulty in crossing this segment initially, but later on the wire was not going through Lehmann. Then I tried what we have just discussed earlier, the HDR. I used 0.5 ml of contrast through the micro catheter, and it visualized the channels. And thereafter, the Filter XT did the job, and after that, the balloon was not crossing, so did rotablation, and finally left on bifurcation with depth to ramus, and this was the outcome. And the third one, this was the complete triple vessel CTO. The LAD was totally occluded from the mid part. The LCX was totally occluded just after origin. And the RCA was totally occluded from the proximal segment. Again, here, no calcium was visible. I started with the filter XT, up titrated to Gaia 2. Initially, I was in true lumen, but somehow missed the lumen. And thereafter, I again retrieved the wire and then gain the true lumen. Again, I was not appreciating any initial hurdle in crossing the balloon, but nothing was crossing after this point. So I changed the catheter to AL2, and even after that, nothing was crossing. I did the rota, and this was the final outcome. So thank you. Thank you so much for kind attention.
I have seen him actually showing a lot of cases in our meetings. Upcoming aggressive Dhananjaya. I will have two comments. The first case, you are actually doing an RCA CTO. What are the things you would have done little better?
So 2 to 3 things, sir. One, I have not done parallel wiring than previous year. So I have started using parallel wiring now. I am frequently doing retrograde CTO. So
I did not ask you. Actually, the basic thing is actually you actually used a JR catheter.
Yeah.
So Hayashi is also very much worried about that. You should have used, since you are upcoming aggressive cardiologist, you should use an Amplatz catheter, AL catheter.
Sir,
that is number one.
Sir.
When you took the wire passage distally, you were not having the other catheter, the left side catheter was not there. So after passing the wire, you just checked with the left catheter. That means you were half-heartedly doing the CTO.
I have taken retrograde short, sir.
No, but if you look at the angiogram in the initial, till your wire crossed, you have only one catheter.
No, sir. From beginning, I have started with 2 catheters.
Then can you show the angiogram?
Yeah, yes, sir. Yes, sir.
Just to understand that
and
actually,
I'm
actually
just,
did a,
sir.
correct?
Yeah, I'm just giving one clarification to the first one, sir. First is the RCA osteoproximal segment was critically stenosed, and I have personally experienced that somehow.
Dhananjay, actually, you are doing a wonderful work. I'm just telling that to improve our level. I learned a lot of things from Japanese, so I was telling that if you can, that is what.
Yeah. But it's a very key point, and so guiding selection is very important. So I totally agree with you. Okay. So maybe 90% of the RCA-PCI, I use Amplatz AL. So in the case of the CTO, I never choose a JR because the stabilizing, the backup of the guiding catheter is very important, and it's a very crucial. So I strongly recommend the user Amplatz. So Amplatz catheter.
An important comment I have to make. You actually pass the wire, you use an orbital atherectomy. In a CTO segment, you would have gone through the subintimal segment. So the only situation, if you are actually through the true lumen, you can try an orbital atherectomy. Otherwise, rotational atherectomy is the choice, because orbital cannot be used. That is actually, we are telling that you created a dissection inside the coronary, orbital is a contraindication.
Yes, sir. I totally agree with both the points, sir. I am not contradicting. I am not in the position to contradict Pratap, sir. And I am just clarifying two things. I am just clarifying 2 things. The first thing, sir, in the first case, the osteoproximal lesion was critically stenosed, and whenever you use Amplatz, it go fit inside that, and even after using higher dosage of heparin, there are chances of thrombus formation in the catheter. That has happened with me. That's why I used to avoid the
Ampliage catheter when osteoproximal segment is critically stenosed. The first one, sir. And the second one, the lesion was critically stenosed in the diffusely calcified in the proximal to mid segment. The CTO segment was fibrocalcific. I had not crossed initially in the orbital atherectomy in the initial unless I have used the imaging, and after that the distal segment was calcified. Then first I imaging the initial segment, and after that I did orbital atherectomy to the distal segment. So thank you so much, sir.
Okay,
Yep.
thank you. Actually, even he does not want to hear more comments. I'm very thank you, Dhananjay.
Thank you, sir.
Wonderful
Sir,
cases.
thank you, sir.
Last person.
Next speaker is Dr. Vineet Kumar from the Heart Hospital. He will speak on the RCA CTO case, present RCA CTO case.
Very warm good afternoon to everyone, all my respected senior and teachers and dear friends. कैसे आगे से हो? This is the story of a 77-year-old gentleman having history of old infraval MI. Now he came with effort angina functional class 2 echo was showing mild LV dysfunctions. There was RWMA in RCA territory. TMT was positive, angiography was done. That saw RCA or CTO and LAD has calcified lesion. LCX also sub intermediate size moderate lesions. Initially was attempted to PCI to RCA CTO in some other hospital here only, but not able to cross the wire. And he was not willing for COBG, so he came. This was the angiogram. Here we see the end was blunt. There is calcifications and attempted in earlier also. So we think we'll try it. Microcatheter was placed with filter FC, and we just want to feel that CTO, but that filter FC wire is buckling. And after that, we have exchanged with the Gaia 2 wire that attempted to cross, but we can see it's totally out of lumen in the last angiogram. With retrograde injection, we can see that wire is not in the lumen at all. But after multiple failed attempts, finally Gaia 2 wire crossed the lesions, and after that microcatheter also slipped there. And that this injection is from microcatheter. And after that, we have exchanged. This is the microcatheter injection. And then we have exchanged the Gaia 2 with filter FC that we have taken earlier. And after that, we remove the microcatheter. And then after serially dilating with a semi-compliant balloon, there were dissections were noted. Then that part is stented with regulating stent. And after stenting, this is the result. And after post-dilations, this is the final result. And after 48 to 72 hours, we have taken for that LAD also. This was the LAD lesion. After crossed with the wire, it was dilated with non-compliant balloons. And after dilations, we have taken that IVL because balloon was not opening properly there. And after IVL, we have stented with a 2.75 stent. And after post dilation, this is the final result of LED. Everyone, thank you, sir.
Uh, he wanted to talk after me only. So it was an excellent case because the tortuosity in the proximal part of the RCA was really, you could identify and take. You actually, in one statement, you wrote that the Gaia second wire was, the Philrepsi was exchanged with the Gaia second. It's the reverse, huh?
Oh, sorry, sir. It might be.
Okay. I just wanted to tell that point.
Yeah.
Number two, do you think that the distal most RCA was dissected or not?
Distal most.
That actually that image was looking like hazy in the distal part of the RCA. That
No,
is
there was a
really appears.
lesion was there, sir. Diffuse lesion was there in the distal part, but there was no definite landing zone. So we think.
No, I'm just telling that it is looking like hazy. So you may have to do a check angio, or that will be becoming, this is actually an investment procedure. Tomorrow the flow will be very good. Now the flow is very good, but distal part is looking hazy. You took a stent without any difficulty in the RCA, or you just could take the stent?
No, sir. After serially dilating with the non-compliant balloon, we can able to get.
Just one comment. You use the IVL for LCA, the proximal LED.
Left side,
IVL for the classification. And I recommend to put the wire to the diagonal branch, because sometimes I will make a dissection, malignant dissection, and it is already the published papers showed. So dissection extended to the diagonal, and acute occlusion. It makes the acute occlusion. But if before the using the IVL, that puts the wire to the diagonal, it can be how can I say, the make a direction of the diagonal branch. So
Yes,
it
sir,
can save the diagonal branch.
Yeah, we'll do like
So-
that from next time. Thank you. Thank
so
you. Sir.
This is the one point with the IVL usage. Okay.
That reporter case are from Japan?
Yeah. No. I don't remember.
Because
but
actually our coronaries are stronger, you know.
Okay.
Thank you. Thank you, sir.
Next presenter is Dr. Samsad Alam from Vedanta Patna.
Yeah, good evening, everyone. And we are very thankful Dr. Pratap Kumar and Dr. Hayashi is here for this presentation. So Dr. Pratap is quite familiar with this case. This was presented 2 weeks back at IJCTO. So we had a complex situation. We had a 72 years old male who suffered with inferior LMI. He presented to us with delayed presentation. He was in cardiogenic shock. He was in temporary pacemaker support. He has got his angiogram done outside and he was referred to us. So he was planned for advice for CABG along with mitral valve replacement because he was also having severe LV dysfunction with moderate to severe mitral regurgitation. He was shifted on IBP support to our surgical department, but anyhow, the surgical risk was very high. A detailed discussion was done with the family. It was said that the surgical risk is beyond 25-30%. So finally, after 2 to 3 days, the family was even not willing to take this risk. So the family came to us and they said that even though if my patient is going to die after opening the chest and all the cutting, then we want you people from cardiology to do anything if possible. We are eager. We are willing to take that risk, but we are not going to take that risk for surgery. So what we planned, you can see the angiogram. There is a significant calcified lesion in large LAD along with diagonal. RCA was completely occluded proximally. We had seen the angiogram. There was antegrade trickling was there. 99% proximal RCA occlusion was there on the first angiogram, which was an outside. Unfortunately, I'm not having the videos from that. So we planned to do a PTCA to the culprit vessel, that was RCA. So we used the Amplas catheter and On IVP support, we proceeded with angioplasty. So we were able to cross RCA with Fielder XT followed by Gaia second catheter with the help of a micro catheter, Corsair. Initially, we thought that we will be able to cross with a workhorse wire because it was a flowing vessel. It was a 99% flowing vessel with antegrade trickle, which was there with the angiogram which was done 3 to 4 days back. So there was so much calcium that we were sure that that normal wire would not easily cross. So Fielder XT, it was very difficult to cross. So then we managed to cross that lesion with a Gaia second wire. We can see after crossing the Gaia second wire, there is some antegrade trickle, which was earlier there, it came back. So we were sure that we are in the lumen because from retrograde, no significant collaterals were visible. So finally, initially, our plan was to open that RCA, maintain the flow. So we tried to cross our microcatheter, but it was a non-crossable lesion. We used a 1.2 Ikashushi balloon followed by 1.0 Ryure balloon, but we were unable to cross our balloon. Finally, anyhow, we were able to cross with a 1.2 Ikashushi balloon alone again. But this was done with a microcatheter by the tip-in technique. We moved to as distal as possible with the microcatheter, and we exchange our Gaia wire with all-star wire so that we get enough amount of support. After that 1.2 Ikashushi crossed, some lumen was created. But still, our microcatheter was unable to cross again on that all-star wire. So we planned that it is a case to be done by rotablation. So finally, with tip-in technique, we exchanged with a rota wire with a microcatheter, and we did a rotablation with 1.25 mm bar. We were quite not sure that how much large is the RCA. So we choose a 1.25 mm bar, which we usually do not. We usually commonly use a 1.5 mm bar. After rotablation, we found that the lesion, it was not that much well prepared. So we again prepared it with a serial post dilatation by 2, 2.25, 2.5. We used multiple cutting balloons with a Wolverine 2.5. Then finally, we did an with multiple ballooning, we did an IVUS run. You can see the dog boning, even with the cutting balloon, even with the non-compliant balloon, which was even seen after using rotablation. After this IVUS run, we were able to appreciate the cracks. You can see the cracks at 11 o'clock, at 4 o'clock. At the ring calcium, we can see one crack at 1 o'clock position on IVUS. So even after the dog boning, we were sure that cracks we have developed. So we had two options. Suppose now the thing is that why rotablation went 1.25? So I said that we were not sure. Second thing, I could have used laser. So two options were with us, whether rotablation or do a laser for this much thick calcium. So laser we are not having. So we were left only with rotablation. The second option which we had to upgrade the bird to 1.5 to get a better calcium cracks. So cost was also another issue because upgrading it will increase the cost. And we are not that much comfortable with exchanging with that Rota Pro, the new bar from 1.25 to 1.5. So we did repeated ballooning. We did it repeated ballooning again by 2.25 mmNC at very high atmosphere at 28, by 2.5 mm Wolverine at 18 atmosphere. And finally, we were able to see that lesion preparation, it has occurred better than earlier. We can see that. The dog boning, which was occurring, now it was not occurring that much. The balloon is expanding well. So finally, again, this was done, and now we think that it is a time to stent. So serial stenting, we took small stents, short stents, so that we will be able to track that long calcifying segment. Distally, we place a 2.5 32, then a 2.75 32, and then a 3 into 24. We knew on IVUS the mid part was nearly 3 mm, and proximal part was nearly 3.25 mm. And then serial post dilatation was done with a 275 balloon at high pressure from the mid to distal, and 315 non-compliant balloon at high pressure up till 28 from middle to proximal segment of RCA. And this was the final result. We were able to wean off him from IVP support on next day. He regained his rhythm on day 3 of the procedure, and after that he was also advised for a planned rotablation for LED, but due to cost constants and also patient was improving, so we were also not very keen to go for rotablation, a complicated second procedure in the same hospital setting. He came to us 3 months after this index procedure. We were planning for a workshop, but he was doing well. He was walking for 2-3 kilometers, and his family, we asked him that you can get your LED fixed. His family said he's not having any angina and he is doing well. And after that kind of hospital stay, which was almost around 10 days, he is not willing. The patient himself was not willing. His family was willing, but the patient himself was not willing for any kind of procedure. Thank you.
Actually, I asked a lot of questions for him. I just hit you 1 week back.
Okay. So I recommend the usage of the IVL in the such case because in this case is a cardiogenic shock, and so sometimes rotablator make distal embolization, so it makes more worsen the LVEF. So so IVL is no influence of the coronary flow. Yeah. Yeah. Of course, the main issue of the usage of the IVL is cost. Okay, I understand. But after the okay.
Instead of that, IVL is more costly than
Okay, I understand. So in Japan, we can use one rotablator and one IVL, or 2 rotablator.
one IVL, one cutting balloon, one OCT, one IVAS. In India, it is not permitted, my dear Hayashi.
In India, actually, the one IVL costs around $400 US.
It is a nicely done case. My only one difference, actually, I would have done, I told you, 1.5 rotabar instead of 1.25, so that the cost can cut down. That is actually one thing. Then you can use a cutting balloon of 2.5. As he told, IVL is an ideal IVL case, but the problem is the cost. If you use 1.5 rotabar with a 2.75 cutting balloon, then you can take a normal NC balloon and finish the case. Actually, it is a wonderfully done case, no doubt about it. And the patient was poor enough. That is why the patient was not willing for the initial procedure.
Actually, he had a poor AF, moderate to severe mitral regurgitation was there. So initially, we advised
not because of the poverty. Because of the MR, they did not agree for procedure.
Due to MR, the surgeon said that the risk will be very high. But the family said that if I am going to take risk for surgery, then I will not get him got cut everywhere. He said that then do it whatever you can do by your angioplasty.
And the
mic close. You can keep the mic close to you.
There is no collaterals from the opposite side in this artery. There was barely minimal flow in the RCA. Why to open this RCA? Because there is I don't think there is viability also. And majority of trial for CTO, opening of CTO and euphoria has gone down because in majority of trial, there is no benefit. There is no mortality. Why to open these arteries?
See, it's not a routine CTO.
Why to spend so much money?
It's not a routine CTO. Whenever we are dealing with cardiogenic shock.
There was no collaterals. From opposite side, there was no collaterals.
No, let Samsad, I will tell you. You are telling that we will allow the patient to die?
Patient was in cardiogenic shock. Yeah, infeval MI with cardiogenic shock.
The patient should be allowed to die?
Yeah.
You are telling the patient should
See,
be
cardiogenic shock, the recommendations are completely different. No, with cardiogenic shock, the recommendations are completely different. In absence of cardiogenic...
Up to 36 hours we can open.
No, with cardiogenic shock, even if it is day 7, you have to intervene. Because shock has to be dealt.
This was complete revascularization. We wanted to open the right first because we couldn't have touched LED. The right was blocked. If something goes wrong with the LED, he would have died. So it was part of... No, not only. For a complete revascular, we had to do it. There was no other option. You had to open
It
right.
was 7-day post-MI, no, sir?
No. And second thing was that LED shoot which we were seeing, it was done after opening the RCA. What I said, we have seen the angiogram which was done outside. There was antegrade trickling, antegrade flow was there in RCA, and that has got occluded. When he was in cardiogenic shock. So that is the culprit. That's why we will open the RCA and fix it.
Shamshad, actually, I don't think what he is telling is we can accept. You just tell that there is one trial called OAT trial telling that for 72 hours you cannot open. I'm just asking a very simple question. This patient had a severe mitral regurgitation. What is the cause of that? The MR is actually, if it is ischemic, that is basically because of the larger PLV branch occlusion rather than OM. It is improved because of that. And this patient, whatever you tell, only because of the intervention patient survives, otherwise patient would have died. You should have given a chance of doing something to the patient. And if without opening the RCA, I will never touch his left. Even if I dilate with a 1.5 millimeter balloon, he will die on the table. And otherwise you have to take an impeller, which is actually another 22 lakhs rupees. He has taken a chance of saving this life. I don't think there is no justification of not doing this case. If you wanted to make a patient to die, there is no problem. Shamshad, you did it.
OAT trial is not valid in cardiogenic shock.
trial will not
Cardiogenic
make
shock is completely different entity. Cardiogenic shock, there is a class 1 indication to revascularize.
Yeah,
Actually, courage trial, don't do angioplasty. You don't do angioplasty. Courage trial, don't do angioplasty.
No, it
That
is
is
not
also there.
courage trial. Decision CTO, majority of trial.
Boss, actually, this patient has no survival.
trial with
No.
CTO has been failed.
Patient has only one vessel that is actually an LAD, which is almost like a 95% disease. There is no other vessel is actually revascularizable. The only revascular vessel is actually RCA. If RCA could be opened up, you are having a support of the left system, you can do open later. But this patient MR mitral regurgitation improved, that itself indicates this patient. This patient is actually an evidence for your CTO intervention.
Yeah, myocardium cannot survive after 12 hours if collaterals are not there. And opening of the closed artery, in CTO trial, there was increase in mortality.
Just listen to me. The proof of pudding is in eating. And this patient has shown, you see how huge that RCA is. You know, it gives huge PDA. There are at least 3-4 PLVs, and he has survived only because his RC was open. So there should not be any doubt in anyone's mind that this was not indicated. He has survived. Otherwise, he was dying. He was sent for surgery, which was refused because of it would have been a very high risk case.
I think the largest trial was OAT trial, sir.
Don't worry
and
about
after
it.
3 days,
No.
opening up the artery, there was increase.
OAT trial,
There was
this
increase
patient
in
would have
mortality.
been excluded from
There
OAT.
is only one point, sir. When he is telling there is cardiogenic shock, there is no way out.
In cardiogenic shock, that guideline that you cannot open after 48 hours is not there.
Up to 36 hours, you can open the
In
artery. there is
cardiogenic shock,
benefit.
the guideline is class 1 indication. You have to revascularize.
So there's a
Not in cardiogenic shock. In cardiogenic shock, timeline is not there. In cardiogenic shock, it is a class 1 recommendation to open the artery.
What will you do? What will you do this case? Okay, you are arguing that you should not do. What will you do in this case? The patient comes to you, what will you do?
I
Keep the
think
patient on a IAB.
I think either viability study or opening of the LAD artery.
LAD.
Patient
LAD
is on
actually.
IABP support.
LAD
Patient is on vent.
I think I have.
Thank you, sir. Let us move on the next session.
Will you do an LAD in this case?
Let us move on to another case, I think, for
OM was blocked, totally blocked.
In cardiogenic shock, culprit artery should be open only. And so RCA is the culprit artery. Yes, inferior wall MI, I will open RCA on IBP or.
I think, thank you, Shamshad. Actually, the discussion will go on. Basically, Hayash wanted to make a comment.
Okay, so there's a no
What will you do?
Of course, recognize RCA. Of course, because yeah, of course, because there's a no collateral flow to the distal RCA. It means that this case, RCA is not CTO, acute occlusion.
It is an
So-
acute occlusion. It is
Yeah.
not a CTO. What I said,
So,
it was flowing
of course-
3 days back.
Of course, ECG show the.
Acute MI situation. It's
So we have to recognize the RCA immediately to save the patient. Yeah.
Life saving is important. Thank you, Shamshad. We will go to the next case.
Thank you.
Whatever he told is also correct. We will go to the next presenter.
So the next presentation is by Dr. Suen from Patna. I will speak on the guided by the vision driven by the rotation. LED CTO PCI done using the IVUS and rotational atherectomy. Dr. Suen.
Hi, pranam to everyone. My namaskar. Konnichiwa, Dr. Hayashi. I'm afraid my case is not that dramatic. It's relatively straightforward. So our patient was 77-year-old gentleman, has all the risk factors, hypertension uncontrolled, diabetes uncontrolled, hyperlipidemia also uncontrolled. He presented with exertional chest pain. He was on some medication for hypertension, which was later adjusted. Non-smoker. His EKG didn't have much changes. Exam was normal. Echocardiogram showed a hypokinetic LED territory in the anterior wall. And angiography, as we see, heavily calcified. I don't know if it's clear. Heavy calcification, proximal LED, total occlusion. In this view as well. Circumflex didn't have significant, but we see very excellent collaterals from the right, filling till the diagonal branch. So we determined it was a very short segment CTO. We had good collaterals from the RCA, and it was tapered, heavily calcified. So JCTA score was 1. And we planned from the very beginning to have a antegrade approach with rotational atherectomy. So we had dual injection, right radial and right femoral. And this was the dual injection. As we see, very short segment. So we took EBU, 6 French EBU 3.5 catheter, and with Corsair microcatheter, we took the run through till the proximal cap, and then we changed it to Fielder XT. And after a few attempts, we were successful in crossing the lesion, and we advanced the Corsair. And as we can see, we were in the true lumen. And we advanced the Corsair, and then we changed it to RotaWire. We did 1.5 burr. We did few passes, and we crossed the lesion, and then we did some polishing run. And this was then we did the IVUS, severely calcified. There were some cracks, some modifications. Next, we did, still there was a lot of calcium and lesion didn't expand well. So we did some non-compliant balloon action and Wolverine action there. As we see, balloon is still not very well now. Yeah, so this is the non-compliant balloon. After that, this is we thought this was acceptable for stent implantation. So we did 3/38 drug-eluting stent from proximal to midsection. Initial angiogram, the ostium didn't have significant lesion, and we were trying to avoid the ostium. But after the stent implantation, as we see, there's some plaque shift. And so we decided to cover that one as well. Circumflex was large. We didn't want to compromise, so we did do the stent overlapping, extending from the ostium to the other stent. We did the IVUS again. Still, there were some sections of the stent which was underexpanded. The area was 3.8, so we decided to do non-compliant. It looks good, the proximal section, but the proximal to mid stent had still underexpanded. So we did high pressure balloon with 3.5 millimeter diameter. And after this is the final IVUS. And overall, we thought it was acceptable. And this was the final angiogram. And there was some still diffuse disease distally. We thought it was appropriate for medical management. He came for follow-up, which was very reassuring. He did not have any angina. His quality of life was excellent. He was very happy, and that's what matters to us. And so key reflections in this case selection was important. He had pretty significant symptoms. his anatomy was favorable for antegrade approach, and we decided to go with the rota first approach without even trying the any balloon. And rotational atherectomy did facilitate the CTO success, and we did additional calcified plaque modification with cutting balloon. And imaging was important to guide this PCI. Thank you.
So Suvan Pranam, one question. You did you do an angio IVUS before putting the stent down?
Yes, yes.
So you have no lesion in the osteoproximal part of the LAD?
I'm sorry, what was the question again, sir?
You had no osteoproximal lesion in the LAD or not?
No, at that time, there was no significant.
After putting the stent, you have seen that there is some problem there. Did
Yeah.
you do an IVUS before doing the second stent?
Yes, yes.
So what was seen there?
There was plaque shift, and it was very severely tightened.
In the last shot, till even now, I feel that some more expansion is required in the osteoproximal part of the LAD. Probably what is the area you got, maybe 5 or 6. I don't
Area we got in the after the non-compliant was 7.8, but still I agree with you. There were some areas which was not, but we decided not to go for the perfection.
Okay.
Yeah. Thank you, everyone.
No,
Yes, let us- sorry. Yeah.
So excuse me. Just one comment. Last comment. Yeah. Okay. About the diagonal branch, osteomolar diagonal branch has a severe stenotic lesion. So that if I were operator, I put dilatation before the stenting, and if the cutting button is recommended, and because I want to control the dissection, so after the so post pre-dilatation and implant the stent. So long-term, the diagonal branch patency is of influence patient prognosis. So I recommend you to keep the diagonal branches, the main side branch patency. Okay.
Protection. Yeah, that's a good point. Thank you. Thanks. Thank you, everyone.
Yeah, I think we finished this session. Do we have to do felicitation or anything, Dr. Ashish? No, only for the old people. After this session. Okay, so thank you very much. We have come to the conclusion of this session. Thanks a lot, everyone.
So after this session, we were moving towards the sessions of nightmares. So we will be having a lot of comments and a lot of discussions. And for that, we have Dr. Vijay Trehan sir himself. He will be starting with his session. And we know he is the one who has seen any kind of nightmares we can expect, and he has managed it. So he has that much of competency and he has that much of experience. So for the next session, we will be calling upon Dr. Trehan sir himself as a chairperson, Dr. Ajit Pradhan sir from Jeevak Hospital, Patna, Dr. A.K. Jha sir from Patna, Dr. Bharti sir from Ford Hospital, Patna, Dr. Anil Kumar Singh from Bihar Sharif, Dr. Arvind Goyal sir from Patna, Dr. Anup Kumar Singh from IGIC Patna, Dr. Neeraj Kumar from Prabhat Memorial Hospital, Patna, Dr. Ravi Vishnu sir from IGMS Patna. I think few people are not, and I will also like to call Dr. Niro Kumar sir, Head of Department, Big Apollo Hospital, Patna. So in between, after talk of Vijay Trehan sir, we will be having talk of Pramod Kumar sir on the topic of STEMI session, how to manage slow flow in coronaries, primary PCI. So I will ask chairpersons to introduce Vijay Trehan sir. Thank you.
Dr. Vijayendra Ansar is a known figure in national and international level. Every intervention cardiologist know about his skill. He's a master teacher and is an innovative person. He is doing many of the things which is innovated by himself. And we know personally him, and I had worked with him. I know the skill and the mastery in the intervention, every type of intervention, not a coronary, all type of structural, non-structural, every type, even he is master of doing echocardiography. So nothing to say about him. Special, everybody knows his skill. And today he will express, he will speak on the nightmares in the cath lab.
So, with the kind permission of the chair, I think let me first of all thank the organizers for giving me the opportunity to be here. I think this is my third consecutive year, and let me see if I can engage the audience. I have sufficient number of people here. So I've been asked to talk about nightmares. One way was to just give you a volley of different cases. The other way was just to show one case where I had a nightmare. So I chose the other way around. So this was for me, a relatively youngish patient. And this youngish patient had some disease, which was in the proximity. There's an aneurysm, if you watch it close to the diagonal, a little bigger one, and there is another aneurysm distal, and there's a tight lesion just in between the two aneurysms. That was the left, relatively easy, but there was a Rentrop 3 collaterals, good collateral to the PD. Left was disease, but looked relatively straightforward. Right didn't look straightforward. There was a disease in the prox right, into the mid right, and then total occlusion there. So, and PLB and PD were feeling retro. So I thought first start integrate. The parallel wire, the bus started to buckle around, try to take a support of the guide. You see the guide is trying to get out with a microcatheter, and the wire is trying to buckle in the island of the RCA, which was in between the 99 and 100. So then I thought, let me try and increase more support with more microcatheter and stiffer wire. The wire got impacted into the PD. It was difficult to take out. With brute force, it was taken out. Fortunately, no harm was done. Then started to work around it, walked into the AV groove. So I was able to kind of have flow in the AV groove. But there's an invite of the stump of the PDA. So started to work again into the PDA. Again, this was a further stiffer wire. I'm just about to get into the PD, but what I find is now I'm in the subintimal space. The wire is stuck. So I thought, forget about it. We'll come next time. Try to revascularize only the AV groove, which was done with the stenting, and turn my attention towards the LAD, which looked relatively straightforward, but the prox and head was filling PD retrogradely. Prox LAD had calcium not appreciated in this view, but it was seen on IVUS. And so we thought upfront start with rota, which was started in this case. Just watch the 1.5 burr. Just watch it. Look at this burr. Look at this. What is this happening? I had never seen this kind of a burr movement, having done thousands of rotation atherectomies. This is like this. It becomes like this. Then fine, like this. Anybody? What was it? Anyhow, my perception was that this is corresponding with that aneurysmal area where there is a slack in the wire and the burr tends to glide. So it walks after the first aneurysm, now makes the same movement in the second aneurysm. And I was scared. Let me not do the same thing distally also. So I thought, good time. This is a first aneurysm, this is second aneurysm. So I thought it's a good time for half rota. All of us know that if you burr half into the lesion, it's sometime good enough. It was good enough in this case. Took a balloon, dilated this area all throughout with the help of a guide extension, delivered a stent, everything going fine. Where is the nightmare? Well, stent is underexpanded distally if you compare with the distal part and the prox part. So post dilatation was done only to get this thing. Well, it might look frightening, but to me it was not frightening because I had seen many of perforations like this. So a balloon tie, not into the cavity, it's a pericardial fusion is already there. So did a balloon tamponade, second guide. The second guide is only for, not only for delivering the stent, it's a second guide is for double anchor to deliver the guide extension also. So guide extension enters the stent, taken deep further into the site where you want to deliver the stent. Now you also have a proximal balloon occlusion which stabilizes the things, and a small contrast. You can very easily and very slowly inflate your this jaw graft, because jaw graft, if you look at it at 6, 8, 10, probably doesn't expand. It is after 10, 11, 12 that it starts. And sometimes if you are just waiting, you continue to bleed. So if you block with the proximal balloon, that gives you both blockage, shows the contrast, and stabilizes things, which were done in this case. And with precision, the graft was delivered. The diagonal is flowing. It sealed the perforation. But there is something more. This perforation is sealed. There is something more distally. And if you see it, what is it? There is a free flow here. And adjoining free flow, you also have a var injury at the bend, but there is no free flow from this site. And also proximally also there is something bad, which I'll try to allude later on. A microcatheter injection shows things are better. There is a free flow, tiny bleeder. And that's the var injury at the bend. But despite the fact, a florid perforation, no need for pericardial aspiration. Now the BP was dropping and pericardial fusion was increasing. So quickly went in, positioned the pigtail deep into it. Look at the left injection. If you see upstairs, prox LAD, there is something wrong there also. So despite the fact I had sealed a perforation in the mid LAD, you have a perf distally, you have a perf proximally. Your microcatheter delineates the perforation better, and your microcatheter is advanced distally into the LAD and then into the feeder over the wire. But now this microcatheter is not advancing further. So despite the fact I know that I'm going through the perforation into the pericardium, I deliberately did it because I needed wire purchase to take my microcatheter into the feeder. Otherwise, I will not be able to deliver a coil. So once this is taken deep, I am able to take the microcatheter into the feeder, pulled out the wire from the microcatheter. Now I'm ready, well set, just to deliver the coil. I confirm it before that. Microcatheter is well seated. Injection from the guide catheter shows that your microcatheter is out of the LAD through that feeder, deep into the feeder. So that means if I am delivering a coil, nothing will ricochet back. All set to send a coil. There goes a coil. If you see, the coil is going right near its end. I try to withdraw my pusher. That is just to check. Every time I deliver a coil, I do this thing. The moment you are trying to reach the target, pull back your pusher. So sometime your pusher and the coil, they are stuck together. And then you have delivered the coil and then it is stuck. It gets pulled out on its own. So it is not stuck. And what I realize is it gets stuck into the microcatheter. It is not getting out of the microcatheter. So what to do? Anybody from the panel, what to do? This is 1/8 coil. This is ProGrit. No, see, most of the time, the real world is that your microcatheters are old. Your pushers are also old. If they have a slightest kink somewhere, then these things, it is not, see, you can very easily deliver them on table. 1/8, 1/8, everything will go. But 1/8, 1/8, some tortuosity, it may not go. If there is some kink, it may not go. So what I'm finding is I am not able to push with a pusher a coil beyond the mid LAD. So if you flush it, you are totally uncontrolled. So I thought, take out everything, because according to me, that's not safe. Coil is a well-formed structure. And if you want to send something different, some biological material, it might still go. So I thought, take fat. If you're radial, you can take it from the tummy. But in this case, we were femoral. So we cut a hole there, took out a fat from here. And this fat generally is at least this big. It will not enter your microcatheter, even HUP. Even if it enters the HUP, it will not enter the lumen of the microcatheter. So it needs to be teased with a needle and blade. And I find this is the best method. Keep teasing with a blade and a needle. what you ultimately will get. And this is not once. I think I must have done ample number of time. Now I'm in the private sector, but even in the government sector, I had been doing it ample number of time. I have sufficient experience of how to tease it. And you have to create particles like this. They should be floating like this in the syringe, and from where you can easily transfer it into a microcatheter. If it is fat, everybody knows it will float, but sometimes it does not. Doesn't matter, because you have to just push a tissue there. So even if it is not fat, all what is required is you can push it down with the help of a needle. Once it goes near the microcatheter entry, then you can push it. If you try to push it with a wire, if you push it with a soft end of the wire, then sometimes the tissue may be big enough, long enough, maybe constrained enough into the lumen, it may be difficult to push with the soft end of the wire. If you try to do with the hard end of the wire sometimes cuts through and walks through this tissue beyond. So sometimes trying to deliver it with the help of a wire is not very easy. Soft end had its own problem, hard end also has its own problem. So what it commonly can be easily done is, as was suggested, that you can take a small syringe, attach a small syringe, and with saline, of course. And if the particle is small in size, this can easily go there, and all what will be required is only a gentle push. Look at only a gentle push. This will be shot into the circulation wherever your tip of the microcatheter is there. If you're not very sure that the things can stay there, the other option is you can fix the tip of the microcatheter by passing another wire alongside it and having a balloon, inflating a balloon, so that you now fix the microcatheter close to the site of delivery, and then you can deliver with the help of syringe only. If the piece is bigger, like this, I think it will be very, very difficult, because if you see microcatheters, they try to cone. So you might have to force, as I said. If you force too much, it's possible that it gets from the hub end into the microcatheter, but doesn't walk. In between it's somewhere in the shaft, it might stop, like my coil stop. And if you apply a brute force, it is possible that you wedge inject, and wedge injection might worsen the bleeding. It might also sometimes lead to just a loss, because it will be going as a projectile. It might just get out of the perforation and be lost into pericardium. The other alternative is, in case you had blood on the table, which you can take it out from a puncture syringe, where you have a blood which is there when it is not heparinized. But I think my practice nowadays is I just take out 2 cc blood, put it on the table to be discarded only after the patient is discharged. Sometimes a patient goes to the ward, and there you get a hypertension, you have a bleed, patient is still heparinized, so you will not be able to get a blood which clots. So 2 cc blood is taken out and to be discarded only after the patient is discharged. And this blood can be easily pushed through the microcatheter. If you look at it, the blood can very, very easily it can be pushed to the microcatheter. And all what is required is take the tip of the microcatheter to the site where you want to do the task. Here, the microcatheter was taken into the bleeder where we were supposed to send the coil. The coil could not be sent. So the tip of the microcatheter is there, and very gently the fat is injected, and you cannot see the trace of bleeder there. In fact, if you see very clearly, you can see the bleeder, but you can't see any blood leaking to the pericardial sac. Now we turned our attention towards a proximal bleeder, which is also a problem. It's still pain in the ass. If you look at it, this is in the zoomed PA cranial view, what you see, there is a prominent, but this is a static stain. This is generally a distractor. Don't look at it. Try to find any active leakage. Yes, there is an active leakage from the diagonal. So can you put a stent there? You stent graft there? No, because there is a big septal and a diagonal, and this is only LED. RC has not been revascularized. So you can't put a stent graft there. So wire goes into the diagonal, which is followed by microcatheter, just to delineate which is the site of bleeder. And if you look at it, no bleeder. Reason? It's possible that the tip is little beyond the bleeder. The bleeder may be just close to the origin of the diagonal. So pulled it back, brought it close to the origin of the diagonal. Cannot see the bleeder there. What to do? Pulled it back a little further. Now I am at the junction of the diagonal os and the LED. and you start seeing something. You seeing a bleeder. So surely not from the diagonal, but probably from some branch which is originating from the LED, just scroll close to the os of the diagonal, wired into that. But this time I'm not able to have a good wire purchase and microcatheter is not advancing. Now, unlike the distal bleeder, where when my microcatheter was not advancing, I advanced the wire into the pericardium. Why? Because there was one free bleeder. If my wire goes through that free bleeder, the only thing that wire will do is at least block that bleeder for a while. And the wire is entering to the pericardium, so it was already communicated. So if you then push the microcatheter over there, you are not doing any harm. But this proximal bleeder, to me, is more like a type 2 perforation. I am not seeing a very frank communication with the pericardium. Also, after sealing the distal perforation, the collection or the speed of collection to the pericardium was not too much. So I thought, no need to push this wire into the pericardium to get a purchase, because this bleeder, even if it is possibly communicating, it doesn't look to be coilable. So what to do? Chair and panels. I am stuck. I have a bleeder. I try to search from the diagonal, distal to proximal at the os, wire gone into the bleeder. Microcatheter is not going. I cannot take wire deep into the pericardium. So what to do? Well, I thought and I surely cannot put a stent graft there. Sometimes we have seen that if you carefully try to reverse heparin, like you give 10 milligram of protamine, do an ACT, give another 5 milligram, do ACT. Just try to bring your ACT from, which is often in such cases close to 350 to 500, 350 to 400, which we generally do in some long cases or in retros. So just try to bring it down. Once you bring it down, which in this case we were able to bring it down to 260, then because this area you cannot do balloon tamponade for a long period of time, because this is the only vessel here. RC is not fully revascularized, circ is small. So what we did was, once this ACT came to 260, we started to do intermittent balloon tamponade there. And that's what we got. Previous one. So if you look at it, everything is fine. Diagonal is flowing, septal is flowing. That bleeder into which microcatheter could not enter, just partial reversal of heparin, intermittent balloon tamponade did work. And surely, of course, your ACT doesn't have to come down to 150 and still have gears inside, because that will prompt a thrombus formation. So we were very careful. Keep running ACTs frequently and keep repeating your process. And this is not the only result. This was the result even after. So this result was static even after 6 hours. So what happened in this case? It was a hat trick of perforations, and that too in the LED, the major branch or major vessel in this patient. As I said, RC not well revascularized, and still you have the 3 perforations here. The most ghastly perforation which most of us are usually fearing is the body perforation. So we could deliver a stent graft just with ease, without any issue, with double guide, double anchor, and guide extension deep into it, deliver very precisely without losing the diagonal. And mind it, everything was done with speed and perfection, so that we didn't even require to visit the pericardium. We didn't require. However, this bleeder, which angio-wise looks to be relatively subtle compared to that mid-body perforation, here we required pericardiocentesis because there was no quick fix. Mid-body, there was a quick fix in the form of a stent graft. Here, the quick fix was not there. It took us a time to delineate as to what is a feeder, took us a time to take the microcatheter there, took us a time to deposition the microcatheter, and also many other steps. Failure, the microcatheter could not be delivered, then trying to revisit that area again. So even if the bleeding was not very fast, but because there was no quick fix, this resulted in tamponade, which forced us to get into the pericardium and aspirate. And this is what was the result. As I said it, coil failed, but biological material did work. And despite the fact this sealed the distal perforation, you see that the distal LED and the retrofill to PD is well maintained. And as far as this prox perforation is concerned, as I just now alluded to, that sometime simple partial reversal of heparin, taking care that you are doing, giving small amount of protamine and frequently checking, even if you have to do 5-6 ACT checks, doesn't matter. And intermittent balloon tamponade sometimes can result in bailing out from an unusual situation with the septal and diagonal preserved. So I thank you for your attention for going with the case.
Thank you, sir. Any question from the audience?
So I had deliberately kept one question which I didn't say. So what do you think was the cause of this proximal perforation? Yeah. So, but here is a see, taste of the pudding. You think it is not indicated. What should we do then? As I told you that if you try to push it with the back under the coil, what happens is the coil has a tendency, see, whenever you try to push a coil, the fundamental is the pusher has to be flat and the pusher does not have to be hard enough, because otherwise the pusher will tend to get alongside the fibers and get stuck. Actually, the question according to me, the question which I deliberately left was, what was the cause of, see, we understand the mid-body perforation, and whatever I may say, there was an error by me. The error was in choosing a balloon which was bigger, or a combination of a bigger balloon and high pressures, because arteries don't perforate. And this site, mid-LED, generally, even if you size it according to intravascular ultrasound, you can get mid-body perforation. If you look at the LED perforation, if you scan 100 LED perforations, majority of them will be the mid-LED. Mid-LED perforations are typically, I have scanned this in the literature, they are typically because mid-LED part often in a tortuosity up and a tortuosity down is intramyocardial, and whatever part of the LED is intramyocardial, not necessarily under a big muscular bridge. This part of the LED generally has a weak adventitia. In fact, the moment you support the arteries, if the arteries go into the brain, adventitia goes off. The adventitia goes off. The moment you support the artery from outside, the adventitia becomes weak. The mid-LED, even if it is not walking through a bridge, has adventitia which is weak, is more vulnerable to perforation despite you try to size it as you generally do for rest of the coronary tree. So that, I think the perforation was because of oversizing, which you size accordingly, but I think mid-LED part generally being weaker, it is better to undersize. Distal wire perforation, I think in a situation like this, when the perforation is there, you try to park your wire distally, and one was here, park your wire distally. Experienced operator should not have left the wire into some branch, but I left it. I think I was kind of overpowered by the perforation and trying to have the wire deep in. But generally these perforations is forgiving. In fact, many of the cases, if that distal perforation is there, people will happily coil even the distal LED, which was not possible in this case because distal LED was feeding the RCA. But I'll say both of these situations are preventable, and at least to some extent they are preventable. They should not have happened, but they happened with us. But what caused the proximal perforation? I did not deliberately keep it in the discussion. Yes. See, if you look at it, there was an aneurysm. This is exactly the same site. I told you, look at the diagonal arch where there is an aneurysm in the first picture of mine. The rota was there. The vessel wall at times, at some part of the circumference where your rota has a bias, will try to kind of do an injury to the vessel wall, which normally is not enough. But abnormal circumstances, it can create a problem. And what was abnormal circumstance here? It was only at the one edge. No, it was the guide extension as we passed. I remember the guide extension had stopped for a while exactly at the site of diagonal because of tortuosity, and then it walked deep. So this same place where aneurysm was there, same place rota made it weaker further, and the guide extension, like the rota, also had a bias, tried to walk into the aneurysm, and we tried to correct it by doing a bat onto the guide extension, balloon assisted tracking, and then the guide extension walked in very easily. So for me, I think the big message for me in this case is that no matter how experienced you are, you must always look for the size, preferably try to size it with intravascular ultrasound, and beware of sizing even with an intravascular ultrasound in the mid LAD. Try to be under 1. Second is, no matter what kind of a problem it is, always watch for your distal wire, which we always say, but I didn't watch in this case. And if you have had some kind of guide wire bias making undue movement of the rota at the site of aneurysm, your other things will also have a bias in that situation, which happened in this case because of that guide extension. Had the guide extension walked in with a bat, probably no injury would have taken place. This was a type 2 perforation by the guide extension on the outer wall or the right border of the LAD. So that is what is my explanation. Any other explanation if somebody wants to
When
do?
putting in a guide extension in a stent, the what is chances of deformity of a stent? Deformity of a stent can occur in many times.
Actually, no, this is a very, very valid question that if there is a stent already, then should you take your guide extension to it? I will say that till the time I was using GuideLiner, GuideZillas, and many others, I used to refrain from taking my guide extension into the stent. But ever since I have started to use Guide Plus 2, this is a very, very malleable catheter. In fact, this is this stent was delivered through a Guide Plus 2, which is a 5.5 French. If you look at a stent graft, you cannot deliver through a 6 French guiding. You have to deliver it through 7 French. I delivered it through a 5.5 French guide extension. Why? Because this Guide Plus 2 from Nipro is something like a snake. It is like Python. The moment your stent graft goes into it, it swells. And the moment it gets out, it shrinks. It's a very, very malleable catheter. And I just don't mind taking this guide extension into the stent or through the stent anywhere. And I find it almost never injures. But you should walk into the stent, or for that matter, any of the tortuously and calcified area with a balloon leading at the tip in the palm of balloon assisted tracking. BAT will kind of give you ease with which you can pass it, and BAT will also prevent many edge injuries which can take place with the guide extension. So your point is well taken. You also must take my point. No, let me just answer your question, because in fact you asked a very pertinent question. Whenever you're taking a second access, you have a hurry of puncturing the needle, puncturing the vessel. Once your needle and your wire is in, then you're at liberty. Then I think what should decide what should be the size taken? I think the largest possible size of the guiding catheter table, which your groin can take. Because this guiding catheter, which is the second guiding catheter, you don't need to take in. It has to be just brought close to the os. If it is big enough, sometime if you have a misadventure with the first guiding, even second guiding will be just good enough to take 2 balloons, do everything. So take big enough or the biggest possible guide. I generally, if I have I always take 8 French guide, because through that you can, in an environment when most of the time you'll take ox balloons, ox wires, and so if you take 8 French, with great impunity you can take rest of the hardware.
And second point is, now in case of calcified lesion, when there is a stent under expansion, now people think that if there is a stent under expansion, they pass the EVAS, they take the ratio of the vessel diameter to the luminal diameter, which has been achieved after stent inflation. And the point is that they say that if that ratio is more than 1.8, it means the risk of perforation are high. So you have to be ready and you have to undersize your post-dilatation balloon. Is it true? Because we have not that much of experience.
According to me, if you have calcification, then this is a good recipe for perforation. And if it is a calcification in elderly, fragile female, I think it's a pakka recipe that you will get a perforation. So you should be ready. Now, how are you ready? First is you must learn that you have to accept sometimes suboptimal results. If a stent is underexpanded to the extent of 30%, people have seen heaven doesn't fall. So your eyes and your brain should be accustomed to accept suboptimal results. That is after you have done the procedure. But I think if you have seen a calcification, if you've seen a trouble, I think upfront you should try to modify the lesion. If you try to modify the lesion with whatever you have, your life is going to be much, much better. But let us say you have modified, you've done whatever, you've done a rotational or whatever you have done, IVLs, and finally, again, your result is not excellent. Just try to see what is the MLA. If your MLA is reasonable, you must weigh and choose 100 times before you want to go up with the size and pressures of the balloon. Am I clear? So there is one from Dr. Jha.
Thank you, sir. Yeah. Thank you, sir.
Thank you.
Next is Dr. Pramod Kumar from Vedanta. He will speak on how to manage slow flow in primary PCI. Case with.
Next.
Our next speaker will be Dr. Purushottam Kumar from Sitamarhi. A case of refractory no flow, Numra saved my day. Dr. Purushottam.
Good evening, everyone. The topic is a tale of recurrent stent thrombosis. A 42 years female who was non-diabetic, non-hypertensive, presented in the emergency department with ST elevation in inferior lead. She presented in the time frame of less than 3 hours. So there was no regional wall motion abnormality. This was the ECG showing ST elevation in lead 2-3 AVF. And this was the CAG, which was showing 100% RCA cutoff from the proximal part. And I did a wiring with a cyan blue wire, floppy wire, and I got a flow pre-dilated with a 2 into 10 mm balloon. And the flow after pre-dilatation was good. I took a 3 into 24 mm biomime stent. I inflated the stent, post-dilated with a 3.5 into 8 mm, and a TIMI3 flow was achieved. Post 4 days, patient came again with a history of chest pain. There was no ECG changes, and echo was also normal. But just the check angio can be done in this case, considering the patient is having chest pain. I did the check angio, and the patient was having a stent thrombosis. So 100% it was occluded from mid part of the stent. I did a coronary wiring again with a cyan blue wire, dilatation with a 2.2 into 10 mm balloon, but still thrombus was there, and pre-dilated again with a 3.0 into 8 mm balloon. But there was restenosis or a thrombus just after the stents, and the patient was complaining of chest pain. Due to paucity of hardwares like thrombosuction catheter or DEB balloon, in view of the chest pain, I just did a second stenting, and I covered the area which was showing the restenosis, and I positioned the stent overlapping the luminal area, and a TIMI3 flow was achieved, and the patient was normal. During the procedure, 9,500 units of heparin was instituted. I gave a cocktail of tirofiban, Nicoran, and GTN during the procedure, and post-op tirofiban infusion was also given. But the next day, again, after in the morning, the patient again had a stent thrombosis from the proximal part. Then the patient lost hope on me and wanted to go to a higher center. Patient landed up with Dr. UN Singh, and he did a drug-eluting balloon here. After doing the drug-eluting balloon, again the patient had a stent thrombosis the next morning. So he again wired the stent, and he decided to put a big stent covering the proximal part to the distal part, and he achieved a good TIMI3 flow. And again, after 7 days, patient again had chest pain, came to my center with no ECG changes. But this time I did not do angio. I just gave her ample amount of anti-anginals. But she was having a recurrent stent thrombosis, and even after 3 or 4 times of intervention, she again landed up with the same condition. Thank you. Sorry. Patient is alive.
Patient survived.
Dr.
And I did the but there was a lot of numbers there. There was a stent under exercise. So I thought the already two stents were there. So I did not want to put another. So I optimized the same method. Optimized did the multiple times, and ultimately I put on the antiplatelet drugs and the heparin, and again after 2 days the patient had a recurrent chest pain. Now again I did the IVUS, and see there was still there was some there was a gap, and basically a lot of thrombus was there. So IVUS was not very much informative in this setting. So now this time I put a long stent right from the covering the proximal end to the distal end. So now the patient had was already we have the 3 months follow up, and she doing good.
Dr. Purushottam, thank you for showing such an excellent case.
Antiplatelet are ticagrelor, and you know.
So was there any relationship with the medication in this patient? Any loading
The
medication?
loading dose was given with ticagrelor and ecosprin.
It might look bad to you, must bite you also. If at this platform you say I had no facility for thrombosuction, I'm really sorry. It's because you said you had no facility for thrombosuction.
At the second stenting.
Wherever, at whichever center. See, most of the practice which we have is primary PCI. And a center which does not have a facility for thrombosuction, I'll say that whatever the trials might tell you, thrombosuction is one of the most important armamentarium. It at least tries to debulk.
Yes, sir.
Number one. Number two, it's fine that you have ended up in 1, 2, 3 stents and increasing the length and the whatever. And finally, things are fine. Many times the whole myocardium gets dead and the patient remains asymptomatic, and you do an angiogram later on and you find that RC is occluded. So each time you get a stent thrombosis, if you have not done a good thrombosuction, what you do is you clog the distal circulation. If you clog the distal circulation, if you go by the Verco's triad, one very important thing is flow. The flow is always weaker if you have not taken care of the chunk of the thrombus. If it is short into the distal circulation, your TIMI flow might be 3. I'm not saying not TIMI 3 flow, but TIMI 3 flow, beyond the TIMI 3 flow, you have what? Frame count, TMPG blush grades, and so many other things. So you have just stopped at TIMI 3, you feel TIMI 3 is okay. I will say TIMI 3 is not okay. Every time you get a thrombus, every time you shoot it into this distal circulation, you're only making things from bad to worse. Second thing is, thrombus is forming on the top of not a vessel wall, it is forming on the top of a metal. If you're trying to treat a thrombus with 1 metal and 2 metal and 3 metal, it's okay that finally patient जिंदा है. तूने बोला कि जो जीता वही सिकंदर, जो जीता वही सिकंदर. But in such a situation, I think there is absolutely no doubt in my mind, you should try to get rid of thrombus as much as possible. Number one, if you have a facility for imaging, try to find out as to what was wrong. Was it that the patient was antiplatelet naive, or the antiplatelets were not given well, or they were not functioning? Should it be ticagrelor, or should you go to Prax? I think that should be thought of. During the procedure, you can think of kind of loading these patients with cangrelor and giving 2B3 inhibitor injectable to these patients. And finally, in such cases, it means if I'm treating this case, and angiographically, unless you have an excellent flow, even if there is some marginal irregularity, that will heal. But if the margins are smooth, distal flow is not very good, by varicose triad, you are again inviting one more thrombus. So I will try to kind of avoid a thrombus, a stent as far as possible, unless during instrumentation you created an injury to the proximal or distal vessel and there is a flap which needs tacking up. I think these are my comments.
Thank you, sir.
And
The answer is, I will see the
if
answer.
it has bitten you,
Mine
I will
is-
like it. You give me your volley of question. We give them provided everything is formed right in front of your eyes. And if thrombus is formed right in front of your eyes, it is the platelets which form thrombus first. The fibrin has to do the job later on. So if a thrombus is forming right in front of your eyes, we started with Riopros. Now Riopro is out of the market most of the time because it's costly and so many other things. But we have the other intermediate molecules. They can be given and they are very, very effective, and they are relatively safer compared to the shooting a thrombolysis shooting a thrombolytic agent in a young patient. We do it sometime, and if you have to do it, I'll tell you my way of doing it. What I do is, because this artery occluded for 5 minutes, 10 minutes, 20 minutes, 30 minutes, patient didn't die. So this patient will tolerate an occlusion of the right coronary artery for some time. So what I'll do is, I take a 4 millimeter balloon, make some perforation in the distal end of the balloon, inflate the balloon proximally with dye, shoot the dye. That dye will show you the balloon is inflated and the dye is filling the distal column. And with the inflated balloon, the dye does not go out. Now, having experimented this, now I will give thrombolytic through a balloon which has perforation distally, so that my thrombolytic agent is parked into the right coronary artery, and I do not necessarily need the full dose. Like nowadays, we are commonly using TNKs. Anything between 5 to 10 milligram of TNK does work in these cases. You don't have to go to 30 to 40 milligram of dose.
And in two patient I did, my experience was the patient developed CSV and transient this. So
Oh, did you use TPA or RTPA?
RTPS.
RTPA, let me tell you, RTPA is very, very notorious for rhythm problems. If you give IC RTPAs, VTs and AV blocks are very commonly seen. That is not to be given
Yes.
IC.
Thank you.
Thank you, sir.
Dr. Purushottam, what was the final LVF?
LVF was preserved, sir. Yes, sir. The last time she came back to me, again, I did a echo. ECG did not have any changes. But
Finally, you did not get TIMI3 flow?
I did not repeat the angio the last time she came. I just increased the anti-anginals, and I also added a NOAC to her drug therapy.
So thank you, Dr. Purushottam. So
Thank you,
patient is surviving, doctor is also surviving. What was the size of the stent initially you have put? 3 and 2. Did you did the post dilatation? So our next speaker is Dr. Ram Sagar Rai on undue hardware struggle. Dr. Ram Sagar Rai.
Good afternoon to all seniors, teachers, and delegates and friends. And this is my topic is now undue hardware. Next slide. A case history. ठीक है यहाँ से ठीक है a 60-year-old female known case of type 2 DM for 5 years, hypertension for 6 years, having history of chest pain on exhaustion. She came in OPD and planned for angiography. Angiography done and revealed that double vessel disease, RCA 90% mid and near 80% distal lesion, and other vessel was LCX, that is 50%. Patient belonged to poor socioeconomic status. So by PMJY, we plan Yojana, we plan to do PTC to RCA. She was short stature, female. We took first right radial access, but just after a few minutes of CT session, radial spasm occurred. So we have switched to femoral route. By femoral route, 6F hemolysis taken, 6 JR guide, 3.5 guide catheter. That was aux guide hooked to RCA. A routine wire, the BMW wire, PTCA guide wire was cross the lesion and parked in distal RCA. This is the angiogram showing the mid lesion and distal lesion. The two significant lesions that are showing here. At first, we have taken 2.5 12 millimeters SC balloons taken for P dilation. The wire, the balloon was not crossing distally. We have planned to pre-dilate the distal lesion, but balloon was not crossed to distal lesion. So, for that we have pre-dilate the mid lesion twice and thrice. The guide support was poor, and we have to stent long two lesion on distal and proximal. So we thought we should take at least one body wire. So we take another wire, PTCA wire, that all star. Just after putting the second body wire, there was we have seen this lesion, a dissection at the distal point before the distal lesion. Patient started steaming on tables. He complained of mid-external chest pain and became restless. The atmosphere became tense. Cath lab technician staff put in a lot more and made ready with TPI support and DC cardioversion. Panic continued. Now we took another 2.5 12 millimeter subcassive balloon to pre-dilate the dissected part, but balloon did not reach the target level. So we thought that balloon might be defective because we have used the aux balloon. So we took another new balloon that was of 1.5 to 10 millimeter. The new balloon did even not cross the target lesion. So we thought that there may be some problem in the wire already were used in this. So we thought that change the new balloon did not cross the mid lesion because the PTCA might be defective. So by the help of the fine cross, we changed the aux BMW wire to new BMW wire. The fear of the complicating the dissection segment, we use the fine cross to change the defective wire. And now wire has been new and the ballooning has been done. The wire is now new, so we plan to stent the distant dissected lesion because patient was restless and pain was continuing. So 2.5 into 32 millimeter drug-eluting stent to cover the dissected distal lesion, but the stent did not come out from the distal third of guide catheter. So at this point, we thought that since we were using aux guiding catheter, so we thought there might be defect at the guiding catheter distal third. So finally, we changed our plan to exchange aux guide catheter to new one. So the problem was that the patient was in severe chest pain with restlessness, and we were in fear of losing wire access from the dissected segment. So we had taken now we have to change the guide catheter, and patient was in pain and the lesion was dissected. So we thought there were two options there at that time on the dock wire. Other is another 360 centimeter PTCA wire. So with the help of the fine cross, we exchanged the previous PTCA wire. At last and finally, we put two stents, one at distally, that was 2.5 32 millimeter and approximately 3 into 36 millimeter drug-eluting stent. Both the stents deployed nicely and post-dilatation done nicely. And this is the final result, which was perfect with slight dye staining at the distal segment. But and patient symptoms subsided. And we also comfortable. So take a message of this discussion in that as much as possible avoid aux hardware in cath lab. Try to avoid PTCA wire with higher tip load for better support as body wire in the tortuous coronary artery. Take routine PTCA wire as much as possible. Distal third of guide catheter is the most frequent point of hindrance due to repeated use of hardware through it. And the long PTCA, 360 centimeter long PTCA guide wire may be helpful in pathetic nightmare condition for guide exchange. Fine cross microcatheter is valuable hardware that can be used even in dissected coronary segment. Be careful, not only PTCA balloon, PTCA wire, but aux guide catheter may be problematic due to frequent use. Thank you, sir.
The only the hindering finding was you are using the ox thing.
Yes,
Then
sir.
there will be problem. I feel that there was a calcification. Calcific nodule is most probably the cause of the balloon was not crossing that point.
Yes, sir, maybe, sir. In mid lesion, there may be calcium that were not causing. But sir, balloon, we have used box early, then later on we use new balloon. We change the wire also. That were not crossing. And last we have seen that the stent was not coming out from the distal third into coronary artery. So the repeated use of the angulation of the catheter where it bends, it may be the problematic.
I think, Dr. Bharti, the problem was mainly the guide support. See, if you look at it, your RCA is going down is fine. But look at the os. After the os, the RCA is taking off for about half a centimeter or maybe a couple of centimeters. Not half a centimeter.
Maybe the problem.
It's going a little up and down. Your guiding catheter all throughout, even when you change the guiding catheter, it was looking downward at the os. If a guiding catheter looking downward at the os, then if the task is difficult distally, either it's a long segment, tight, calcium or whatever, then these guiding catheter will almost never give you support. The simple remedy for these situations is you extend the guide. The moment you extend the guide, that proximal upward part goes away, down everything has to walk through it. Otherwise, I think if I were in your situation, I would have taken a employee guiding right from the beginning. And if the employee guiding was there right from the beginning, I think the task would have been very, very easy. It was finally, what did you do? Almost nothing. But I'll give you 100% marks for being able to change the guiding on that wire, because I was sitting here and talking to Dr. Pramod that now the wire, this will be very difficult for you to exchange the guide. So that means skill set is there. If somebody could change the guiding catheter on a wire which was like this, so that means skill set is there, probably thought process is not correct. If you had a employee guiding or if you had extended the guide, that life would have been easy. Sometimes these cases can be done through a bigger guide with a small guide, like 7 French guiding with a guide extension through it. At times, such cases can be very easily addressed by even a 5 French guiding. And 5 French guiding, how do you do is take a balloon distally into the lesion. Once you inflate the balloon, take the 5 French guiding into the lesion. So that becomes your guide extension. If you're not using a 5 French guiding, you're using a 6 French, then again, what you can, because this was a pretty big size os in the proximal right coronary artery. So if you inflate a balloon in the mid RCA, wherever you're finding difficulty, anchor the balloon and intubate your guiding into the prox RC. Then I think the life would have been very easy. The issue was your guide is never sitting into the ostium, is always looking down. So all your hardwares, the moment they find a difficulty, they kick out the guiding. Not the ox guide.
The other thing is that if you have to exchange the guide, you could have taken a regular Teflon wire.
Yes, I
and
have
then
changed.
exchange it over that. Then it is much safer. Your guide, the coronary wire would have stayed, because this is what Dr. Rehan was saying, that this is going to come out. But because this was a 300 centimeter, you were able to change it. But you put a Teflon wire, regular Teflon wire, over that you can change the guiding.
Have you understood it?
Yes, sir.
Have you understood it? The message is that if there is a PTC wire, then if you try to exchange your guiding catheter on a PTC wire, it's a lighter wire. So if you want to increase the support, the simple thing is just take a 3-5 wire alongside. You park a 3-5 wire into the aortic sinus. Now your guiding catheter till the aortic sinus will easily go on to a 3-5 wire. After it has gone there, pull out a 3-5 wire. Then if your guiding catheter tip is at the aortic sinus, all what you have to do alignment into the RCA, then you can do it very easily on a PTC wire.
Yes.
Taking the guiding all along till the aortic sinus on a 1-4 wire is difficult. So
Thank
that
you,
part can be made easy by doing that task on a 3-5 wire.
Thank you, sir.
Thank you, Dr. Ramsagar. For the next speaker is Dr. Aditya Bhaskar from Guwahati for stent embolization.
Yeah, good afternoon, everyone. So this is my case. Where is my stent? My case is 72-year-old hypertensive male presented with non-STEMI. Troponin I was positive. ECG was LVH without significant STT changes. Creatinine was 1.7 and echo was mild LV dysfunction with mild mitral regurgitation. So we took for coronary angiogram. We can see that RCA, there is some intermediate disease in the proximal to mid part and critically stenosed at mid part, and there is TME2 flow in the RCA. Similarly, left system, left main was normal. Some intermediate disease at ostial LAD and mid LAD has significant disease. L6 is free from any significant disease with too much of tortuosity. So it was a 2-vessel disease with syntax score of 16. So we planned for PTCA plus 10 to RCA and LAD. I choose RCA first. I don't know. Both lesion was equally significant. So it was not looking a very complex case. So I started with JR guide and run through NS in RCA. So I could not cross any ETO balloon. So then I took 2.5 into 8 mm semi-compliant balloon and pre-dilated. After pre-dilatation, the result was not good. So I tried to negotiate the same balloon distally, but the balloon was not crossing. So I did more pre-dilatation by 2.75 into 12 mm NC balloon. Result of pre-dilatation was more or less good. I thought, let's give a try for a stent. So I took a 3 into 40 DES to cover the lesion. However, as expected, DES could not be negotiated. To facilitate DES delivery, I did some deep guide engagement and I tried to push the stent, but stent was not going. So I thought we have to predilate more the lesion, we have to prepare it well, and we may need a guide extension support for stent delivery. But stent was not coming out. Then I tried to pull the whole assembly. There was some more resistance, but now things was coming back easily. But what we left? So there was a stent stuck inside the coronary artery. Stent was partially in the right coronary artery and partially in the aorta with no wire inside. So this was a case of total stent and guide wire loss. So we have only option to snare it. So I took a gooseneck snare, snare and tried to snare it. With some difficulty, I could catch hold the proximal part of the stent in multiple attempts, and I took it gently because there was fear that if any stent is deformed, it may injure the ostia or proximal part of the right coronary artery. But main problem was at the femoral site because we know that the stent was not inside the guide. So when I give a gentle traction at the femoral end, the stent got elongated and luckily came within the sheath, and then it finally came out. So I did check angio. There was significant residual disease at the proximal RCA, which was more visible in the epicranial view. Then I did 1:1 pre-dilatation with 3 into 12 mm NC balloon, and I deployed a smaller DES of around 3 into 24 mm, and it post-dilated with 3.5 into 10 mm balloon. So this was the final result. There is some residual disease at the distal end of the RCA, but I thought that this is not my day, so I left that. So what went wrong? There may be some stent manufacturing issue because multiple reports were at that time from different places. It may be procedure related because proximal lesion was not well prepared. But to be very true, I was not very harsh during the procedure because I knew that this stent is not going to go. So I had to prepare the lesion well. I just did a little deep intubation of the guide with gentle push. But I did some bigger mistake, which I realized later that I did not upgrade the sheath. Ideally, we should upgrade the sheath to 8 French or larger side for easier removal of any foreign body. And I forgot to take an angiogram from the sheath to see the integrity of femoral artery. So take-home message is adequate lesion preparation is the key element for successful and uncomplicated PCI. In case of ambiguity, always take a different view for more clarification, at least angiographically. Imaging could have given a better picture, and don't forget to upgrade the sheath in case of lost foreign body and take a sheath angio after retrieval. Try to maintain guide wire position, which was not in this case, and snare is an essential armamentarium of any catheterization laboratory. Because this was not my regular cath lab, I went just for a call and asked that whether diffuse is there, covered stent is there and snare is there. Then they said yes, then I'll only proceed for the case. So coronary stent loss, maybe partial stent loss, maybe total stent loss with guide wire in situ, total stent and guide wire loss, or stent loss in aorta. So in case of partial stent loss, we can inflate the stent balloon or we can put a smaller smaller balloon and we can inflate at 2-3 atmosphere and we can retrieve the partially lost strand, which is visible in this video. I think it is too long. So after just inflating the smaller balloon, we can pull out this. So the other method is like sorry, it's not coming. Another method is like you can put a 3-4 wire in the around the stent and you can entangle it the stent and you can pull the stent in total. So this is a snare technique in which we can take a coronary micro snare, we can catch hold the stent and we can take the stent inside the guiding catheter. Yeah. So this is called multi-wire technique in which multiple wire usually taken around the stent just to grasp it and we can take out the stent. But these cases when the stent is inside the coronary arteries. After multiple rotation of the wire, we may be lucky enough to get hold the stent and take it out. So another option is we can crush the stent inside the coronary artery. So there are different methods of snaring. This is important. You have to catch hold the foreign body in the proximal end, not in the midpoint, because in that condition, it is very difficult to retrieve it out. So there are some other technique, that is distal grab technique, in which you can cross the wire through the foreign body and you can grasp at the proximal distal end. So these are the techniques. And finally, if the stent is in peripheral aorta, if it is in carotid, you have to contact the neurologist. If it is in below the femoral artery, it can be left for conservative management. Thank you. Yeah. Yeah, it was SMT stent.
When you decided to snare it, I would have taken another guide, put a wire, because when you pulled out, the right coronary artery was unwired.
Yes.
It was unprotected, it could have closed.
I just tried, but at that time I thought, sir, from where I will increase the guide, because half is the stent, half is the coronary artery. That is the actual approach what is written in the textbook. You have to take another guide by.
No, in fact, this what Dr. Pramod pointed out is one of the most important things. The moment you have caught the stent and you have taken it down beyond the arch vessels, कोई emergency नहीं अब है ही नहीं बिल्कुल भी. चाय पीने चले जाओ, कॉफी पीने चले जाओ, सुसु करने चले जाओ, कोई दिक्कत नहीं है. At this time, what happened to your right coronary artery? In fact, before you want to start all this business, take it second access. Take and वो सब कुछ नवा होना चाहिए. Second guide, which should be sitting very close to your ostium of whichever, left, right, whatever. सब कुछ नया guiding, नई wire, सब कुछ. The moment you catch it and you are like this, either you or your colleague should shoot into the vessel, which playground जहाँ भी था, and wire that area. Once you have wired that area, in case things are not very happy, इस टेंट को जो नहीं निकल रहा है छोड़ दो कहीं भी नीचे, वहां काम करके आओ पहले. Because this is the biggest mistake. You become totally engaged into the groin. यहाँ से नहीं निकल गया, फंस गया, उधर से पेशेंट को suddenly arrest हो गया, CHB होके. Because हो सकता है कि 5 मिनट पहले वो viable हो, stentable हो, सब कुछ हो. So I think this point, what Dr. Pramod said, should whatever you should, many things, they are all beautiful things. The first thing is have a second access, go up, and then, as I told you. Second is, in case, let us say you have caught it. You have caught with whatever, and at the groin you have a 6 French sheath or a 7 French sheath, and the system is not coming. Then how do you upgrade with your wire already onto a snare? How do you upgrade your system to a 8 or a 9 or a 10 French. Can you do it? Have you got the question?
No, sir. I could not
See,
get it.
you did not, first of all, you did not think. Ideally, you should have started with a bigger guiding catheter and a bigger sheath. Let us say you have not started, you have started with a 6-7 French sheath and a 6 French guiding catheter there. You've taken an excess from the other side, you have reached also there. You have caught a stent, you have brought it down, it's not coming in the sheath. Okay. Now, pakad to rakha hai usko. Now, if you have caught it and your sheath is not bigger in size, then how to upsize the sheath?
Opposite side, sir, we can take.
So you finish the task from the opposite side. Whatever wire is there, you go from the opposite side and bring it down. This is one. The other is sometime if your stent is on a balloon, not on a snare, on a balloon, sometimes the stent comes on a balloon and it's come down, it's not getting into the sheath. Then you cut it at the hub end. Cut at the hub end, take out the sheath, 6 French sheath or a 7 French sheath from the groin. Now you have a cut end of the balloon catheter and a wire. Both together will not go into a dilator of a 9 or a 10 French. So you cut the dilator close to the tip, usually about 2 or 3 inches close to the tip, just before it starts to taper. There the internal lumen is bigger than the internal lumen near the tip. So if you cut the dilator couple of inches proximal to the tip, there the lumen of the dilator is bigger. So it will take both a 1/4 wire as well as a shaft of the balloon and you can advance over that. So that's how you can, despite the fact your system is there, you are precariously balanced, you can still change it.
Thank you. Next presenter is Dr. Nirav Kumar. Abrupt closure vessel during angioplasty. Bro.
Good evening, everybody. So this is a case. So he is 72-year-old male, diabetic. ACS happened 15 days back. Non-ST elevation MI. Non-ST elevation MI managed conservatively. Presented with angina on grade 2. Echo revealed LVF of 45%. So this was the angiography. There is a lesion in the OM major at the proximal end. And there is a significant lesion in the LAD artery in mid portion. And RCA, there was minor plaque. There is no significant lesion in the RCA. So we thought that we should open the culprit artery first. So I took the run through wire. So run through wire was So run through wire was not passing. So I took the whisper wire because there was track in the artery. So I took the whisper wire. During passing the whisper wire, I suddenly noticed that there was complete closure of that artery during trying to pass the lesion. So, but there was minimal symptom. Patient was not symptomatic at that time. So, and I tried everything, but whisper wire was not crossing. So I took this CrossFit 200. So initially there was some resistance, but the CrossFit was, the CrossFit crossed the lesion. With CrossFit, I crossed the lesion. And there was good tip movement also. So it passes from the artery very well. Then I took 1.5 into 8 balloon to dilate the artery at that point of time. Then I took 2. So this is I'm doing dilatation with 1 into smaller balloon. Then I took 2 into 8 balloon to open the artery further. So, but this balloon was not going through the lesion. And in the meantime, I lost the wire access also during the pushing the balloon. And I gave the dye, and there was no flow seen. So I took several wire after this, but every time the wire was going into the same track, and it was not opening. After several attempts, I noticed that patient became symptomatic, and there was some STT changes also. So even after repeated attempt, repeated wire, this was not opening. So I talked. I talked with the surgeon. So he was ready for the graft. So this was the final shot. So then the surgeon put the graft in LAD in OM artery. So patient is surviving after the operation. So patient selection is important. It was benign looking lesion, almost type A type of lesion in both the artery, but it was ACS setting. Most probably during the initial effort, the thing get blocked with the clot, and after repeated trying, wire was not crossing. Most probably it was zigzag separate lesion. That's why the wire was not crossing. And wire escalation, initially I took the workhouse wire, then I took the whisper, then I took the hard wire. So hard wire goes into the false track, and every time when I was trying after that, the wire was going on the same track. So that's why the things, and I think the persistence is required in such a cases. And I think we have, if we have we can afford the surgeon, and if surgeon is ready, so better to give, because there was significant lesion LAD, and there is a block OM artery also. So I sent this patient for the. So this is Hippocrates quote. It is painful thing to looked at your trouble and know that you yourself and no one else has made it. Thank you.
What was the cause for this abrupt closure? Balloon dissection or wire dissection?
So abrupt closure, that was zigzag separate lesion. Wire has closed. The initial wire has closed, but it was not crossing the lesion comfortably, because that was as separate zigzag lesion. That's why support was not there. Then I think I will take the whisper wire, it will slip away from the zigzag shape. So during the trying, the flow was get blocked. So most probably initially there was snow plowing because of the thrombus, and later on the false track, and every wire was going into false track. That was the region of complete closure, abrupt closure. So LAD, there was significant lesion in LAD, and patient was symptomatic. There was some pain after the dilatation. Yeah, that is the possibility, but the work can be done half because OM is left. So
Because that is not a big OM, sir. It looked like just intermediate size vessel probably.
So it was intermediate. It was good size vessel, almost half of the LCX artery.
Second thing, most likely wire might be in dissection flap. Probably that is the reason balloon is not going.
Yeah, definitely. Initially, dissection flap was made because of the size of the lesion, and after that, everything was going into false flap, the new flap.
Thank you. Thank you, Dr. Neura Bose. The next presenter is Pramod Kumar from Artemis Hospital. Pramod Kumar, topic is complication during bifurcation stenting in ACS.
Good evening, everyone. So without delaying much, I'm going to start my topic, which is dissection during bifurcation stenting in acute coronary syndrome. Little bit about bifurcation stenting. It is around 16 to 20% of the PCI done worldwide, and the procedural complication noted is around 9%. The restenosis rate is as high as 36%. So most of the time we prefer provisional stenting. Coming to the case, my case was 15-year-old female patient, hypertensive since last 10 years, presented with sudden onset chest pain and sweating for 6 hours. Following initial treatment on the line of acute coronary syndrome by local physicians, he was referred to us for further management. In general examination, the blood pressure 110/70, heart rate was around 110 per minute. In the respiratory examination, there was mild basal collapse. In ECG, there was ST elevation in V1 to V5. Creatinine was normal. In echo, there was hereditary hypokinetic with ejection fraction 40%. So we immediately took the patient for coronary angiography. And in coronary angiography, we found LMCA was normal. The type 3 LAD, proximal to mid LAD, there was diffuse disease with maximum 90% stenosis. And osteoproximal diagonal, there was 90% stenosis with Medina 111. In L6, mid L6 was 60% stenosis. The RCA was dominant artery and there was mild plaque in mid RCA. If you see the angio plot in the LA caudal view, the mid LAD has diffuse disease with maximum 90%. In the osteoproximal diagonal, there is around 95% stenosis with distal TIMI2 flow. So in this patient, we plan to do bifurcation stenting to LAD and diagonal with DK crush technique. We taken the 7 French EVU catheter. We crossed the BMW wire in the LAD and took the Sion blue in the diagonal. We dilated both the lesion with 2:10 semi-compliant balloon. Then we stented the diagonal with 2.75 into 18 Ultimaster Tansei. And we crushed the stent with 3:10 non-compliant balloon in LAD. Then we finally did the first kissing with 2.75:10 NC and 3:10 in the LAD. Here all the nightmare started. After the first kissing, there was dissection in the proximal LAD after the first kissing. The dissection further increases, it partially closes the flow in the LAD. So without delaying, we immediately stented the distal LAD and the osteoproximal LAD. Distal LAD with the 2.5 into 38 and the osteoproximal LAD with the 3:21. Then we rewired the diagonal segment through the LAD strut. We did the post dilatation in the distal LAD with 2.75 and the osteoproximal with 3.5:10. And finally, we did the final kissing with 3:10 in the LAD and 2.75:10 in the diagonal. So this is the final shot. In the mid diagonal, there is also 60% stenosis, although the patient was acute coronary syndrome. So what we can achieve? So take home message, coronary dissection is the potential complication of angioplasty and the risk is not always avoidable. By proper balloon selection and technique, we can avoid overinflammation and can prevent dissection, avoid deep catheter intubation, and gentle contrast injection are crucial. Careful guide wire manipulation, avoid aggressive guide wire movement, ensuring proper wire tip positioning is important. And most important thing, keep yourself calm during the complication and patiently think about the solution. Thank you.
You will manage complication. Usually proximal part you have it dissected. What was the reason for the?
So after first kissing, we observed the dissection in the proximal LAD. Most likely, I think overinflation.
Yeah.
Yeah.
The balloon is out of sustain. Sometimes it will inflate.
It was
During inflation, be careful. during in-stent dilatation that never we slip out the balloon from the stent part. This is one of the important cause of the proximal dissection. And this is, but you have managed very well. Thank you.
The crossing was done with a ANSI. sir. Thank you.
Okay, thank you, Pramod. And the next speaker is Jishan Mumtaz from Muzaffarpur. Topic is LED perforation.
Thank you, sir. Thank you for having me here and letting me present my case. I'll be presenting a short case regarding a perforation in LED. A relatively simple case to begin with, but it cascaded into a lot of things which gave me nightmares for a long time. But anyway, so we start with a 65-year-old hypertensive male. The patient was known to me. So it was a case complicated both professionally and emotionally as well. So he presented with a history of rest angina, sweating, and nausea for the previous 2 hours. ECG was showing hyperacute T waves and a mild ST elevation. His echo started showing some regional wall motion abnormality in LED territory, and troponin was elevated. So it was a clear case of anterior wall MI. Considering it was an anterior wall MI and a primary PCI, we straight away proceeded with using a 6 French EBU guide from a radial route. So which was showing that almost mid to distal LED being diffusely diseased, as we can see in this angio. So LCA was already engaged with the 6 French EBU 3.5. It was wired with a run-through wire. So there was a little difficult wiring, but with the help of balloon support, we somehow managed to put the wire into the LED. Daughtering was done and some pre-dilatation done. Then check angio showed that this vessel had not properly opened up. So a repeat pre-dilatation was done with the same balloon, but this is when things started to get little anxiety inducing. So we have a first evidence of puff of leak from somewhere from distal part of the coronary artery. So first step, the balloon was it's in the guide itself. So we advanced the balloon and placed it at the probable perforation site and gave a prolonged balloon tamponade for at least 3 cycles for at least 10 minutes. So the perforation is getting severe as the time is progressing, and we kept repeating the tamponade at least 3 times, hoping that somehow this perforation will seal off by its own. Echo machine was brought up. Echo started showing some collection of pericardial tamponade, not tamponade, pericardial effusion, but this collection seemed static. It was not progressing, and there was no evidence of RARV diastolic inversion. So although the pericardial kit was prepared, we did not go ahead with tapping. So now coming to the algorithm for for a case that comes to us for perforation. First, we try and do a balloon tamponade. If the patient is hypotensive, we start with IV fluid and vasopressors, pericardiosensitis if needed, and we notify surgeon. In our case, we don't have surgeon, but I am fortunate to have another colleague, so we always call for help. So the extravasation was persistent. The 3-4 cycles of balloon tamponade did not help in sealing the vessel. So the options are we put a covered stent or we put a embolization coil. Now on ourself we have the Graft Master, and Graft Master has a larger crossing profile. And since we had started with a 6 French guide. We had to do take a second puncture from the femoral root. This time we took a 7 French puncture. We took a 7 French EBU 6.5, sorry, 3.5, and we chose to go ahead with a ping pong technique. So with a 7 French EBU, we are trying to wire into the LED. Through mild success, we managed to get somewhere near the balloon, but no matter how much we tried, this wire did not go into the desired area. So even with the second balloon, we took another balloon. We tried buddy wire, second balloon to support the BMW wire, but the wire did not go into the desired vessel where we were targeting it to go. So now when we're attempting with the 2 different catheters, 2 different balloons with 2 different wires, this led to the dislodgement of the entire assembly. So we lost the access, wire access to the LED that was already there. So we already had a 7 French guide and we had to rewire everything. So we did away with the radial guide, and we engaged the LCA with a femoral guide. There was 7 French. So we thought that since the caliber of the vessel wasn't very great, we thought we'll put a Guidezilla and attempt to ensure a smoother delivery of whatever we planned, whatever hardware we wanted to put. So we took a Guidezilla and kept it at the tip. We took the same 2.5 balloon that we had used. We tried to place it at the perforation site. So with that, with that balloon support, somehow we thought that we had wired correctly. So the balloon was kept, balloon inflated, and the perforation site was kept worsening, it kept whipping. So with balloon support, we managed to put the Guidezilla, advance it distally, at least till the mid LED level. Now with the Guidezilla directed shoot, the perforation looks horrible, and the leak seems to go in all places possible. Okay, so now we had Graft Master. Graft Master comes in various sizes. Since it was a distal vessel, this lowest caliber that is available with us is 2.8. So we advanced the 2.8 vessel. We thought we have placed the vessel correctly. Now again, coming back to the covered stent, there are 2 types of stents. One is the PK Papyrus by, I think, by Biotronic, and Graft Master by Abbott Group. So PK Papyrus has a shorter crossing profile, so if we can use in isolation, can we even be put through 5 French. Graft Master, if used in isolation with no other hardware, can be put with 6 French, but it is advisable always to use at least 7 French when using graft in covered stents. So these are the various sizes that it comes in. So again, this Graft Master by Abbott Group. So we thought we have placed it well, inflated it. Now, when you put the Graft Master, we realized that when we had attempted the wiring second time, instead of going into the actual LED, we had caused another perforation which had gone into the ventricular cavity. So now, because of that perforation, there was a direct connection from LED into the LV. Okay. So again, this is a horrible sight. So now what do we do? What the options left to us? We cannot put another covered stent. So the only options available are embolization. So embolization again. So we are fortunate to have some embolization coils again on our shelf. So we put a fine cross microcatheter. Sir, exactly that point. Okay, so we put a fine cross. Okay, 1 second. Okay, so sorry, I'll go back into this. I was trying to show something. So this is a fine cross. We see a opaque end of the fine cross microcatheter. When we're trying to push the coil was not going across the fine cross catheter. We had only microcatheter that was fine cross on our shelf. We did not have any other microcatheter. So we were trying to push. Sometimes some guidelines say that SCI guidelines says that even my fine cross microcatheter can be used to deliver coils. We only had that one. So we were having trouble. We were crying. This coil, no matter how much we were pushing, was not going inside. So so now it's like now microcatheter is not working. So we were panicking how to explain it, because this person was actually known. It was a known of a doctor also. So this horrible. Okay, so we somehow removed the microcatheter with the coil that was inside. Then we came that we will try we don't have actual pictures of the fat embolization we tried, because no one was thinking of taking photos at that time. But this is some, we took a nick from the groin area, we mixed it with contrast, we tried to inject through microcatheter, but somehow it never went. We don't know where the fat went. So that was failed as well. Now coming back to the microcatheter in question, see, the microcatheter profile says it is a 0.014 compatible. Okay, the two coils that we had on table was Micronestor and Hilal. Both are 0.18 compatible. So because fine cross microcatheter has a tapered end, that coil was not pushable across the microcatheter. So so desperate times call for desperate measures. What we did was we took the fine cross microcatheter, we cut off the tapered end. And with that tapered end, we could push the two coils. See, we tried one, and then when one went, then we were sure that the second one will also go. So we pushed the second coil as well. Okay, and so this is the final. We had a no flow, but I was never happier to see this no flow come ever. This no flow was a welcome no flow. See, now we can see that there is that cover stand that we had put. Somehow it is flying everywhere. But the proximal end was stuck into the myocardium. Is a distal end that was probably draining into the LV cavity. It stayed there. We did not know how to take that off, and I was not expecting a surgeon to help with that also. So that was left inside. The right side shoot was taken in the end, which was showing it was a pretty dominant RCA. Okay, the coil was there. The cover stent was still there. We repeated the fluoroscopy 2 days later. The cover stent was still there. Okay. So this was basically a type 3 perforation, which was into the LV cavity, which gave me time. Patient remained stable and minimally stable, like mild hypotensive, but it gave me time to do all these things. If it was into pericardial space, probably I wouldn't have been that lucky. So at 1 week, the pericardial effusion started receding. At 1 month, it had disappeared. The LV function remained the same as at the presentation. There was no decrease. Patient was symptomatic for the initial 2 to 3 days, but was put on a lot of anti-anginals. So with time, the pain went away. Okay. Yes, sir. Thank you. Yes, sir.
Why? ECG was normal, heart is flowing.
No, sir. ECG was not normal. There was a hyperacute T wave. Troponin was elevated. The echo showed a regional wall motion abnormality. Patient was symptomatic for the past 2 hours.
Yeah, I feel that you have put the graft in the wrong place.
Yes, sir.
I feel there is another channel has been made
There was
by
a small channel
and they have
that
put
we
that.
didn't.
So
At
all
that
the
point, we
things
didn't
become
see. Sorry, sir.
Burst.
Yes, sir.
God is great, and He saved this patient. I don't know how this patient saved. I don't know.
Initially, during wiring time, wire was knuckled there. In spite of all the knuckling, if you have taken the balloon support, that might be the reason that dissection happened at that point only.
Sorry,
Because-
sir, I didn't get your question, sir. Please
No,
can
no.
you repeat?
Initially, first wiring time, when you have started the procedure, wire was not going and you have taken the balloon. At that time, your wire was knuckled there.
Yes, sir,
I
that
think
is
2-3
correct, sir.
times
But
first.
in subsequent shoots, there was no evidence of dissection.
Knuckle
why-
wire, if we take the balloon support, definitely it will definitely.
Sir, but the
cover it.
perforation happened somewhere else, sir. That knuckling has nothing to do with the perforation.
Probably initially your perforation was due to wire.
Yes.
And after that, balloon, overinflation of balloon can lead to further increase the.
Yes, Dr. Trehan said that that area is weak, in the distal areas are weaker, so maybe it was a 2.5 balloon. Any primary PCI, I go with a 2.5.
Sorry to interrupt.
Okay, okay.
Yes, sir.
Thank you. Thank you.
This CD needs a lot of discussion at the end of entire session is over.
Not at all, sir. Not at all.
So,
Sir, patient came himself to give whatever file we needed 2 days back, sir.
Okay, thank you. Thank you, Jishan. Intracavitary.
Shunt. Fistula.
LV fistula. LAD LV fistula.
So question is, if it is a LAD to L shunt, patient not going into tamponade, could we have sent patient to the surgeons?
There are some tamponades there in echo
All-
also. And fluoro.
The patient
Very
has both
minor.
intracavitary and extracavitary effusion also.
Yes, sir.
that's why I say a lot of questions are needed for discussion. Let us move on to next speaker.
Okay, next speaker is Shreyans Trivedi. The topic is difficult wiring in tortuous RCA. Dr. Shreyans Trivedi.
I beg your pardon, there's a slight change in the topic, sir. There's a stuck stent balloon. So thank you to the organizing committee for this opportunity. Our patient is a 74-year female with diabetes and hypertension. She presented with inferior wall MI, and the culprit was the RCA. LCX also showed some critical lesions, but was not tackled at that time. We took a RCA guide with 6 French JR and guide wire whisper. The PLVB branch was 100% blocked. So how to play this run? Let's go. So we can see the PLV branch was 100% blocked, and a discrete lesion was there in the RCA mid part. Not able to play this. Somebody from the technical team? So initially we fixed the PLV branch with the 2.25 2 into 12 Equiforce and balloon at 12 atmosphere, and drug-eluting balloon DEB was done with 2.25 2 into 225 magic touch at 8 atmosphere. Later, since the mid RCA lesion was appearing to be discrete and was appearing to be benign, we contemplated that direct stenting of the mid RCA lesion would be enough. So we went ahead and took the 3.5 into 38 Zions prime and inflated up to 10 atmosphere. But to our horror, the distal stent was unexpanded. Then the stent balloon further could not be retrieved after the inflation of the stent, because we can see there is a underinflation or non-inflation at the distal end of the stent. Thereafter, we had to do multiple inflation and deflation of the stent balloon, but in spite of that, it could not be retrieved. So we tried to cross with BMW and the whisper wire. All these wires did not cross the lesion or the stent. Meanwhile, the patient was started having chest pain, and proximal RCA was totally occluded just before the stent. The ACT was all right of 320. Then we further took with fine cross support. We took the Fielder XT wire which crossed the lesion, and to inflate at the underinflated side, we took 1.25 into 10 Joule balloon. We inflated it besides the unexpanded part. Then the balloon, after that only we could retrieve the balloon successfully, as we can see here. Therefore, for further stent optimization, post dilatation was done with 3 into 8 NC balloon distally and 3.25 into 15 NC balloon proximally. This was the final result after getting the stent balloon out. So, underestimating the lesion severity can result in our worst nightmares. Adequate pre-dilatation by achieving the full inflation of the balloon, quarter to half size less of the vessel caliber is must before the stenting. In case of stuck stent balloon, polymer jacketed wire like the Fielder XT which we used here and Pilot 50 are helpful in negotiating the lesion. Microcatheter support may also be needed. We have to keep a watch on the ACT while managing the complications. Imaging would have helped us in understanding the lesion severity beforehand, and it's a very good tool for lesion preparation. So in this case, most probably the lesion would be fibrotic. So cutting balloon would have been ideal for the adequate pre-dilatation, and any simple case can turn into a nightmare.
Thank you, Shreyas. It means ki you have to adequately dilate the pre-dilate the lesion before the stenting.
Yes.
Okay, thank you. Next speaker is Pawan Singh from Medanta. A case of refractory no flow penumbra shaped mite.
A very good evening to all. Coming to the case history, a 50-year-old gentleman with prior history of diabetes, hypertension, had recent NSTEMI, was admitted for elective coronary angiogram, and echo was near normal with mild hypokinesia in the LED territory. Lab parameters were within normal limit. This was the angiogram of the left and shows the proximal mild in LED, proximal mild plaquing, followed by critical lesion in the mid LED. And the diagonal is good diameter and had the critical lesion in the osteoproximal diagonal. We have given the choice of CABG versus PTCA, but patient opted for the PTCA. We went ahead. The plan was simple, to keep it very simple, to do the cut and deb to the diagonal and the provisional single stent strategy to the LED. We wired with the BMW in LED and D1 both, and started pre-dilating with 2.5 into 15 NC balloon at 12 atmosphere in LED and 10 atmosphere in D1. Then followed by that Wolverine 2.75 into 15 at atmosphere in LED and at 4 atmosphere in D1. After using cutting balloon, then there was no flow or some slow flow noted in the observed in the LED, and patient also started having chest pain, and there were some ECG changes. We gave intracoronary vasodilators, Nicorandil, NTZ, but this no flow was just progressing, and the patient started having chest pain, severe chest pain, and we have to use the morphine and brought up the anesthesia team. Then initially we thought that it must be dissection, and so we went ahead with a stenting of this proximal LED, and we used Giant Sierra 3x38. But in spite of that, no flow persisted, and we thought that we have missed that mid LED lesion, and so we went ahead with the stenting of the mid LED overlapping with the proximal LED. Until this time, actually, we patient was he was in deep agony, and hemodynamic instability had just started. And we are now just stenting the mid LED, and thought that so this no flow will we will overcome this no flow. But however, there was no rescue from it, and no flow was just persisting. And then we were in total chaos mess, and we thought that so we are dealing with something else. This is not dissection. We checked the ACT, and ACT was, to my horror and to our distress, it was just 132. And we started heparin, started tirofiban infusion, then multiple rounds of thrombustor. We started used thrombustor, gave. And at one point we got the flow, but just we removed that thrombustor, and again the same situation, no flow, and patient becoming hemodynamically unstable. And we gave all sorts of, we tried everything from adenosine, just except for nitroprusside. We tried everything from Nicoran, NTZ, adrenaline, almost 3 to 4, whatever the maximum dose is recommended, 200 mics of adrenaline. We gave the 200 mics with each sort of 50 mics of adrenaline, but just with partial relief. And even we tried with this with the use of the thrombustor, we tried to deep into the lesion. We gave it with some partial success. Then we decided that we have to take a call, and then we used Penumbra, although the cost was the constraint, but not at the cost of the patient's life. Then we used this Penumbra, and 2 times we used it, and finally we got this satisfactory flow. But we had this was the result of 2 hours of struggle, and we had to be satisfied with this final result. What I learned, actually, understanding the cause of the no flow is crucial for its management. In my case, I initially thought that I was dealing with dissection, because I went ahead with the Wolverine balloon at higher pressure. So I thought that it is dissection, but I was wrong, and we were just this was the extensive thrombosis or high thrombus burden, which was has caused the no flow. Checking ACT at frequent interval can save us from such disaster, and from that time we have made it mandatory to check ACT after 5 minutes of giving heparin, and after every 15 to 20 minutes in the cath lab. Sometimes heparin can be faulty, and when recurrent case of suboptimal ACT, check heparin brand and replace it. Actually, we have not observed stent thrombosis, very, very rare, but just on that 2 consecutive days, we had the 2 stent thrombosis, and that was due to this faulty heparin brand. And this was then we replaced it, that heparin brand, and since then we are doing fine. And avoid stenting until very sure about dissection, and Penumbra can be savior in patients with very high thrombus burden. Thank you. And patient is doing fine, and just came last week, and is doing fine. EF has decreased. It was 35 to 40% from initial 50%.
It was due to faulty heparin, or heparin was not given adequate?
No, sir. No. It never happens, sir. It was faulty heparin, because 2 consecutive patients on the consecutive day had the stent thrombosis just due to this heparin. ACT was lower. We give heparin, we mention, we note the time, and we write it on the.
I have also faced one patient, different brand, new brand when coming in hospital, always check the.
Yes, sir. I have the name of that brand.
But the ACT was checked only after placing two stents.
Actually,
and-
we didn't thought that case should be the thrombus burden, because it was hardly 15 to 20 minutes that just after pre-dilatation there was no flow. I thought firstly it is dissection. Went after stenting, we didn't get the flow, and after using all sorts of coronary vasodilators, we didn't get the flow. Then we checked, and it was 30 minutes of time. So generally we give 100 unit per kg of heparin, and we achieve good ACT, and we don't have any complication. But it happened during that procedure, and it happened on the second day also. Then we thought that it must be the heparin which is faulty, and we replaced it. And since then we are
Penumbra is a thrombosuction device.
mechanical thrombosuction. Yes, sir.
So
Its
it is-
caliber is more than that of Thrombustor. It's almost 5.3 French, and a good chunk of it's a very good device for the.
Thank you,
clots.
Pawan.
Thank you.
So the next CD presentation is post PTCA stent abscess, a rare entity and surprise in OT by Dr. Amir Kazmi.
Good evening to all of you. First, I would like to be thankful for organizing committee to give me an opportunity to be as a speaker here. So I'd like to start my case, a brief history and background. A 54-year-old male who has been done post PTCA 2 months back was referred to me for CABG from one of our cardiologist colleague. And on history taking, it was found that he has PTCA to LAD about 2 months back. After the 3 weeks of the post PTCA, his symptoms started with frequent episode of chest pain along with shortness of breath. He has associated on and off high-grade fever with chill and rigor, and mild swelling of the leg and the low general condition. The most disabling symptoms were his persistent high-grade fever with chill along with chest discomfort. A course of the antibiotic was given on the basis of suspicion that he has some sort of infection, and blood culture and urine culture were also sent. Urine culture came out to be negative, but blood culture came out to be positive for MRSA, and IV antibiotic were started for 2 weeks as per culture report. After a course of antibiotic, patient general condition became much better with decreased frequency of the fever spike, but chest pain persisted. So a check, he has a persistent ECG changes in chest lead and rear chest lead, and his check angio was done, which revealed complete in-stent stenosis of the LAD stent, along with aneurysmal segment of the LAD in which the stent has been put. His circ and the RCA were normal, and a patient was finally referred to CTVS for surgical needful. In view of severe chest pain along with the ECG changes, he has been planned for the surgical revascularization after a course of the antibiotic. So we have done the routine sternotomy and pericardiotomy, but just opening the sternum, we have found the dense sedation of the pericardium to right ventricle and adjacent LV along the segment of the LAD in which the stent has been put. He has an associated fibrinous pericardial effusion. After positioning of the heart, we have placed the octopus stabilizer we just used to during our surgical anastomosis. LAD was initially scratched just to see the segment of the LAD in which we have to put the graft. So we can see here, we are dissecting put the octopus stabilizer in the LAD, proximal LAD. We are just dissecting the LAD, but in that area, the LAD was nothing, but it was full of the pus. Whole of the LAD area stented area was inflamed, and no surgical pain could be found out. There was absolutely full of the pus. The surrounding epicardium is also inflamed, and we can see the white yellowish thrombosed stent on the section with this 15 number blade. So when there is no plane was found for the anastomosis, the octopus stabilizer was finally removed, and we just felt the LED segment with the finger and found that there was a pus pocket. We just expressed the pus. There was a huge pocket of the abscess coming out from the LED segment in which a stent has been put. So that area was full of the pus. So that might be the one of the reason why patient had a persistent high-grade fever along with the chest pain. So that may be the reason. So after this, we have taken a few of the pictures. In one of the pic, we can see here that thrombotic stent can be seen with the plaque, and after the pus evacuation and the aneurysmal LED segment can be seen. Here, these are the same pic, and after finally the debridement of the LED segment, the stent has been removed. So these are the remains of the LED stent which has been taken out with difficulty, and we can see the crumpled and the stretched out remains of the stent. So after stent removal, debridement and cleaning of the LED lumen was done. Pus was set for culture and sensitivity, and aneurysmal LED segment was covered by putting a vein patch. Fortunately, the distal LED segment was good, so Lima was harvested and placed in the distal LED segment. So post-operative course of IV antibiotic was given. Antibiotic was later modified as per the culture report, and the post-operative course remained uneventful. In immediate post-operative period, there was 1 to 2 episodes of the fever in the ICU, but in subsequent follow-up after discharge, patient was symptom-free, and he was without any symptoms of the fever of angina. So a brief review of the literature about the coronary stent infection. It is a rare complication of the PTCA associated with a very high and morbidity and mortality. And in some of the cases, up to in various series, it was found that the mortality is up to about 40 to 50%. Since the introduction of the coronary stent in 1987, fewer than 30 cases of the stent infection have been reported till now. And the most common presentation, we all know, that is fever, chill with chest pain may be there, which is maybe related to the periprocedural bacteremia. And about seen that about 80% of the coronary stent infection is really associated with the pseudoaneurysm. So what are the predisposing factors we have to look just to prevent? There may be the patient-related factor, like patient may be immunocompromised, patient may be diabetic, he may be of CKD. But beside this, the various factors which are related to cath lab are, there may be inadequate sterility, difficult vascular access, repeated use of the local site like groin area especially, repeated reuse of the hardware such as balloon, catheter, and especially in common resource poor hospital, deferred removal of the arterial sheath, multiple guide wire manipulation, and pull-down indwelling catheter. So these are the flow chart which shows that how these catastrophic complication of the stent abscess, stent infection may take place. So the most common organism implicated in stent infection is usually Staph aureus. It is seen in 80% of the cases. Pseudomonas may be seen in less of the 20% cases. Samore et al. Has done his study on this PCI-related bacteremia, and he has seen that it can be seen in up to the 0.64% of the cases. So most cases described very early in the very early infection that may happen after 2 to 4 weeks, 2 days to 4 weeks after the PTCA procedure. And how we can diagnose and manage this case diagnosis. No single modality is confirmed the diagnosis of the stent infection. Diagnosis is highly based on high index of the suspicion with the recurrent episode of the fever after the PTCA. We have to send the early blood culture in such cases. Check angiography must be done to show the patency of the stent, whether the stent is patent or not. Transthoracic or TE can be done to see any infective focus, or CT MRIs can be done to definitive diagnosis. What are the precaution suggestion? In patient with a fever and chest pain after stent infection, stent infection should be highly suspected. Blood culture should be sent. Broad spectrum antibiotic to cover MRSA, MSSA can be started. And angiographic procedure should be done as early as possible. In late onset infection, surgery should be considered early in the course, especially if the major complication is apparent on angiogram. In early onset infection, medical therapy might prove beneficial. Surgery is indicated if any major complication are present or medical therapy appears to be failing. What could be done in surgery? We can do the evacuation of the poolant pericardial fluid and debridement of the area, excision of the epicardial granulometer tissue with debridement. Ideally, the stent must be removed at the time of surgery, but may be difficult. In most of the cases, it is not possible to remove the stent. Antibiotic therapy should be administered apparently at least 4 weeks or possibly longer, irrespective of the whether we remove or not remove the stent at the time of the surgery. Thanks. Any question from the audience?
Thank you. No question. And then due to flight of Dr. R.J. Jadhav requested to do, I called the Dr. R.D. Jadhav. He will speak on the post MI VSR device closure, case-based discussion.
First, thank you, respected chairperson, dear friends. First of all, I want to thank the organizer who has brought me here. So, post anterior MI VSR with acute pulmonary edema closed with muscular. This is the 56-year-old male, and this is the VSR which has occurred 1 month after MI. And this is the 3D. This is showing the VSR. This is the septal defect, and echo was sent from outside to give 3D picture of the VSR, and in different 3D from LV side, from RV side, the margins are fragile looking. This is the color flow, and then we put the IBP, did some angiogram to look where it is, and then crossed with the thermo wire and IMA catheter, snared it out, snared from below, snared it out, and then put the sheath like this, the delivery Amplatzer delivery sheath, and this is 22 millimeter muscular VSD, post-MI muscular VSD device was deployed across the VSD. And then de-screwed after confirming. And this patient was having creatinine 2.5. So only few 10 ml contrast injection was done and no contrast injection, only echo was done. We showed closure of the defect. Only few traces of blood is going through the studs. Otherwise, no flow across it. So more high mortality, and it was done with the device. Patient is now class 1 on medical therapy. Another patient, elderly, 82-year-old male, again anterior wall MI and VSR. This is there is a split in the septum. If you see, there is a split in the septum, and this is the complex VSD. This is really it's difficult to close, but since surgeons had refused, patient was admitted under surgeon, cardiac surgeon. He told, no, you try to close it. I cannot do surgery here. It's all split septum. So again, crossed with the IMA catheter and snared it out. From below to upward, neck, below to upward, from the, because it's the apical side, so put from the internal jugular, snared it out. And then sheath, delivery sheath. This is 10 French delivery sheath of Amplatzer. And delivery sheath was deployed into the LV. And this is the from internal jugular vein. And then device was deployed. And this is all again IBP support. Device was deployed. And this patient improved. This is the way device took the shape. This is the some tilting of the disc was there. And slight leak is there in the upper rim, otherwise okay. Patient improved hemodynamically, IBP removed after 2 days, and he is now doing class 1 with the medical therapy. And so another patient, inferior wall MI, this is I did in Patna, Dr. Nishant Tripathi, 75-year-old male, acute inferior wall MI, no PCR thrombolysis was done, having VSR on 3rd day and cardiogenic shock. And this is the ventricular septal defect in inferior MI, typical inferior posterior part, inferior part. So here angio was done, and this is the defect. We again put on, patient was in pulmonary edema, so put on IBP support, and we all give Gylocard to prevent VT-VF during the manipulation, the LV, and then snared it out. And again from the neck, snared it out from the neck because it is more towards the apical side. The device sheath was gone in, and so deployed the device. Defect was closed. Patient improved. After 3 hours, there is a slight leak at the rim, and within 5 minutes, device got embolized. And it embolized. Patient was hemodynamically stable. Everything was fine. We are very happy. But after it got embolized, and this is maximum size device, 24 millimeter. So we took in, and it is embolized to the pulmonary artery. Patient was again gone into shock, even on IBP. So snared it out, took out, and then tried with the ASD device. We brought ASD, but the ASD device shaft is only 4 millimeter. We could not able to approach properly the device, and so took out, and again patient was sent for surgery, but surgeon refused. That he told that if he will be alive for 1 week, then I will do, otherwise not. But after 3 days, patient died, which Dr. Ashok has informed me, and that's thank you for second talk. Whatever defect come in echo based, whatever device comes in echo, 6 to 8 millimeter more. Yeah, irregular. So sizing is based on echo, not on angio. Angio we don't do even. Edimeter, yes, edimeters, friable. That's why this RC inferior wall MI one is after we close it, there was no flow. And after 3 hours, there was some flow was appearing on the upper rim and then embolized. So this is the risk is there, but maximum size is 24 millimeter muscular VSD device. Beyond that, there is no, because you need a shaft of 8 to 10 mm. Shaft should be there, and there was no shaft, so that's why we could not able to close with the ASD device. ASD device only 4 millimeter shaft, so that is the problem. Ideal time, it's an acute indication. Indication, say, if patient develop acute VSR, means it's a acute closure should be done as quickly as possible. It's like surgery. Acute surgery is emergency needed. Yeah, son, definitely. Most of the VSR is not small, is mostly large. Yes. Yes. But there is no other option. What you can do? Other patient, I have done more than 15 cases. 4 patients died, and rest are surviving. So you have to take the risk. No other option. 90% die within 2-3 weeks. Die. So next topic is CTO bifurcation. Bifurcation of LMCA. How I approach. I have 3 techniques to do the bifurcation of LMCA. First technique is the provisional, which I like the most. First technique is provisional. Second technique is mini culotte or decay mini culotte. And third technique is decay crush. And fourth technique is mini crush. And tap technique rarely I do. So this is another patient. This is CTO of RCA with left main bifurcation. This is the left main bifurcation, true left main bifurcation. So how to? So first open the RCA and then took him for LMCA to LAD, dilated with the balloon, put the stent across. Did the pot, recross, kiss, and final result. So this is the way 70% of left main bifurcation can be done without that. Now a similar case, provisional similar case, did the provisional stenting. 90% cases you can do provisionally unless disease extension is more than 3 to 4 millimeter into the circumflex. Here because calcification, so I dilated, otherwise I don't pre-dilate. Put the single stent technique, recross, there is a pinching, recross, pot, recross, kiss, pot, and final result. So provisional stent technique is very good. Long term is also very good result. Now another technique is decay crush technique. Many people prefer decay crush. I don't do now. Previously I used to do it. 10 years back I used to do decay crush. Now I do mini culotte maximum. And this is the RCA having disease. So RCA should be taken first. And this is the patient having disease into the LMCA distal as well as ostial and circumflex. So both diseases are involved. LAD, circumflex at the ostia and left main. So first did the RCA. Final result. This is the final result of the RCA. Then took him on IBP. He arrested, he was developed pulmonedema during angio. So all, so dilated the sequential dilatation, then stented the LAD. LAD made as a side branch because LAD is smaller as compared to circumflex. Then first kiss and then dilated the, stented the circumflex. Final kiss, pot. Here there is no distance for pot. So we didn't do the pot, only kissing, final kissing and final result. Now the mini culotte technique, which I do mostly, this is the distal bifurcation lesion. True bifurcation lesion here. So crossed both the arteries, dilated the LAD. I prefer not to dilate the side branch here, and then did the pot, recrossed, pot, recrossed, and then dilated the recross area with the 1.5 millimeter balloon. And then bigger balloon, and then stent, position the stent, deployed the stent, pot, recross, kiss, individual sequential dilatation, and then kiss, and then again pot, and that's the final result. So this is the way mini culotte technique. Nowadays we can modify by decay mini culotte, and this is the technique. We can do the left main bifurcation. So this is the final result. He is doing fine. All these patients are doing fine. So tap technique I don't do, but just I want to show just that you can do it. This is one of my colleague was doing before. Heavily calcified artery, could not able to go even with the balloon. So they tried everything. So did the rota, heavily calcified, and this is dilated, the rotational atherectomy done, and then absorb stent was put in here after dilatation, proper dilatation with the NC balloon. And this is the ostial lesion. We cannot put the ostia stenting, so we have to put from LAD to LMCA, and then there is a pot and there is a pinching of the circumflex. Here I did the tap technique. This is tap of the stent, and this is finished with the tap. So this is the what all technique you can have. Thank you.
Thank you, sir. The next talk will be from Dr. Praveen Chandra from Gurgaon online presentation.
Right. Let's hear from chairpersons for that session. For the next session, may I invite Dr. R.D. Yadav, sir. Please just stay back here. Jana, chale gaye. Okay. Dr. Abhinav Bhagat, Dr. Vikas Singh, Dr. Anshu Agarwal, Muzaffarpur. है कि चले गए मंसू जी? मानस ठाकुर सीतामढ़ी, जयमाला मिश्रा और Dr. Gautam, Dr. Siddhanath, please come and join a chair. In this session, we have online talk of Dr. Praveen Chandra from Delhi,
Connected.
followed by, I think,
I'm connected.
CD
Hello.
presentation by our own people. Okay. The guest speakers is only one, Praveen Chandra from.
Very warm welcome, sir. Dr. Praveen Chandra needs no introduction. He is the chairman of cardiology in department in Medanta, the Medicity. Welcome, sir.
Thank you. Thank you. And I can see that you people are really enjoying cardiology like anything, because I was hearing a lot of very.
Can you increase the volume, sir, please?
Yeah. So how can I increase the volume?
Either,
So
sir.
is the volume better now? Is it better?
Yes, sir, better.
Okay, so I'll just speak a little bit closer. So basically what I was saying is that it is so heartening to see that you people are doing an excellent job. I cannot imagine the kind of cases which are being done, and the way they are being handled is superb. I could see some cases, but I must congratulate the whole Bihar cardiologists who are doing a really great job. So hats off to you and many, many congratulations. And I hope you will do better than this. So with this, I am going to start with my presentation, and this is just my experience and my thoughts on using drug-coated balloon in bifurcation. So as you all know that, what is happening? So here, okay. So yeah. So as you know that in bifurcation angioplasty, the biggest challenge is that stenting, we still do not know what is the best technique, whether it is a decay crush or one stent or two stents, and then restenosis of side branch when it happens, as we see many times, is a real problem. So, and when we put two stents, problems of stent thrombosis and restenosis, everything is there. So that is why I just want to share with you that there has been no best technique. So we are in search of something better. Now, what happens is that these are so many techniques. Provisional, decay crush, Q-Lot, T-tap, V-stenting. Why there are so many techniques? Because we don't know which one is better. So we have to choose and select based on the anatomy. And based on that, we decide whether we put two stents or one stent. But what about no stents? So basically, drug coating balloon is actually transforming our practice. And let me tell you, in about 40 to 50% of my patients today, lesions are being treated by drug coated balloons. You may be seeing many patients who are being treated here. And this is about 40 to 50% definitely. And especially in situations where there is medium size vessels like 2.75, 2.5, 2.25, and instant restenosis definitely. Of course, in this also we do not know which is the best way to do it, but I will share with you what we are doing, and we are getting very good results with that. Of course, about the discussion about what kind of balloons. So These are various types of balloons which are available, but I will share with you the indications which we do. But today I have to speak more about bifurcation lesions, especially the side branches, how to handle them. So what we do is, the optimal lesion preparation is the key to success in drug-eluting balloons. Okay. So in drug-eluting stents, many times we do direct stenting. Many times we do some simple pre-dilatation with a 2 mm balloon and put the stent and then post-dilate. Here we have to prepare or treat the vessel like a stent-like result and then only do a drug-eluting balloon. So drug-eluting balloon is the final painting process, nothing else. So we have to get a acceptable angiographic result. That is the difference between stenting and drug-eluting balloon. Get an acceptable angiographic result and then do a DCB. And these are the two strategies which we use in drug-coating balloon for bifurcation. And these are where you use both main vessel and side branch as drug-coated balloons, or we use stent in the main branch and drug-eluting balloon in the side branch. This is known as the hybrid technique. So we started with the hybrid, but now we are more, gaining more experience, and many patients are being treated with 2 drug-eluting balloons also. So the difference, of course, as you can understand, is that it helps in 2 things. One, stent thrombosis or acute occlusion rates are very, very low. So because there is no stent. So if there is no stent, there is no stent thrombosis. And then shorter duration of DAPT, which is required in many patients today in our Indian population, because they are sometimes elderly, sometimes they have liver disease and many other things. And the recovery is much faster with drug-eluting balloons, as we understand. But this is what I'm saying. But what is the evidence? So the evidence has started coming from the studies which were done for DCB in small vessels, and then of course the SCAR data, which is the recent evidence of DCB in bifurcation. And here you see that they compared the DCB only strategy and the hybrid strategies here. And here are the results. They are quite positive. Low event rates in bifurcation lesions with paclitaxel drug-eluting balloons. So this was paclitaxel, but it has been done with sirolimus eluting balloons. And then they compared different paclitaxel eluting balloons and found that the rates of incidence of any events was very low. The low MI rates were seen both in paclitaxel balloons and other balloons in patients who are undergoing bifurcation, PCI, with DCB only strategy or with hybrid strategy. Both are doing reasonably okay. And this is just a comparison, because many times you will be confused whether I should use a paclitaxel or should I use a sirolimus. But let me tell you, the data is at the moment comparable. Some studies are positive towards paclitaxel because of the positive remodeling effect. But overall, I think at this time we can say that it is comparable. The only issue, let me just give you a word of caution. If you have to use 2 or 3 balloons in the same vessel, like for a long lesion, in that situation, you should try to use a sirolimus eluting balloon. Why? Because the toxic window, the therapeutic toxic window of paclitaxel is lesser. It can lead to aneurysm formation or vessel necrosis, because we have seen that in Taxus stents or paclitaxel eluting stents, that there were increased incidences of malapposition, which was basically because of over-dilatation of vessels because of the aneurysm formation. This is the DCB BIF trial, drug-coated balloon angioplasty for branch compared to provisional stenting. This trial was again aimed to do this, and here stenting was done to the main vessel, and then if there was a significant lesion to the side branch, then you can do a drug-eluting balloon if there is no significant dissection there also. So here they looked at the results and they found that the results, and these were the steps of the procedures. As you can see here, drug-eluting coated balloon was the last step. You only do it once you are sure that there is no major dissection, the TIMI flow is okay, and then only you should do it. So these are the number of patients. As you can see here, about 391 in the DCB group and 393 in the plain balloon group. And here you see that the crossover to the stent group was also very less. So do not be afraid, or do not be concerned too much about that. If there is a some recoil and you want to stent it, don't try to stent it because the drug will take care of that. There will be positive remodeling effect and the patients will be okay. I'll show you some examples. So this trial did definitely tell us that provisional stenting, in place of provisional stenting, you can do a drug-coated balloon with a lower 1-year risk of target vessel failure when patients were treated with drug-coated balloons. So I'm just sharing you 2 or 3 case examples on that, and that will be the end of my presentation. So here you see this is a bifurcation lesion of the LAD circumflex. Earlier, I would take 1 stent here, and then there will be some degree of a pinching effect here. We will have to do then a stent again, or maybe just do a drug-eluting balloon. And of course, and this is a very big artery. I cannot compromise this artery also. So this both have to be treated properly. So we do a cutting balloon. So the main step is I use a Wolverine cutting balloon, no other cutting balloon, only Wolverine cutting balloon by dilatation on both sides. So on one side, I take 1 cutting balloon of 2.25 going up to 18 atmospheres. And the other side, I use a cutting balloon of 3 millimeters going up to, again, 15, 16, 18 atmospheres, which become like a 3.4 or so. So with this, we then do a drug-eluting balloon to the side branch first, followed by the main vessel. Keep the wires there, check everything is okay, the flow is TIMI3 everywhere, and it is done. So no more stenting has to be done. This will heal very properly, and you can leave dissections up to type 2 dissections or type B dissections or type C dissections also can be left if there is no staining and there is no compromise of lumen. So if there is no luminal compromise, it is okay. You can see a flap, no problem. So with this here again, you see that this is a patient who has a bifurcation lesion. Again, LAD diagonal, very big diagonal here. There's a LAD and a big diagonal. And here we treat that with again, process again this drug-eluting balloon to the side branch. So this is a hybrid technique. This is the right coronary was treated separately. So we first dilated the main vessel, did a cutting balloon of the side branch, and then of course drug-eluting balloon to the side branch and DES to the main vessel. So this is the combination which you can also do in some situations, but you can decide what kind of strategy you want to take. Then similarly, this is a patient who is again very interesting, very tight stenosis of ostium of the circumflex. So now this is something very important I'm going to share with you. This patient had stent in the LAD. She came with angina. And then we said, okay, we have to do nothing to the LAD. It's okay. There is distally some plaque. We'll not touch it. We'll treat this circumflex, which is very tight. The RCA was also okay. So we treated this circumflex. This RCA was treated at that time and with stents. And then here you see that there is a tight stenosis of the ostium of the circumflex. Did a cutting balloon through 0.75 into 12. So we have to be aggressive, 1:1. And then we put a 3x15 drug-eluting balloon here. So again, drug-eluting balloon, we are a little bit more, in terms of sizing, we go a little bit higher on the higher side rather than the lesser side, because we go to very low pressures. So this is what we do. There is some haziness, no problem, leave it as such. Then this patient did very well. 1 year later, she comes with angina. So we thought this circumflex is gone. But here what you see is the LAD is restenosed and the circumflex is looking beautiful. No restenosis and the vessel is looking so well healed, so that there is no evidence of any problem here. And hopefully this vessel will remain like this for the whole life. The RCA was okay, so everything is fine. So when we have multiple, like, this is a trifurcation. From bifurcation, we go to trifurcation. Again, in these kind of things, if you try to put too many stents, 3 stents, it will definitely lead to either restenosis or stent thrombosis. So here we do wire all the 3 vessels, do cutting balloon dilatation of all these lesions. Still, we are not able to dilate the lesion in the circumflex. We do a high pressure cutting balloon, then a shock wave dilatation. And after that, we still do not put stents. We do drug-eluting balloon to both LCX, ramus, and only put a stent in the LAD, which is the single stent strategy. So here, this is known as hybrid stenting. And this patient also did very well after that. This is the final shoot. Everything is flowing well. There is no problem. So finally, my friends, what is my way of doing bifurcation DCB? Pre-dilatation and IVUS sizing of both vessels is very important, because sometimes the vessel looks like 2, but it is actually 3, like in that circumflex which I showed you. Then cutting balloon for both the main vessel and side branch based on IVUS sizing, and if there is no major dissection, DEB to both the vessels. And then final snuggle kiss can be done in some patients if there is a snowplow effect. Otherwise, there is no need to do anything. And so this is my final message, that bifurcation lesions are complex, they are high risk, so treat them with care and do hybrid PCI or do a DCB only strategy. And choosing which balloon, you can choose either sirolimus or paclitaxel, both are okay. And definitely keep the balloon at least on for at least 90 seconds. This is my advice. At 90 seconds or up to 2 minutes is also okay. And then these patients will do well. And if these patients have calcification, if you have to do shock wave, rotablation, no problem. You can do everything and finish off with drug-eluting balloon. So with this, I will stop here. And thank you very much. If you have any comments or questions, please go ahead.
Coating balloon without imaging. Imaging, sir.
Yeah.
DCB without imaging.
Yeah, you can do DCB, you can do any angioplasty without imaging, but now there is ample evidence and enough, experience and evidence both, that if you do imaging, whether you do with drug-coated balloon or with drug-eluting stents, the acute complications and long-term outcomes are definitely better. This has been shown in the ultimate study. And also in imaging, many times people ask whether OCT or IVUS. So I can tell you both are equal, no problem. But so today in my lab, the imaging rate is about 110%, 120%, because in some patients we do both, OCT and IVUS both. So every single patient, even if it looks like a simple LED, we will do this. So I think it is worth investing in this, method of treating these vessels. Earlier, when I was doing it, I always used to think it is not necessary, I can handle this. And I know everybody used to do this. But now today, we have learned that it is better to do it this way.
Sir, when we use drug-eluting balloon in side branch, so what's your protocol? Earlier, we used it to do a kiss with a.
Yeah, I can hear you. I can hear you.
Then we start. Preparation before stent.
I cannot hear.
But now we have changed that thing. We now used to do a drug-eluting balloon in the side branch if the ostia of side branch is diseased before placing stent in the main branch, and then we do a cross and do a kissing. So what's your take-home message regarding this?
Yeah. So basically deciding whether we put DCB to the side branch and put stent in the main vessel or do both with the DCB, this decision is taken after you have done the first step of optimal angiographic result, which means you do a dilatation of the side branch, you do a good dilatation of the main vessel, see everything is okay, there is no major dissection, the vessel flow is good, everything is fine, then you are sure that yes, now we can do DCB. So that decision has to be taken at that particular time. And if both the vessels are okay, start with DCB of the side branch and then do DCB of the main vessel, then that is it.
Sir, the question was that when we are stenting the main branch, we are sure that we are going to stent the main branch. So side branch, that using DCB in the side branch, it is better to use before deploying stent in the main branch, or it is better to use after deploying stent in the main branch?
It's a very good question. We still do not know the answer. There has been no study to do that. But typically speaking, it is better to do it before because of two reasons which I have thought in my mind. One is that if you are crossing the drug-eluting balloon through the stent struts, some drug may, kind of scrape out or something like that. So it's better to do the drug-eluting balloon of the main vessel, a side branch first. And then also you are making sure that the drug is on the entire ostium of the side branch, because ostium is where the stenosis happens. And if you do a DEB after that, there is a possibility that the ostium may not get enough drug because of the stent struts. So that is why it is better to put the DEB first and then do the stent to the main vessel.
This was a big question because we have shifted to this strategy almost 3 to 4 months back, but still there is a lot of debate on the DCB platforms everywhere that we cannot do a case, we cannot do a recurrent ballooning after deploying DCB if the drug is lost after that.
No, it is not. So this is what people were thinking. But the thing is that once the drug goes into the vessel wall, it is embedded into the vessel wall. So definitely if you try to do too much of intervention, that's not recommended. But if it is essential, if there is a dissection flap, or if you see that the lumen is compromised, do it gentle, just inflation, so that whatever, the tissue is hanging or there's anything, it can just, become better. That's all.
Sir, after putting that stent in the main branch, if the side branch have some impinging is there, need to do the decade double kissing or no?
Yeah. So the thing is that, yes, so if you have done the DEB of the side branch, now you have put the stent in the main vessel. And then if you see that there is some, chinking effect, or the vessel is looking very small at the ostium, you can do that's what I was saying. You can do a gentle dilatation, but be careful, because sometimes you can go into a small dissection flap and then you have to put second stent. So be gentle, and your threshold to do that will be less, should be less. Because sometimes if you look in one view, it looks very tight. If you go to the, for example, LED diagonal, if you see in the epicranial view, it is looking more. When you go to the iliocranial, you see, oh, it's looking fine. So check in 2-3 views, then only take decision. Yeah.
One of your second case, sir, that ramus, even after DCB, that lesion was in the angiography looking very tight, almost 80% or 90% like that. In that scenario, if the flow is very good, need not to do anything or need to do something.
Generally, that's what I was saying, that many times, so we do imaging also in these patients before we do the DEB. Even if angiographically it looks more, sometimes there is spasm also in the vessels. So consider that, do a imaging. If the vessel lumen is good, do not worry, this will heal and then this will become big.
Thank you. Thank you.
Sir, one thing, LMCA, DCB, bifurcation, LMC bifurcation, can we use that DCB?
Yeah. So let me tell you today, if a patient comes to me who is a young patient and has a ostial tight LED lesion, okay, my first strategy is to do a DCB to that. Why? Because they respond very well. You do a cutting balloon dilatation, get a good lumen, and then do a DEB. Your left main is protected, your circumflex ostium is protected, and your LED is treated. So you have created no harm. If you put a stent into the left main to LED in that ostial lesion, because it behaves like a angiographic bifurcation. So in that case, you have put a stent in the left main, chance of problems. You will have a chance of stenosis occurring in the ostium of the circumflex in the next 6 months or 1 year. So all that is avoided, and the chance of having any stent thrombosis is also finished. So I'm very, very satisfied and very happy doing this technique, but make sure that you get a good angiographic result before you do the DCB in ostial LED, ostial circumflex, or the left main. So in left main, sometimes if there is a tight stenosis at the distal left main, ostium is also disease of the LED and circumflex, not too much space to put the stent, then you do a cutting balloon to both sides, then do a DCB to both sides, do a gentle kissing inflation, and that's all. The patient will do very fine, no problem.
Sir, sometimes we do the pre-dilatation and it's a very fibrotic lesion. We use the cutting balloon and again it's recoiling. Then we use the DEB, the adequate balloon dilatation 1:1 through the IVAS imaging, but after at the end result it recoils and angiographically it doesn't look good, but we got the TIMI 3 flow. What to do in such scenarios, sir?
I mean, you have to make that decision there at that time. I'm not saying that everything you have to leave behind with DCB. If there is a significant recoil or if the patient lesion is not responding to balloon dilatation, in that case, you have to put a stent. Then the stent is definitely there on your side. If you feel that it is not looking good, the flow is although looking good, but the ostium restenosis is more than 50%, then you do it. If it is less than 50%, like 30%, 20%, no problem. Just leave it like that.
And sir, during your discussion, you told that case in that trial, bifurcation trial, they have deployed the DAVE after putting the main branch, main vessels stenting. That was the DAVE was the last procedure.
Yes,
But in your opinion, it should be deployed before that.
Because they were comparing two strategies at that time. So it was basically a test of method. Now, to improve the method, we started doing this thing that now we are sure that yes, this strategy works. A hybrid strategy is a good strategy. But to further improve it, we started doing this thing that you do a DEB first and then do a final kissing inflation if required.
Okay.
Thank you, sir, for the excellent talk.
Thank you.
It was highly informative and lots of data are emerging as far as drug-coated balloon is concerned. So there are many gray zones till date, but definitely it is the future of
it is evolving.
bifurcation stenting.
Yeah.
Thank you.
Okay.
Thank you, sir.
Thank you very much.
for joining.
And all the best for the rest of your sessions. See you later. Bye-bye.
Thank you, sir.
Bye.
Next case is primary angioplasty in cardiogenic shock. I invite Dr. Sumit Kumar Verma from Begusarai for his case. Welcome, Dr. Sumit.
Thank you. Good evening, everyone. I'm going to present two cases of primary angioplasty in background of cardiogenic shock. The procedure were uncomplicated, and the intention is to highlight that this availability of this facility in the peripheral part of Bihar, and I wish this facility should be available at least every district headquarter of Bihar. So starting with my first case, a 51-year-old male having a strong family history of CAD, addicted to tobacco, developed chest pain with perspiration when he was preparing feed for his cattle. He then immediately rushed to the primary health care center, and after that he was shifted to my emergency. At the time of presentation, he was already exhausted. His BP was not recordable, and the ECG shows ST elevation in V2 to V6. The screening 2D echo shows the LV ejection fraction of 30%. So patient was immediately shifted to cath lab after loading with antiplatelet statin and with inotropic support. This was the angiogram that LAD was completely occluded from the proximal part. So we wired the lesion in LAD through floppy run-through wire. After that, pre-dilatation done with 2 into 12 mm NC balloon, and we secured some perfusion in the LAD, but the distal tip of wire was in the side branch, so it was negotiated in the main lumen distally. Then again, the blood flow stopped. So we again dilate the lesion with the same balloon, and this time we have some flow with high thrombus burden. So we put an stent of size 3.5 into 36 from proximal to mid LAD. And after putting the stent, long and handsome LAD came out. And there was proper position of the stent. So, and patient started showing sign of improvement. He came out of the inotropic support in next 10 to 12 hours and was discharged successfully after 48 hours of hospital course. His 1 week and 6 week follow-up were uneventful. Now the second case, again, this is an interesting case. In the early morning, I got an ECG from my junior colleague working at the block level. The ECG shows extensive ST elevation in V1 to V6, 1 AVL, and his BP was at that time 90/60. I just asked him to load the patient with antiplatelet and statin and shift the patient after starting STK because I was not sure about the transportation. But they somehow managed to come to my emergency within 1 hour after starting STK. At the presentation, the ECG was repeated that shows the similar finding, no sign of successful reperfusion. The pain was ongoing. So patient again was shifted to cath lab after with support of inotropic agent. And this was the angiogram. This is the LED is completely occluded from the ostium and there is a small circumflex that is non-dominant. So LED was wired and pre-dilated with the 2 into 12 mm NC balloon. Then we got a good flow. The lesion looks like a fibrotic lesion. And we put a stent in the mid LED of size 3 into 23 mm and another stent of size 3.5 into 28 mm. After that, there was a good flow, TIMI3 flow, but the proximal part of the stent was not fully dilated. So it was a post-dilatation done with 3.5 into 12 mm balloon, and that we achieved that TIMI3 flow. And the patient immediately starts showing sign of recovery, and he came out of the inotropic support in next 12 hours and discharged successfully after 48 hours. His 1 week follow-up was uneventful, and now this patient is preparing for his exam to be held in the next week for his promotion. It is a departmental exam in education department. So the take-home message for both these cases, I think it is better to hit hard early in the ACS. That can bring good luck to the patient and treating cardiac team. Thank you. Thank you, sir. Thank you, sir. Thank you, sir. Thank you, sir.
Good evening, everyone. So I think it's quite late, so I'll be quick. My presentation. So are you able to see this? Yes. Not moving. Slides not moving. Slide move नहीं कर रहा है. Change. Slide move नहीं कर रहा है. वहां से ऑफ किया. वहां से ऑफ किया. वहां से निकल दिया. प्ले हो रहा था. वहां है. वहां से ऑफ करिए था भाई. स्टॉप करिए. वीडियो प्ले नहीं हो रहा. उसमें वीडियो प्ले नहीं हो पा रहा है. इसमें वीडियो प्ले होगा. लैपटॉप से प्ले होगा. हाँ हाँ लैपटॉप लगा है. हाँ मूव कर रहा. ठीक. Okay. So, 65-year male presented with chest pain of 6-hour duration. He was hypertensive, non-diabetic, with topical chewing positive vital stable examination. ECG was finding of inferior MI with EO of 40%. After that, CAG was done, in which left system had only mild disease in the plaque in the LED, and mid circumflex had some 40 to 50% lesion. After that, the RCA was done, in which we can see the RCA has very tortuous course, and distal RCA was 100% occluded, and the proximal RCA was taking a upward bend followed by a downward bend, just like S-like configuration. So we can see the tortuosity of the RCA. So basically, this is a case of tortuous RCA between Shepherd's crook deformity, in which the variant where the proximal part of RCA takes a tortuous upward course resembling a Zephyr's crook. So we can see the proximal bend of the RCA and its tortuosity just resembling a Zephyr's crook deformity. So what's the plan for do a PCI in tortuous vessel? So we can do body wire technique. So it increases the support. We can use guide extension catheter to extend the guide catheter reach and provide additional support, especially in distal lesion. Increased guide backup can improve support with AL instead of JR. We can use macro catheter to increase forward wire possibility. We can use Cipri wire like Whisper and Pilot. We have to use low profile balloon. We should have good vessel preparation so stent and balloon can easily be deployed. And we have to use short, thin stud stents. So I used a Whisper wire. I just parked into distal RCA. And after that, I tried crossing the balloon. Balloon was not crossing. So I have to park the body wire in the mid RCA, but still it was not crossing. So I had to put the body wire into the distal RCA. After that, the balloon crossed and I did pre-dilatation. But we can see this after pre-dilatation, there was flow into the distal RCA, but the proximal, I think there was dissection or pseudo lesion or spasm, which will come later. So wire statting of the vessel can produce a pseudo lesion due to vessel spasm or dissection. So patient was having chest pain, so I gave the intracoronary vasodilator, but still the patient was having pain. So I had to put the stent because patient was having pain. So I took a short stent of 3 into 28 mm stent, and I just parked the stent into the mid RCA, mid to distal RCA, but the proximal part of stent was in the plug segment. So I just deployed the stent, and after the stent got deployed, there was completely no flow. So patient was having chest pain and BP just got dropped. So what are the differential for differential for acute vessel closure? So it might be due to spasm or I would do thrombus with distal embolization or dissection. So most probably it was a dissection as I just put another stent into the proximal part of RC. We can see there is some flow into the stent segment. So after that, as the patient was having pain, I had to deploy the stent, and after that we can see I stent deployed and there was a very good flow into the vessel and the tortuous vessel got straightened. So this was the case of Zephyr's crook RCA, primarily PCI. So what's the take-home message? So tortuous vessel PCI can be challenging and can be done with the help of body wire technique or guide extension, increased guide backup with AL catheter, macro catheter, or we have to use Cipri wire, or we have to short thin stud stent. And catheter induced spasm is basically more common in RCA ostium than the LC ostium. And we have to use less supportive strip wire if there is spasm. And we have to use vasodilator. We have to use vasodilator before we have to put the stent in the RCA. Or thank you. Any comment? Actual lesion was the actual lesion was in the distal RCA, but after
distal RCA, proximal part that lesion.
Distal RCA was 100% occluded. You can just bring the slide back.
No, there is no doubt for that distal part. I'm saying that initial proximal part that look like might be some consult in.
Tortuous lesions. Yeah, but patient was having pain, and I get the best.
No, because initially that angiographic images did not saw any lesion there.
Yeah.
After putting the wire, probably that might be concertina effect. It's always better to remove the wire and see what is there.
Yeah, but patient was having pain and there was no flow.
See, actually, the stent
part
which
of the
was
stent
deployed.
lodged into the plug segment. I think it got dissection, so I had to put another stent because
It not look like that. Probably 90% it look like concertina.
Okay.
Stent. First RCA is going up and coming down and tortuous. So when
And
you
we are
put a
making it
wire,
straight.
at that hard part of the wire has straightened it up, and that is
Definitely
causing
that is
concertina
concertina.
effect. That's what he's saying. So if you are sure that there is no lesion proximally, so quickly you stent distally and remove the wire. And once you
see what
remove the wire, the RCA will regain its shape and flow will
But
achieve.
there was no flow. So if I just removed the wire and I didn't get the access
No,
again, then
no flow is because because of wire. Wire is crushing and the vessel is like crushing on itself. So that's the causing, I think.
Okay. Yes. Okay. No.
If you do not want to lose the wire and to see whether it is concertina or not, another way is to just add a dock wire and put a microcatheter. The microcatheter is very soft, it does not lead to concertina. In that way, you can see whether it is concertina or not. If it is no concertina, then you can avoid the proximal stent. And the slow flow may be due to various reasons, maybe due to this concertina, or maybe due to some thrombus migration and all.
No, because the proximal part of the stent was lodged into the plaque
No, in
segment, and
primary,
it might
primary
got that.
PCI, we often land the stent, many a times we can land the stent in some plaquey region. That is not a big deal because you are not doing a routine interval. It is a primary PCI. So many times you can, we often put stent in a plaquey zone. That is not a big issue, I think.
These are the suggestions, but
Yes, sir.
But end result is good.
Yes, sir. Because yes, sir. Thanks.
Thank you to Amit Kumar for his very nice presentation in the primary PCI in case of the tortuous RCA, that is known as the Shepherd Crook or crowback appearance of the RCA. Now the next case presented by the Kamlesh Kumar
Take the first
with the
slide.
left main stenting in ACS in unstable angina patient.
Thank you. Good evening, teachers, everyone, colleagues. So I'll be presenting one case we did. Left main stenting in acute coronary syndrome. So it is like we can see is anterior wall MI. This patient is little old, like 76-year-old. And we did coronary angiogram for this patient. And we can see like left main distal is significant. Can you play it again? Yeah, just click. So fine, like this left main distal was like some 70-80%. With LAD mid lesion was also like some 70 to 80% lesion. And LCX also like prox to distal was like significant 80 to 90% lesion. RCA also like RCA coronary angiogram is not there, but RCA also like in the distal at the bifurcation was 80 to 90%. So seeing this all coronary anatomy, we referred this patient for bypass surgery only. But by the time I came back to the console room, patient started having angina. So like we then discussed the need for primary angioplasty. I mean like coronary angioplasty in this case. So what we did is like we put the wire in LAD first and we ballooned it first. So like our main purpose like was to go and do provisional stenting of LAD and left main, although lesion was like little long. So we tried to cover it. We thought of it covering it with 2 stents. So we ballooned it with 2 into 10 semi-compliant balloon. Then we thought like doing it and taking the stent towards the left main, then it will be difficult for us to take the stent into LCX. So after pre-dilatation of the LAD lesion, what we did is like we wired LCX when we thought of stenting LCX first. So we put the stent after pre-dilatation into LCX. The stent was 2.5 into 33. So getting desirable result, we thought of stenting left LAD, and then this is like left So then we took 2.75 stent, 2.75 into 30 stent into LED mid segment. And then we saw in between normal zone of LED, and we thought of not overlapping the stent. And we again took another stent of 3 into 18 into the LM LED zone. And we deployed it. We did NC with 3.58. And the result was like okay with slight pinching of LCX. And yeah, this was a straightforward case. Patient is doing well at 1 and 3 month follow-up. Thank you. Any question is welcome. Yeah.
You did NC 3.5 size
3.5
in
into
left
8.
main.
Left main, yeah.
Well, at least you have to do NC at least 4 mm.
I don't know, like we did not use imaging, so we don't know like whether it was 4 or it is 4.5 or 3.5. But what we did is like we went with 3.58 into higher pressure, like some 16, 18.
No,
Yeah,
if-
but agree,
looked
doing
like
it to
it's
4,
also-
I agree, it should have been done, yeah.
Yeah, Finet's law you have to follow. If you are not using IVUS for left main, if you are not having IVUS and you are doing a left main, so you have to follow the Finet's law. Left main in Indian population, it can't be below 4.5. We usually do it. It is used, the range is, it is between 4.5 to 5.5 adult
Fine.
patient. So at least you should have gone with a 4 mm balloon at high pressure. At least you should have achieved 4.25 because a 3.5 mm stent in a left main, it is a future problem.
Fine, sir, fine. But with this CNET law also, the vessel volume will come out of it 3 only. And we...
No. Angiographic view is misleading.
Circumflex we did with 2.5. LED we did with
be-
2.75.
It should be 2/3 of LED plus LCX diameter.
Okay.
See, OM is
It should be
2.5, the
2/3.
circumflex will be at least 2.75.
Fine, agree. I agree, like it should have been done with 4. Fine.
What should be next approach? Should he check the angiographically after 6 months?
Oh, actually, we called this patient after 1 month for the this thing for plasty of RCA. We did RCA, we did coronary angiogram. This was flowing vessel only. Ideally should have been done like that time we were not having imaging, so I thought of doing imaging in the next setting. Yeah.
For an IVUS, because IVUS can be available on the same day in
True,
Patna.
sir. True.
They have a console everywhere running at different centers. So second time an IVUS should have been taken.
Should have been done. Yes.
You have to give concession because you have put 4 stent.
Thank you.
Okay. Thank you.
So the next case is triple vessel stenting ACS patients in a peripheral hospital by Dr. Shaukat Ali.
Good evening, everyone. I'm going to present on a case of anastomia presented at my hospital with chest pain of 2 days. 65-year male presented with a chest pain from last 2 days, having heart rate of 78. Blood pressure was 108/64. Chest was clear, and there was no history of diabetes, hypertension, smoking, or alcohol. This was the ECG showing the hyperacute T waves in the chest leads. On echocardiography, it was found that the patient had EF of 40 to 45% with hypokinesia in basal and mid anterolateral and infralateral wall with low moderate MR. TROP-T was positive and serum creatinine was 1.4. Angiogram was done showing the proximal RCA approx 50 to 70% and distal RCA approx 90% stenosis. On left system, the D1 showing 90% stenosis, and LAD and LCX also having some stenosis. And angiogram showing that LCX having 95% stenosis. %95% and LAD having approx 95 to 99% stenosis. So I planned for, we have calculated syntax score for this patient, and on syntax scoring, we found that the syntax 2 scores showing CABG and PCI both option for the patient. After discussion with the patient relative, they opted for PCI because they don't want to take this patient to nearby hospital, which is at least 4 hours far from our Purnia district for CABG. And after expressing risk and benefit, because in my hospital there is no availability of OCT or IVUS, so I planned for the osteal LAD stenting and stenting of RCA and LCX. After explaining all the risk, I have wired the LAD, and after wiring pre-dilated with 2.5 to 8 balloon at approx 14 to 60 millimeter of pressure, the lesion was very fibrotic, and even after ballooning, the lesion showing severely narrowed segment. So after, and there is a mild plaquing in a distal leftment. After sharp positioning of the stent at the LAD ostium with the stent of 318 size, we have inflated at the LAD ostium. And there is even after stenting, there is some under expansion in the LAD ostial region. So I have post dilated with 3.58 balloon and showing good inflation. And this is the final result after post dilatation, which is showing normal flow of LCX, no pinching, and even ramus is good flowing. After that, I have taken pre-dilatation of LCX with 2.58 balloon. And stented with 315 Ultimaster Nagomi. And there is no need of post-stent. Vessel is flowing TIMI3 flow, and LAD is also having acceptable result. For the RCA segment, proximal RCA and distal RCA having proximal RCA having 50 to 70% and distal RCA having around 90%. So pre-dilated with 2:12 balloon. And after that, stented with 2.528 Ultimaster balloon. Ultimaster stent and showing TIMI3 flow. This is the final result. Thank you. Yes, sir.
I think in this case, it's better to first stent the LCX distal, then go for left main to stenting. Because it's such a fibrotic lesion in osteal lesion. I have one such case 1 year back. The stent tend to slip in left main also. So it's better to go for planned left main to stenting. Later on, previously we go for LCX stenting, then go. Second thing in osteal stenting also, if you do LCX later on, then there are times when this proximal stent can interfere with the stent passes into LCX. So it's better always to do L6 first, then go for LAD. Okay.
Yes, sir, you are right. Ideal, this vessel should be stented from left main to LAD because we had no backup of imaging. We could not decide. The vessel mismatch size is very severe because left main size is approximately twice as the size of LAD. So I have decided we have good space for the LCX. That's why we have planned for the LAD osteal stenting.
Actually, osteal stenting is a myth.
Yeah, it's
I would say.
myth.
Osteal stenting is a myth and a future burden too. And it is a future burden too.
I'm totally agree with you. ostial LAD stenting is a myth. We should always stent LAD to left main to LAD, but there is a risk of LCX pinching
I
and
personally imaged 5 consecutive back-to-back ostial stenting cases.
at peripheral hospital with
in that
triple vessel stenting, the dye load and ACS. These are the factors should also keep in mind for the stenting of the patient.
That's done. Actually, we have seen that the plaque is there. See, carina bifurcation is not a separate entity. It is a continuation of left main. Ostial LAD, basically it is a part of left main. So any disease in ostia of LAD, there will be disease in left main too. That's why ostia, we have to do a crossover. There is no question at all.
Yeah.
That-
Yeah.
That if you want ostial LAD stenting and you have the LCX, you can do the LCX lesion first. Because if any chance,
Because actually in ECG showing hyperacute T wave in chest slit V1 to V3. That's why I've understood that this could be due to the LAD lesion. So I have touched LAD first.
LAD is already good flowing, na? There is no flow compromise there. Second thing, one more thing I just want to add here. If there is no imaging, always do high pressure non-compliant balloon dilation. As you told, no need of any post
sir.
dilation, it should not be.
Yes, sir. I have inflated with 3.8 at the
No, not
23
LAD.
ATM pressure.
No, I'm not asking LAD.
Yeah.
For the circumflex and RCA also, because if there is imaging you can see, then you can leave, that is okay. But if we did not have the imaging, it's always advisable to do the high pressure non-compliant balloon, so that whatever the mal-apposition or non-apposition is there, because that will improve the long-term result. It's usual dictum. Nowadays, usually we are not leaving any stenting without high pressure non-compliant balloon dilation.
Sir, for left main,
No,
I think for left main imaging should be necessary because
No,
there is a severe mismatch between the LMCA and LAD.
No, I'm telling
Yes.
something different. I'm not telling that. I'm telling if you are just putting any stent, it's always better to do non-compliant balloon, high pressure,
Stenting is saying.
post dilation. That is
Okay.
necessary.
Yes, sir. Thank you.
For such tight ostial lesions, better to use cutting balloon upfront.
Yes, sir. Cutting balloon is a better option. Thank you.
Very well done case. Thank you. Next case, left main bifurcation by Dr. Gautam Kumar. Optimized by intracoronary imaging.
Good evening, everyone. It's my great pleasure being part of this event. First of all, I would like to thank organizing committee for giving me this opportunity. Respected chairpersons, all the dignitaries and my dear colleague. Today I'm going to present 1 or 2 cases which illustrates left main bifurcation, provisional stenting optimized with intracoronary imaging. This is the case detail. 42 years old female patient presented with non-STMI. Cardiovascular risk factor was diabetes and hypertension. Her clinical examination was unremarkable and she did have normal ejection fraction. Coronary angiography revealed distal left main 50% stenosis, and there is tight stenosis in the ostial LAD and mild plaquing in ostial left circumflex. In cranial projection, you can see dual LAD with mid LAD having 50% stenosis. So whenever you come across bifurcation lesion, 2 questions needs to be answered. Whether a side branch needs to be preserved. In our case, it is left circumflex, so definitely it needs to be preserved. And the second question is, what is the likelihood of side branch occlusion after main branch stenting? So this is a non-true simple bifurcation. And there is mild ostial disease. So the likelihood of losing side branch seems to be very low. And this is Medina 110 bifurcation, left-hand bifurcation lesion. So the plan is to do PCI of LMLED crossover stenting. It is provisional single stent strategy to begin with. And you know, ostial lesion is a different animal. So adequate plaque modification is must. So we will do adequate plaque modification. And lots of data are emerging that imaging reduces mass, reduces TLR, TVR. So imaging guided PCI optimization. So both LED and CIRC was wired with workhorse guide wire. And balloon angioplasty was done sequentially with semi-compliant 2.5 by 8 millimeter balloon. And after that, it was pre-dilated with angiosculpt 3.5 by 10 and then NC balloon of 3.5 by 10 up to 18 atmosphere. This is post-angioplasty result. Both LED and CIRC are flowing well with TIMI 3 flow. And IVUS run was taken. IVUS comes from LED to left pen. There is a mild disease distally, but there is significant disease in the ostial LED as well as in the distal left band. So 40 by 16 millimeter drug-eluting stent was placed across LM into LED, and subsequently it was deployed. And this is immediate post-deployment result. There is slight pinching of left circumflex. This is in cranial projection. And then proximal optimization was done, which is not seen here. Proximal optimization was done with non-compliant 4.5 by 8 NC balloon. Then rewiring of left circumflex was done through the distal struts. And then post-dilation was done with NC 40 by 8 balloon. So whether you can see there is a pinching of left circumflex. So the question is whether to treat it or not. So whenever you see ostial pinching of jailed vessel, so always do FFR. So pressure wire was placed into left circumflex and the FFR was 0.9. So it was decided to leave it alone. This is a paper which was published 20 years back by Ku et al. And it was seen that physiologic assessment of jailed side branch is very useful. And when the jailed side branch FFR is more than 0.75, there is essentially zero risk of TVR over the follow-up of 10 months. So it was decided to leave it alone. This is the final result. CIRC and LED is flowing well. And this is corneal projection. Then we did IVUS. IVUS run was taken. The stent is well expanded in the LED. There is no, or there is a virtually no malapposition, no stent edge dissection, and there is no any geographic miss. So in a couple of minutes, I will see you another case, 56 years old hypertensive diabetic female patient presented with ACS. Clinical examination was unremarkable. Again, it is Medina 110 bifurcation lesion. Again, LED LCX was wired and was pre-dilation was done with NC 3010 balloon. Stent was placed across LM into LED and subsequently it was deployed, jailing left circumflex artery. Then proximal optimization was done with NC balloon. And then rewiring was done through the distal struts. There is a question whether to wire distal or proximal. So if you are going to do provisional stenting, always rewire through the distal struts, because after balloon dilatation, the strut will scaffold the ostial left circumflex, and it will be easier to do mini crush or if it will convert into two stent strategy. Then final kissing was done with 3.5 by 12 NC balloon to LED and 2.75 by 12 NC balloon to left circumflex. Then it was repotted. This is the final result. And IVUS run was taken from, it is coming back from LAD to left hand. The stent is well expanded, it is not seen yet. And in conclusion, provisional stenting is preferred bifurcation stenting because in major recently done trial, EBC main and DK Cross 5 trial, it was seen that provisional stenting is better than two stent strategy if you are doing simple non-true bifurcation. Jailing side branch wire improves safety. Proximal optimization is recommended before side branch rewiring because it will prevent from abluminal wiring of left main and it will facilitate into the side branch wiring. And functional assessment of jailed side branch lesions can guide need for additional treatment. Thank you.
Yeah, Gautam, Dr. Gautam, please. I have a few points on technicality because your planning was absolutely fine. Your theoretical things was absolutely good. But coming to technicality, why in first case, why there was pinching of LCX?
It was maybe due to Carina suit because I have taken
No, not that one.
optimization.
You have not seen the IVUS properly because the size of a stent was a bit larger. You have chosen 4 mm diameter of a stent. And always choose stents on the reference of distal vessel, not on the targeting your left main. First. And second thing, you have used a bit larger balloon for post dilatation. I think length of 6 mm could have been better for that.
What was inappropriate actually? It crossed
What
the-
was inappropriate?
Good cases, Dr. Gautam, but as seen, your quad balloon was crossing the carina.
Yeah.
That was the reason because it should
At
never
that time,
cross.
we didn't have 6 mm balloon. That's why I
Yeah,
used that.
so maybe, or actually.
It should be at the carina. The distal marker should be at the carina.
Spare the carina. Carina
It
means.
should not be beyond carina. It will cause.
Right, yeah.
It will cause carina shift.
Be touched.
That's why we did the FFR.
Yeah.
To rule out in the functional physiology or hemodynamic significance of the lesion.
So whenever planning bifurcation, we should leave enough length of the stent in the main branch according to
Sure.
whatever balloon length we have on the shelf,
Sure.
in case we don't have short balloon. So there's no harm in stenting up to the ostium of the left main just to make a good pot.
Yeah.
Number two, when you did IVUS, did you also interrogate the mid-LAD lesion, which was appearing like something 50%, which was just after the diagonal? Was that also interrogated by IVUS? Or IVUS was limited only to the left? main?
Only to the left. LAD left main.
Okay, so retrospectively, do you think that that could have probably given you better insight? Because sometimes lesions don't appear significant angiographically, but when we do
But
IVUS or FFR, so we do realize that these, and especially when you have done a bifurcation case. So I think that could have helped. And then, as Dr. Ashok said, that you had IVUS on the table, you used also. So another run from LCX to LM might have given you better insight in actually what happened at LCX ostium. But definitely because your FFR was negative for the LCX, so physiologically it was definitely a very good result.
Thank you.
Next case will be by Dr. Girja Shankar Jha, senior cardiologist at Ninti Cardiac Care, Saharsa. He will be speaking on left main angioplasty.
Good evening, my seniors, my respected seniors, and thank you for the organizing committee to give me the opportunity to speak over here. So left main PCI remain a challenge for all the intervention cardiologists because it is always a high-risk procedures because of patient comorbidities, hemodynamic compromise, and complex coronary artery disease. So the side branch should also be preserved So it's always become problem when the ejection fraction is less than 35% and there is hemodynamic instability, accompanied by diabetes, heart failure, and increasing age. So favors CABG is low ejection fraction, diabetes, high syntax score, distal bifurcation left main disease, severe calcification and tortuosity, and need for long stent and multiple diffuse disease, particularly in diabetes people with high expectancy score. So patient with CABG PCI can be done in patient with life expectancy less than 5 years, high surgical risk, frailty, prior CABG, advanced age, and important comorbidities. So post-Excel, these are the criteria, 5, 6, 7, 8 were the earlier criteria. Post-Excel, they have increased the lumen area by 6, 8, 10. And then we always know when you have in periphery, you don't have the backup of IVS, you should always use the Finite law or Muller law, where you can see the mother vessel size to be size of daughter vessels multiplied by 0.6. So you can add the daughter vessel, multiply it by 2 and divide by 3 to get the proper size of mother vessels. If it is a triple vessels, then you should multiply it by 0.577 for mother vessels diameter. I don't have that liberty over there, privilege over here. Hopefully this year I will get IVS and ROTA over there to do the procedures. If FFR lumen area by IVS is less than 4.5, we should revascularize left main. So I will directly come to my case. My case, how to play? How to play this? Extremely sorry for disclosing the name here. I have made cut over there. Please don't see it. So this was the distal left main. Patient had a increasing ST elevation MI. Non-ST elevation MI, it was ongoing chest pain. So patient was given option to go to Patna for bypass surgery, which he refused. So it was a Medina 111 disease. So after explaining the patients, it was 49-year young male. So I did predilation in both the vessels and then also the pot. And then I have done pot, and then I have pre-dilated both the lesion. After that, I have deployed LCX stent, crushed it with mini crushed with a balloon, and then I have deployed a stent from left main to LED. And after that, I have recrossed both the lesions. I have recrossed the lesion. I have done the simultaneous kissing for both the vessels, and I have after the stenting there was some distal blockage where I have deployed another stent. I have done the pot, and after the pot I have done the kissing, and it was a good result. So here I have used 4 into I don't remember the size, but it was 428, and then post-dilated pot with 4.5 balloon. I have done this with 4.5, simultaneous kissing, and then pot with 4.5. So it was recross and then simultaneous kissing. Then final pot was also done in this patient. Patient is doing well and is in close follow-up of mine. So I will show another patient. So this was the final result. I am showing another patient who was 76-year male, and it was again Medina 111 blockage. severe stenosis. After again, patient was told to go to Patna for bypass surgery, which they refused. And again, I have to recross LAD and LCX both. I have pre-dilated both the lesion. There was very severe calcification in the LAD artery. I was very much saddened that I did not have rota over there. I had done a cutting balloon, and then I have prepared the lesion bed properly. And after that, I have deployed the stent in LAD and LCX both. I have pre-dilated the lesion. This was in LAD, and then I have done a from left main to LAD again. Another stent was deployed. There was 2 stents deployed in LAD, and after this, a pot was done. In this, I did not probably I didn't touch the L6 in this patient, and the patient was done provisional stenting only in this. This was another patient who presented with ACS, and there was a simple obtuse angle in which I did mini-clot stenting. And this, I was not having the pictures seen over here. This was another patient. Here again, it is Medina 1-1 classification blockage. Here again, I have done pre-dilation of both the lesion. And here, first stent was deployed in LCX. It was crushed with a main balloon in left main, and then stent was deployed from left main to LAD to LCX. It was then pre-dilated, left main to LAD stent was pre-dilated, and pot was done. There was some residual stenosis in this patient because probably calcium was there. Although cutting balloon was used to prepare the lesion. This was in the last case. I had presented earlier also this patient who presented with acute MI, ST elevation MI, in which I have done just provisional stenting only in this patient, and I pre-dilated LCX, and I have done left main to LAD. Main thing is that if patient present with acute MI, and there you have to do intervention with left main to LAD, and patient in cardiogenic shock, beside doing immediate stenting, you should also do you should check the acidosis, and you should correct the acidosis also, and hit hard acidosis before true acidosis set in, because once the acidosis set in, it's very difficult to survive the patient. Who actually this patient survived and is doing good, and still is in my follow-up. So.
Yeah, Dr. Grija, I think your time is over now. And one thing I would like to say, in your center, I am seeing so many of left man bifurcation is coming. So my suggestion is just have imaging.
Not only that, if you are anywhere presenting in the forum, it's always should be presented in a CDN, just like proper format, not like recorded in mobile. Even if you cannot able to do, someone else can easily do for you, because it's looking, you are very busy, no one, that is not looking good. This is not the way.
Okay. Thank you.
Thank you.
Okay, thanks.
Yes.
Last but not the least, Dr. Ashish Ranjan will present his case on left main disease and LAD CTO.
Respected chairperson and senior who has given me the opportunity to present this case. This 62-year-old male presented with worsening ongoing accelerated angina with an STMI for last 12 hours. TROP-T was strongly positive. Echo So multi-territory hypokinesia with preserved thickness of EF 35%, one episode of VT in emergency, which was DC-verted. Past history, he has an infralateral STI in 2020. He was post-stated primary PCI to LCX done. That time, LAD to so lesion was there in LAD, but he was not willing for the stage PCI to LAD, and he lost follow-up after 2022. This is the post PCI 2020. You can see this LAD proximal mid junction 80 to 90% stenosis. But here in the present, so patient, sorry. Back. This so this not work like second. ये नहीं play हो रहा. So the present SI, so patent stent in LCX. ये अपने चल रहा है. So patent stent in LCX क्या हो सकता है क्या? नहीं तीसरा होगा. So that is so patent stent in LCX with distal left main 90 to 95% stenosis with LAD CTO feeling retrogradely from the RCA. He was taken for that time. He was what to do? He should be sent to CABG or we should do the primary. And that time and we have to relieve the chest pain. Then we have, after discussing with bystander, they were not willing for that CABG. Though that time we were taken for the revascularization in view of refractory chest pain. This is the that time LAD we have to that time we also do the LAD CTO mapping, which was feeling retrograde by simultaneous injection RCA. J CTO score was 2, length was 20, more than 20, and angle was 45. In that, when we taken the patient, our first priority to somehow this lone flowing vessel LCX, our first priority was there. So we done the LCX pre-dilatation with 3 mm NC balloon, followed by 3.5 into 10 mm Wolverine cutting balloon. After that, there was good flow, chest pain also some decreased. After that, our aim was to how to cross the LAD. LAD CTO and LAD D1 level, so D1 wired also wired to get the extra support. Then we use the fine cross, but soon we have to change to the Crusade double lumen catheter wire escalated from Whisper extra support to Gaia next to proximal cap caused with some difficulty. After that, wire repeatedly entering into the septal branch and microcatheter not crossing the proximal cap. LAD, we use the 90 angle microcatheter used to cross deep into the septal branch to main LAD carefully with the support of anchoring balloon into the 2 mm NC into the LCX stand. So we get more support, and at distal cap we cross slowly we cross the distal cap as we crossed to the D2. Then Gaia wire was removed and filter XT was used with extra curve to enter the LAD. LAD, we exchange the LAD wire exchange with simple workhorse wire. LAD then serially dilated with Riori 1 mm into 10 and 1.5 mm, 2 mm finally with 2.5 mm NC balloon, and distal LAD was stented with 3.5 into 38 mm synergy DES drug-eluting stent, and from LM to LAD overlapping with distal stent to Megatron 4 into 32 drug-eluting stent. Distal LAD was post-dilated with 3.5 NC, and LM part was dilated with 4.5 mm and into 8 NC balloon. Then we done the simultaneous with the drug-coated balloon. Left main into LCX crossed with workhorse wire, stent strut expanded with 2 mm NC balloon, simultaneous kissing balloon done with 3 into 12 NC balloon done with the 3 into 12 mm NC balloon from left main to LAD and 3.5 mm into the 15 mm coated balloon from LM to LCX at nominal pressure for 30 seconds twice. We done the pot with the 11 stent done with 4.6 into 10 6 mm NC balloon. This is not working. So this is the final result. Final result take home is be prepared to take emergency cases as surgeon rarely accept such cases. Tackling lone for flowing vessel is the most important step in managing such cases. Double lumen catheter, 90-degree microcatheter are vital tool in negotiating CTO at bifurcation. Anchoring balloon can give you extra support, and drug-coated balloon are nowadays used even in proximal bifurcation with good result and possibly better long-time outcome. So patient is doing well. Thank you.
That was great case. Congratulations,
Uh,
Dr. Ashish. But one thing can I ask, because for
In that-
drug-eluting balloons, we have to keep them inflated for 60 minutes so that the entire drug goes into the wall. But for left main, although cases are being done, but is it really safe to keep it inflated? And also in a situation where there is a kissing balloon positioned there. So that itself
That
will
time,
cause,
this is the 30-second we use.
but a recommendation
Two
is
times we
60.
have rated. We are seeing the pressure also.
Yeah, but also, do you think now retrospectively, although that time you did whatever you felt was best, and then you got a very good result also. So retrospectively, do you think that it would have been better to inflate circumflex to LM with DEB alone, doing it for maximum time, whatever patient could tolerate, so that drug could
Yes.
easily disseminate into the wall, then do KPI?
That
But then these things it's
that
easy
time-
to say now, but I can understand your anxiety levels when you were treating the patient. That was a very critical patient. Did the patient tolerate ischemic time, or did the patient develop any severe ischemia, chest pain when
That time after this Wolverine cutting, he was very much
became stable?
stable now.
Symptoms subsided.
Subsided.
Great. So all cases in this session were very good cases. And it is really, really courageous to, yeah, I'll come to you. It is really courageous to do very, very complex cases in periphery, especially places like Sirsa with no surgical backup. So congratulations to all of you. And before we end, there is one question from Dr. Shamshad.
Actually, the execution was almost near perfect. 2 points, we can improvise this. First thing, when we use the anchor balloon was in LCX, so 2 mm anchor balloon will not do the job. Basically, that your crusade catheter it help it in crossing the lesion. The second thing, when we use the DCB of 3.5, so before deploying a DCB, we have to prepare the vessel with the same size of DCB. If you are going to use a 3.5 mm DCB, then we have to prepare with a 3.5 mm NC.
3.5 mm Wolverine cutting balloon was used to dilate LCX. It was initially dilated with 3 mm NC balloon, left main to LCX, and then 3.5 mm Wolverine cutting balloon was taken to dilate it.
No, actually, we have crossed the strut. We did a kissing with a 3. So we have to open the strut for a 3.5 DCB to inflate it adequately. That's why, because we have to deploy the drug at the ostia of the LCX also.
Yeah, we have
So we
already
have to
crossed
prepare-
and then we dilated the strut of the stent, and then it doesn't lead to, if we have dilated it well, then the drug deposition is well. But if you have not dilated it, then drug wastage might be there while crossing the strut of the stent. So if you dilate the strut well, then it won't be a problem.
Thank you, chairpersons.
Now close the session.
जाइएगा कोई नहीं. मोस्ट इम्पोर्टेंट सेशन तो अब शुरू होगा. हमारे जो सबसे एनर्जेटिक डायनामिक ऑर्गेनाइजिंग सेक्रेटरी हैं डॉक्टर आशीष कुमार झा। आप देख रहे होंगे इन्होंने कितना वंडरफुल प्रोग्राम ऑर्गेनाइज किया है। मैं अपनी तरफ से तो इनको कॉन्ग्रेचुलेशंस एंड थैंक्स देता हूं, बट वोट ऑफ थैंक्स देने का अधिकार इन्हीं का है। आई इनवाइट डॉक्टर आशीष कुमार झा फॉर द वोट ऑफ थैंक्स, एंड देन आई विल इनवाइट you people, if you want to say something about this conference, its success, कहीं कुछ गड़बड़ियां हैं, कुछ डिमेरिट्स हैं, खुल के बताइए। पेरीफेरी से जितने भी हमारे कॉलीग आए हैं, मैं उनसे जरूर रिक्वेस्ट करूंगा आप अपना एक्सपीरियंस आकर यहाँ एक एक मिनट बताएं, हाँ, सो दैट कि हम लोग नेक्स्ट ईयर इसको और अच्छे से कर पाए, अच्छे से कर पाए। आशीष प्लीज।
Yeah, thanks to all of you. It was all of you who made this program a great success. I already told this, and I would like to have your opinion how we can improve it, so that the day this NIC will, this BIC will be like India Live or NIC, when the cases will have to choose cases from multiple cases, then I will be one of the happiest persons, and I think that that day will be more successful. So I would like to have opinion for further improvisation from any one of you, if you like.
Dr. Roshan.
John Roshan sir is there, and I would like to have his opinion. He has come.
Only one guest speaker is still sitting here. So, thank you, sir.
Sir, please
Thank
come
you.
here.
Thank you to the organizing committee. I think it is not easy to arrange a meeting like this. So the well-mannered way and fashion in which it has been conducted, I think is excellent. And also the choice of speakers also, I think, was very good, because all the people who gave their talks had really researched what they were speaking on and spoke appropriately. The other big credit to the whole meeting is the people who are attending the meeting. And I can tell you for sure that similar meetings don't have this kind of attendance where people are sitting, listening, even sitting in the valedictory function to listen. So that's, I think, a big plus to the cardiologists of Bihar. We should always look at how we can improve. And I think from perspective of improving, we can look at making the program a little bit more bigger and have more focused areas being discussed, and maybe have some more faculty coming in from other states who have more experience, so that you can learn from whatever mistakes that they have made and not avoid making the same mistakes that others have made. But overall, I think it's a great meeting. I think the organizing committee has done a great thing, and for me, it's a matter of great pride to see Ashish in this great role that he has done, and kudos to him and Arvind sir and all the others from the organizing team to have done this great job. Thank you.
Thank you, sir. Please just stay back. At the end, we will have a group photograph. So please just stay. JP Karan साहब आइए. कुछ बोलिए. Yes, Vineet. यहाँ आके बताओ. Yes. Your feedback is very important.
The initial first session, we all are usually telling ki discussion will be at the last, let finish the all part. Main thing, after all cases, we are usually not remembering what we have to ask. So it's always better to discuss after one cases only, so that some more time for discussion will be more fruitful, because only listening all are just like sleeping. If we are discussing something, that will give some energy to everyone, and all are usually awake. No one is sleeping like that. So this is my suggestion. If we have some more time for discussion after each cases only, that will definitely give us some more better way to understand. That is my opinion, I think.
Pramit from Gaya, please come. Dr. Adit Bhaskar. JP sir आइए. Jishan Ali, Shaukat Ali साहब आइए.
Very good organized conference. Kudos to Dr. Ashish Jha and Arvind sir for this. Nothing much to improve. But one thing, we can include some live in box cases also. 1 or 2 live in box cases. And second thing, people from outside the state should be included in the first half, middle half, and in later half, we should all from this state of the Bihar. This is my, all the very good organized conference. Thank you very much.
Yeah, it was very nice session, and every session was very fruitful, and we a lot from this session. We should continue this next year. Thank you.
Yeah, actually, it was a wonderful conference, and I attended BIC 1. That time there was thin attendance. Now the curve of BIC is actually very steep. I don't think we need to do anything extra next from the BIC 4. I think it will require a full 2-day. And among my colleagues, 2-3 colleagues from Northeast, they have done MBBS from Bihar. They were really very interested to come to Patna for this BIC. So I don't think in the way we are going, it will need a full 2-day session for BIC. Thank you. Thank you for inviting, and I requested Shamsad today also that don't forget to invite me also next time. Thank you.
Very nicely organized conference, Ashish. The first 2 editions, I was very involved in the conference, but this time I was helping him from behind, but not very actively involved, but very nicely organized. And Arvind sir is always a pillar. And I remember from 2015, when we organized Cardicon conference of a CSI annual conference. And I was always trying to put an interventional program in that. And then sir gave me 1 hour in Cardicon. So from 2015 till 2 years back, I was given 1 hour time every year for organizing that intervention sessions. So I have started intervention CD presentation session from 2015. And we always tried to organize a separate interventional cardiology conference so that we can discuss among ourselves and learn from each other. So 2 years back, we have started it, and now it has progressed. Only thing is, I think we need more time to discuss, and we need more time for our master faculty to express themselves, little more time. So I think we have to keep it like 1.5 day or 2-day program from next year onwards, because you always feel 15 minutes is less, and we don't get more time for discussing or asking questions. Thank you.
Last year,
My hearty congratulations to the organizing team. It was a wonderful program. And actually, when I compare it to the national conferences, NIC and India Live, I strongly feel that this pattern is much better than that. Or maybe we should have different spectrum of conferences. So this type of meeting where the focus is on different variety of cases where youngsters, seniors, and others, they have their own experiences, the way they addressed particular problems. That discussion is much more fruitful than somebody coming and taking data from all the journals and presenting. That is maybe that is not as interesting as this conference was. So the selection of cases, allocation of time to discussion of cases was really very good. And I think same pattern should be followed. And probably some compromise was there in the discussion after each case, but after all, there has to be a limit. So beyond which it cannot be done. Definitely it should be extended. But truly, again, congratulations to all of you, especially Dr. Ashish.
सब कर देते हैं बॉस, अभी ही कर देते हैं सब. Actually, this was brainchild of Arvind sir and Dr. Vipin. They started BIC and this is the 3rd year. BIC is going great. But next BIC, I think going to done by, you are going to possibly. So I have 1 or 2 suggestions. because we are doing great cases, even in periphery, peoples are doing very good. My suggestion number one is to summarize, and faculty, we can limit the faculty lecture one in each session, and we can start a prize for best cases. So 1, 2, 3 we can do, and one request to the presenters, they try to show one case with full discussion, and that's why if there is time allotted for 6 minutes, we can summarize cases in 4 minutes and take another 3 to 4 minutes for discussion. That will be more fruitful. And one announcement from my side, I'm going to organize CADICON, and most probably in the month of September 2021, you all are requested to join very actively, and you have to do one more thing. In coming week, I will call you, most of you people, and I will give a assignment, because my thought is to publish update, cardiology update. So you have to take care, and you have to write one chapter at least. I will come to you. So everybody is invited in CardiCon 2025 in the month of September. Most probably date will be 21st of September. Thank you.
So it was long back in 2019 when I passed out from KGMC. I joined Ruben. I was in the cath lab and I just said, boss, हम लोग का मिड टर्म इंटरवेंशन मीट नहीं होता, यूपी में तो हर साल होता है. So that thing then started. Then we planned that our numbers are increasing, then we will organize. And it started with nearly almost 24, 26 cases in first, and today it was 48. So it started with 24, 25, and it ended at 48 today. That's why we need either 2 halls in the next meet or 1.5 day complete. And what Ashok boss had said, we have to decrease the number of lectures so that the discussion time is there for every one of us. And what Ashish boss has said, that we will be more than happy if we will have to select the cases. So from next year, possibly we will get that opportunity to select the cases, because we have 40 or 45 total number of lectures, and I hope we will be able to get around 80-90 cases. Case submissions for this conference. So, and second thing, everyone, for everyone, it's a take-home message that there is never a criticism in these kind of conferences, and there is never a kind of leg pulling. Whatever discussions are made, these are made. Somebody has its personal experience, somebody follows the guidelines. So any comment not has to be taken personally. Everybody wants to improvise any kind of thing, what he thinks can be improved. So it's a healthy discussion, and we learn a lot whenever we attend these kind of conferences. Even when if anybody attends, most of us attend NIC. So nightmare session, whenever it's presented in NIC, there is lot of discussions. At times, people fight together. The discussants often fight together. So it is not a grudge what people have in themselves. They have to get more and more knowledge. That's why they attend, and they just discuss with themselves. So it was such a nice meeting, and full house up till 8 p.m. We never expected when we were organizing BIC 1. Thank you.
Now, our secretary, Upendra Narayan, CSI Bihar Chapter Secretary, wants to say something. Few words.
A very good evening to all of you. It is very heartening to see you all. You are all, many persons are sitting at the 8 p.m. and have a great day today. And in the capacity of Secretary Bihar Chapter, I would like to thank all the senior members, senior colleagues, and especially youngsters who participated in a big way. We see our number of interventional cardiologists have grown up, and as a complex intervention has also grown up and picked up. We are all doing in all type of interventions. We have just seen complicated left main, bifurcation, CTO, different type of complication we have handled in a very nice way. This is very great. And this is the third edition of our BIC conference. And in the next year, we will see even the number will increase. And now standard has even grown. And also thank you to all the colleagues and members of from the pharmaceuticals and all those who are the part of the conference and make this our event a great success. Thank you once again. Thank you.
Now, this is the second part of vote of thanks. Sorry, we have left some persons, so I'm extremely
I
apologize.
would like to thank the press media for their support and extensive coverage. And pharmaceutical industry, the device companies, it has all happened because of your gracious support. Otherwise, it would not have happened. I would like to thank the Hotel Moria staff. They have worked. There was a marriage ceremony which ended at, I think, at 2 or 3 a.m. And they just prepared the dice and everything. And they were awake all night. So thank you. And special thanks to Sanjeev sir for mastering the inauguration thing. Special many thanks to Dravesh ji. He has always been a pillar of strength for all the conferences he has been organizing, and he's doing a fantabulous job. And thanks to, and last but not the least, I think most, Arvind sir. He's always there. Thank you, sir, for your means you have energy. I can't describe how much energy you have. You are a great person, supporting everyone's, supporting youngsters to do better and better job. Thank you, sir.
Now, it's my desire to have a group photograph. Before we leave for the dinner, please come join for a group. This will be a memorable photograph for us. हम लोग 2 रो में खड़े हो जाएं, स्टेज पर और थोड़ा नीचे. आपके बगल में खड़ा हूं. चलिए. आ गया. Please, dinner is ready. You must enjoy your dinner. Sorry, म्यूजिक का प्रोग्राम नहीं रखा गया है, लेकिन एक लाइन तो मैं कहूंगा कि चलते चलते मेरे ये गीत याद रखना, कभी अलविदा ना कहना. फार्मा इंडस्ट्री एंड डिवाइस कंपनी जी.
Dinner for everyone.
ये आशीष जी बोलेंगे ज्यादा अच्छा रहेगा.
No, I invite you, all of you, for dinner here, and one device company and pharmaceutical industry. Please have a group photo.
Yes,
please come.
इसी तरह 2 रो में हो जाइए.